Hello, everyone, and welcome back. Welcome to day 2 of the 3rd Annual Summit on Global Innovations in Patient-Centered Care. Thank you to everyone who attended day 1. Leadership at AAKP, again, we have to thank our staff, led by Executive Director Diana Kleins and assisted by Erin Kale, Director of Stakeholder Operations. Let's have a quick recap of yesterday. Yesterday, we heard from Dr. Murray Sheldon from AAK Strategic Partner, the FDA, who has joined AAKP in a push for a global patient consortium to make artificial organs a reality for many facing kidney disease. Global allies and partners and kidney patients from the Netherlands, from the European Union, from Ireland and Argentina shared how a global patient consortium can help accelerate innovation and benefit patient consumers in their respective countries. We also heard from industry partners on the impact of COVID-19, the impact that it has had on and continues to have on vulnerable populations, and the implications for future kidney patients with acute kidney care. AAKP is here today, again, with our co-host, the George Washington University School of Medicine and Health Sciences. And we're going to continue on with our agenda about kidney patients and innovations. And yes, folks, today we have another full agenda. We're going to hear from industry partners that are leading the way in including individuals with rare and genetic conditions in clinical trials, preemptive treatments for diabetic kidney disease, innovations in home dialysis and post-transplant care, precision medicine for kidney patients and artificial organs, and much, much more. But again, I want to thank our sponsors, Travere Therapeutics and Horizon Therapeutics, our gold sponsors, CareDx, our silver sponsor, Hansa Biopharma and Sanofi Genzyme, our patron sponsors, and of course, AstraZeneca and Eurofins Transplant Genomics are our supporting sponsors. And we really appreciate their support of this 3rd Annual Global Summit. In closing, I want to refer to and share a few words from my Juneteenth message that I think are appropriate as we listen to the proceedings of the day. As a kidney community, we should take heart knowing that, united together in purpose, we have shared intelligence and capacities that can drive many innovations and save many more lives. But in order to do this, we need thoughtful, patient engagement, which means the inclusion of even more minorities in research, clinical trials, and disease prevention and treatment education. Most importantly, we must be united in our resolve to end disparate care and to expand care choices to all kidney patients, because every kidney patient has the right to pursue their dreams and life goals. AAKP is 100% committed to the principles outlined in the 2019 bipartisan executive order. Principles such as choice, competition, innovation, upstream diagnosis, and artificial organs. Stay tuned for coming announcements that will better enable you to be involved in research, clinical trials, and advocacy. Again, I want to thank you for joining us today. Now, I will turn the program over to the moderator for our first session, Jennifer Jones. Ms. Jones, you're up.
Thank you for joining us for the 3rd Annual Global Summit, Global Kidney Innovations, Expanding Patient Choices and Outcomes, a collaborative partnership event presented by the American Association of Kidney Patients and the George Washington University School of Medicine and Health Sciences. My name is Jennifer Jones, and I am an AAKP Board of Director, Executive Committee member, and ambassador. I'm also a resilience coach, speaker, and a retired Marine Corps veteran. 10 years ago, I was diagnosed with membranous proliferative glomerulonephritis type 1 idiopathic after exhibiting symptoms of acute kidney injury, or AKI, while deployed to Afghanistan. Throughout my journey, I have experienced AKI numerous times due to this disease. In fact, this January, I returned to peritoneal dialysis after having 5 years with a kidney transplant. if it weren't for the nephrology team of Walter Reed National Military Medical Center, I may not be here today, and that weighs heavily on me. However, I am hopeful that one day the focus of my treatment will change from mitigating disease to preventative medicine and modalities. As health consumers and the center of patient-centered care, it is crucial that we provide input and gain access to new kidney care innovations. Being part of AAKP allows me access to the education and resources I need to not only improve my quality of life as a patient, but also the platform to use my voice and my experiences in a meaningful way to demand more innovation and more choices for myself and others diagnosed with chronic kidney disease. As an AAKP member, you can do the same. It is critical now that we as patient consumers raise our voices and create demand for new diagnostics, devices, and biologics in our independent countries. By cultivating a united patient consortium, that demand can be supported globally for patients in countries where healthcare systems and/or infrastructure may not support patient consumer choice and/or access to care and treatments. Today, I am pleased to introduce friend and ally of AAKP, Dr. Rajit Basu, Associate Professor of Pediatrics at Emory School of Medicine. Dr. Basu is Research Director of the Division of Pediatric Care Medicine at Children's Healthcare of Atlanta, and he serves as a steering committee member for the No AKI campaign, a BioMareau-supported global campaign. For our session on Evolving Science, Implications of Acute Kidney Injury on Long-Term Kidney Health. Dr. Basu, you may start your presentation.
Hi, my name is Raj Basu. Thank you for joining this global summit. I'm excited to talk to you today about acute kidney injury, and specifically about the assessment of AKI knowledge in a study that we did and the data that we have, looking for educational opportunities as we move forward to help diagnose and manage acute kidney injury in critically ill patients. I have a couple disclosures to make sure I tell you about. The most important is that some of the work I'm going to be discussing was just recently completed. It's not yet published, but it was supported by the Ipsos data management company and also bioMérieux that is involved in the AKI space. And I get there's no royalty or anything with this data. It's really just me. I do consulting for acute kidney injury. So over the past decade, we've really made a case for the idea that acute kidney injury is important. We have data set after data set that shows, as I'm about to, that there's increased morbidity and mortality independently associated with AKI. We also know that AKI independently adds up to costs that are exorbitant in hospitalized patients, almost to the tune of $10 billion per year in the US alone. We know that acute kidney injury increases your length of stay by almost 3 to 4 days. We know that hundreds of thousands of people die every year with acute kidney injury. What we don't really know is what we can do about it. Recently, there have been a number of movements trying to get more people aware of both the problem of AKI, what we can do to recognize AKI, how we can manage AKI. And the American Society of Nephrology put together what they call a toolkit, or a series of interventions geared toward the idea of improving awareness, recognition, and management of AKI, improving education, generating guidance on AKI evaluation and management, developing a toolkit, engaging hospital administration, and raising awareness of the fact that AKI leads to complications not just in the short term, but also in the long term. More recently, I think we have all been hit in the face pretty much with COVID-19, and in the world of critical care nephrology, we know very well that acute kidney injury in the setting of COVID-19 makes all the outcomes worse. Even though we've gone through a series of learnings in our first wave, second wave, of third wave, whether you're in the Western Hemisphere, in the Eastern Hemisphere, in the Northern Hemisphere, in the Southern Hemisphere, what we know is that acute kidney injury in the context of COVID is worse for you. Not only in the short term, as morbidity and mortality go up in those patients who have some form of AKI, but also with relation to progression to chronic kidney disease. If we just take a step back and look at the data across populations, these are the big 4 studies across neonatal, pediatric, young adult, middle-aged adult, older age adult, across the globe studying the incidence and prevalence of acute kidney injury and patient outcome. And quite startlingly, almost all the data is almost the same. 1 in 4 acutely ill patients, regardless of age, regardless of severity of illness, have some form of AKI. And there's an independent association with AKI and poor outcome, a dose response, so to speak, that more AKI is associated with more death. And we just know that in our world of critical care nephrology, this data is loud, it's strong, and it's powerful, and it's repetitive. We have more and more data that shows us almost the same thing. What we also know is we're limited by our tools at our fingertips. If you look at the diagnostic things that we have, whether they be creatinine as our major diagnostic variable, urine output, glomerular filtration rate, either directly measured or indirectly measured, we know that there's quite a bit of variability with muscle mass, volume contraction, fluid state. This is made worse in patients who are acutely ill, which is most people who have these things measured, in pediatric patients who don't have a baseline, and in neonates who hardly have anything measured. So what we're dealing with is a black box of diagnostics, of understanding what the disease is for disease that causes a lot of problems. But what we need to understand is what we don't know. We think we know quite a bit, but what we are missing is the idea that we can't tell what non-nephrologists, non-intensivists know or don't know about AKI, because we would think that potentially there's a knowledge gap. So there is a big possibility here. If we could really understand gaps of knowledge for people who are, quote, not the bully pulpit, not the choir, we're not preaching to the same people we preach to. People who are not intensivists, not nephrologists, about the data I just showed you about the problems with AKI. It may identify new opportunities to raise awareness in the hospitals and beyond, because as you know, many people in the hospitals are varied degrees of discipline of different medical subspecialties and also walks of life. Improved awareness may be crucial to what we as critical care nephrologists believe to be true. Considering AKI as a problem, recognizing that it's either subtly happening or in your face, prophylaxing and preparing against AKI, mitigating the effects, and managing AKI. It allows us to be more proactive than reactive. So what we conducted in the fall months was a study across Western Europe and US looking at healthcare providers and what we considered AKI awareness. Again, this study was supported by the Ipsos group and by bioMérieux. So what we did was a survey-driven study of healthcare providers across 3 paradigms, what we called AKI impact, knowledge of acute and chronic associations with AKI, familiarity with AKI itself. What is the current status quo for diagnostics, what people do management, what they believe to be true. And then the third, which is what could be true. What are people interested in? We studied these 3 paradigms in unison. So we looked at about 1,000 practitioners from the US and Western European countries, as you see here. They were divided amongst intensivists and nephrologists that we thought would be positive controls, people who knew all about AKI, emergency room physicians, cardiologists, and then your ward physicians, the hospitalists and internal medicine docs who manage patients for all across the board for different things. All 5 of these groups of physicians all deal with acute kidney injury to some shape or form. We had screening criteria that mandated that they worked a certain period of time in the hospital and a certain qualification level and be involved in decision making. And again, the study was conducted in the fall months of 2020, and it was a simple 15-minute online interview of people that had already signed up to be part of a survey kind of driven study site. And this is what we found. Of all the people that we surveyed, the hospital size was quite varied, but most people worked at hospitals that were notable, above 100, 200 beds. Most of the units had at least an ICU, emergency department, or dialysis unit. As you can see, about 2/3 of them had all of them. A lot of them had ICUs that were quite large in size. Almost half of them had a hospital that was an ICU of at least 30 beds. Many of them dealt with many AKI patients. Most of them were adult providers. And we looked at, as I said, the different paradigms of AKI. What did we find? Believe it or not, almost half of all providers, and this included nephrologists, this included intensivists, are not even using the term acute kidney injury to denote an increase in creatinine or a decrease in urine output. Please remember that AKI was introduced as the new way to name kidney injury in 2004. So 17 years later, what we're dealing with is half of providers out of this 1,000-person survey were not using AKI. They were calling it acute kidney failure, acute renal failure, or other things, knowing that AKI is the term that all of us as critical care nephrologists are putting out there to each other that we should be talking about. If we look at AKI impact alone, what you can see is we compared knowledge of AKI next to things like sepsis or a stroke or a heart attack, things that you would think most people understood. In the sense of very familiar, it is this idea that you understand what a patient looks like, you understand what you might do. Now, obviously, the disciplines were varied. If a nephrologist saw a heart attack or a cardiologist saw AKI, it was different. But if you look at the knowledge of an intensivist, a hospitalist, an emergency room physician, it was varied. If you look at the AKI is common in the ICU or outside the ICU, it was varied. Most people agreed that it increased both morbidity and mortality. Most people agreed that the cost of managing AKI was high, but as you can see, this varied quite a bit between subdiscipline. Emergency room physicians, hospitalists were not aware of how much money AKI costs. The other thing is, if you look at the bottom tab where it says leads to chronic illness, you can see that nearly all of the non-nephrologists were not aware of the long-term consequence of AKI. In this situation, we know that probably 20 to 30% of patients who have some form of AKI have chronic kidney disease. But if you ask an emergency room physician this, or a hospitalist this, or a cardiologist, many of them were not realizing this. But almost all healthcare providers agreed that early detection of AKI can lead to better outcomes. So in these specific statements about detection of kidney injury, being able to detect that before damage occurred can improve outcomes, or not recognizing AKI can lead to significant problems, or there's a stronger need for education, most of the people agreed. And those people who use management guidelines are more likely to agree that not recognizing AKI early can have a bigger financial impact on the healthcare system. So the current state, and in a state that may not be overly fascinating to us in some ways, I would say that we found something dramatic in the sense that 3/4 of nephrologists and intensivists indicated that some cases of AKI were missed at that hospital. Now, if you put it into perspective, if you said that 3/4 of them believed that cases of sepsis or heart attack or stroke were missed at the hospital, that would not be something that people would tolerate at all. More so, many of the subspecialties indicated that current methods for the diagnosis of AKI meant that diagnosis was often missed. Now, it was interesting that the nephrologists and the intensivists felt more strongly about this than the hospitalists and the emergency room physicians. So the experts in the field believed that we're missing AKI, but the people that are not in the field believe we're not missing AKI, which creates a big problem of the people who don't know that they don't know. And if you look at the bottom, and if you look at this idea of management of AKI in terms of nephrology consult, hospital protocol, KDIGO guidelines, which are the management guidelines that have existed since 2012, so almost 10 years, what you'll see is that a majority of intensivists are not following any kind of protocol. Half of them will call nephrology, meaning most of them do it on their own. Majority of hospitalist physicians, ED physicians are not following any kind of guidelines, not following any kind of protocols to recognize and manage AKI. A majority of people do feel that changes in creatinine are not sensitive nor specific for AKI. And many of them indicate that tools available for the early detection beyond creatinine and urine output were insufficient for their needs and desires. And as you see to the right, the comparison of the United States and the Western European countries showed not a lot of dissimilarities between those regions. We draw attention to this idea that more than half believe that AKI is missed. More than half believe that urine output is not specific for AKI. More than 80% believe that AKI costs a lot. Internists, pediatric practitioners, nephrologists, cardiologists all vary with how much they believe in the diagnostics, how much they believe in the guidelines, how much they're using. This varied all across the board. Probably one of the most startling findings was that of the people that indicated, yes, we are missing AKI, 1/3 of the cases that they believe they were missed could have been prevented. That is like saying that, hey, we had 10 patients today, we missed a significant proportion of them with sepsis. We could have prevented the sepsis had we recognized it, managed it in time, diagnosed it in time. This is an opportunity for improvement for us. As I mentioned, the KDIGO bundle guidelines, which have been in place for the last 10 years, less than 50% of healthcare providers are using these guidelines. So the potential, what we could do. Almost all providers indicated they would like to learn more about prevention, detection, and treatment of kidney injury. Most of them, probably a little more than half, in some disciplines, and looking overall at the United States and Western Europe, believe that knowledge of AKI is poor outside of critical care medicine. If you look at nephrologists and intensivists, again, those of us who believe that we are experts, we believe that people outside of our fields don't know. And the people who are outside of the fields who don't know that they don't know. And this is evidenced by the fact of the steps used to monitor AKI. So if you look at the bottom row, those are the steps involved in the KDIGO management guidelines. And what you'll see is cardiologists, hospitalists, emergency room physicians, even nephrologists and ICU people. As you go down the list, people check the boxes of those things less and less and less. You think about the specific ones, such as alternatives to contrast for patients with AKI who need CT scans and need radiology with contrast. The people who are administering those drugs or ordering those scans are often the people in the emergency department, often the hospitalists, often the cardiologists who need to catheterize patients. Those are the patients who could make a difference in adjudicating AKI mitigation steps. In this cumulative agreement graph, what we're showing you is the proportion of healthcare providers who agreed to the following statements one by one by one by one by one. AKI is associated with morbidity and mortality, most people. Current AKI diagnostics are imprecise. Less people, but still a decent amount. We miss AKI. Tools outside of creatinine urine output are insufficient. We keep delaying our diagnosis, which leads to poor outcome. And if we could improve that, it would improve outcome. What you see at the end is a separation between intensivists and nephrologists and emergency room physicians and hospitalists, in the sense that the experts in the field who know the epidemiology, who know the recent data about diagnostics, who know the management guidelines, feel much stronger about the idea that all these statements are connected to the people outside of the field, something that we can improve upon. So this slide also shows an agreement slide where we looked at proportion of healthcare providers who strongly agreed to the idea that creatinine and urine output changes may not be the greatest test for real-time diagnosis of AKI, and the concept that we're missing cases, diagnosis is delayed, and that we can improve outcome. As you can see, the agreement shifted between subdiscipline for the missing cases and delayed cases, but it was robust in the idea that we could improve outcomes if we could detect injury before damage actually occurred, i.e. preventative medicine, i.e. the idea that we recognize stroke symptoms before true damage is long-lasting and occurs, the idea that we can recognize signs of a heart attack before someone has serious heart damage. So our big summary findings. We found a wide range of understanding with familiarity with AKI, understanding AKI impact both short-term and long-term, fairly unison point of view that AKI was a problem in the short term, that diagnostics we have could be better, and that outcomes could be better. Quite a bit of variety in the sense of AKI leads to long-term problems, and of quite a bit of variety in terms of who's following the guidelines that were issued a decade ago. So what are our take home? What do we take from this data? What do we take from the data that we have, that as critical care nephrologists, we have tons of epidemiology that shows us AKI is bad, severe AKI is worse, AKI in the context of critical illness is terrible for you. Healthcare providers agree that it's an important contributor to patient morbidity and mortality. But we have a long way to go to understand that everyone understands what we understand. The diagnostic adequacy should be improved. There's a lot of desire for education. There's a lot of education that needs to happen with regards to KDIGO management guidelines. And so we do have some clear opportunities to raise awareness for AKI and integrate this idea of more personalization of medicine for the concept of AKI and critical illness. And with that, I'll stop, and I appreciate the chance to speak to you today, and I'd like to acknowledge people and invite everyone to be a part of our Pediatric AKI Nexus.
We appreciate Dr. Basu for his taking the time to share his insights and expertise. Thank you.
I had a lot of bad days with gout, but that one took the wedding cake. Even with medicine, my uric acid was still too high to stop painful gout buildup and joint damage. But then, my doctor recommended Krystexxa. That was a good day.
Krystexxa is a prescription medicine for adults with gout whose symptoms are not controlled by other gout medicines.
I found out that Krystexxa can start dissolving years of gout buildup within 24 hours of the first treatment.
Serious, life-threatening allergic reactions can occur. Tell your doctor right away if you have any symptoms during or after treatment. Krystexxa is not recommended if you have high levels of uric acid without a history of gout. The most common side effects were gout flare-ups, allergic reactions, nausea, bruising, sore throat, constipation, chest pain, and vomiting. Do not take Krystexxa if you have a rare disorder called G6PD deficiency or favism. Your doctor may test for this before you start Krystexxa.
I received Krystexxa for about 6 months. Now I'm in control, not gout.
Ask your rheumatologist about Krystexxa.
Thank you for joining us for the third annual Global Summit, Global Kidney Initiatives, Expanding Patient Choices and Outcomes, a collaborative partnership event presented by the American Association of Kidney Patients and the George Washington University School of Medicine and Health Sciences. My name is Kent Bressler, and I am an AAKP Board of Director and AAKP Ambassador for the state of Texas. I have FSGS, and my brother blessed me with one of his kidneys 34 years ago. On my kidney journey and professional RN career, I have felt that access to kidney care innovations and patient care choice as a health consumer is essential to providing excellent care and patient satisfaction. Patients play a critical role in the U.S. and globally. Their presence creates demand for innovation and more choices for the patient consumer. The takeaway here is that patient lives are in the balance. Patient consumers need to raise their voices to create the demand for new diagnostics, devices, and biologics in their independent countries. That is accomplished through patient consortiums that support patients in countries where healthcare systems and/or infrastructure may not support patient consumer choice and/or access to care and treatments. Being part of AAKP allows me to participate and make a difference in the kidney patient community. AAKP provides excellent guidance and resources to address national and global kidney issues. Today, I am pleased to introduce a great friend and longtime ally of AAKP, Kathy Machuzak, the Director of Patient Advocacy at Travere Therapeutics. For our session on evolving sciences, clinical trials, best practices for inclusivity in rare genetic conditions that lead to kidney diseases, a successful global trial. Kathy, please go ahead with your presentation.
Thank you, AAKP, for this opportunity to talk about this important topic. My name is Kathy Machuzak, and I am the Director of Patient Advocacy for Nephrology at Travere Therapeutics. Travere Therapeutics is a small biotechnology company based in San Diego. We are exclusively focused on identifying, developing, and delivering life-changing therapies to people living with rare disease. Our organization is unique in that many of our employees come to work each day because we are rare disease patients, survivors, caregivers, or have in some way been touched by rare disease. In addition, we at Travere are ensuring that a focus on diversity and health disparities are built into everything that we do. I'd like to give you some background first on rare diseases, and in particular, rare kidney disease. There are 7,000 rare diseases that affect 1 in 10 Americans. 93% of these diseases have no specifically approved FDA treatments, and 50% are rare diseases that affect children. As I mentioned, I work in patient advocacy in nephrology, and one of these diseases is called FSGS, or focal segmental glomerulosclerosis, and the other is IgA nephropathy. African Americans are 13% of the US population, but account for 32% of kidney failure in the United States. Also, African Americans are 3 to 5 times more likely to develop kidney failure faster than Caucasians. FSGS disproportionately affects Blacks and African Americans. There are various causes for FSGS, and this disease can also affect both adult and pediatric populations. IgA nephropathy is a disease that disproportionately affects Asians, Pan-Pacific and Native Americans as compared to their Caucasian counterparts. It can affect both pediatric and adult populations. And in addition, Latinos and Hispanics have a high prevalence for FSGS and IgA nephropathy. Also, diversity is not only about race and ethnicity, but also about gender, age, lifestyle, location, and other factors. These all have to be taken into consideration when identifying and recruiting patients for clinical trials. At Travere, we have been working to bring awareness in rare disease and diversity in various ways. The patient voice is key to understanding the disease journey of rare kidney disease patients. At Travere, we've been working to ensure that patient voice and perspective is involved in all aspects of our company. Just go to our website and you can see that patients are front and center. In addition, we work with patient organizations like the AAKP, NephCure, IgA Nephropathy Foundation, and others who help kidney patients, as well as organizations who work with various patient populations like Black Health Matters to bring awareness about rare kidney disease, clinical trials, and resources to patients and their families. Recently, we conducted 3 advisory boards in 2020 on engaging diverse patients with rare kidney or chronic disease. Our advisors included patients, patient advocacy groups, nephrologists, national minority groups, multicultural consultants, and groups that work with the African American, Latino, Hispanic, and Asian communities. These insights are provided here. And to look at this slide, you'll see that there is a dark round circle with challenges and importance. These are the areas that are common of all 3 communities. And on the outer rims of this round circle, you can see the areas of intersection where 2 of the different organizations and communities intersect. So first, let's start with the similarities in challenges. The cost of care and low income are really affected by all these communities. There are, because of it, they have lack of healthcare coverage and they can't afford the tests or follow-up care. Taking off of work can be very difficult, and the African Americans cited job demands as an additional barrier. Latinos and Hispanics said that transportation and childcare were additional barriers, and that's why they couldn't take off work to go to see their PCP or doctor. And all populations have low income as well as essential workers. Stigma and fear of having a chronic disease was brought out by all 3 communities. It deters more Chinese and Latinx and Hispanics from proactively seeking care for a rare or chronic condition. And African Americans did not overtly talk about stigma, but note that they do not discuss the family business and thus feel isolated and not understood. When it comes to preventative care and PCPs, compared to whites, adults in these populations are less likely to have a PCP, and therefore proactively seeking preventative care isn't common. But let's now talk about the importance. And family came up as extremely important for all 3 communities. African Americans value the participation in family activities, but they may not venerate the family as overtly as Asians and Latinx or Hispanics. Asians cite family involvement is crucial, although there are generational differences that may affect knowledge and openness to clinical trials. The Latino Hispanics regard family and friends as the most trusted sources of information and support. Health literacy, they want to make sure that all materials are developed at the right level and with the right words. It's really pressing to make sure that instead of medical terms, things are talked about in more colloquial language. Also, the term clinical trial may not even be in the language or vernacular of many Asian languages. And similarly, the Latinos and Hispanics may not even be familiar with the term clinical trial. Cultural relevancy. All three groups expressed a preference for their doctors who look like them or sound like them. All groups would benefit from educational materials and outreach initiatives that were tailored and sensitive to their culture. They want trusted resources that reflect an understanding of their cultural preferences. Asian Americans valued the illustrations in materials and responded to outreach in native languages. And this is very similar to the Latino and Hispanic community. Dietary guidance. Food and food traditions are really important to all these cultures. There is an unmet need for nutritional guidance for all three groups. African Americans cited guidance as needed on optimal dietary approaches, including referrals to dietitians for rare kidney disease management. Latinos and Hispanics would benefit from Spanish language cookbooks and nutrition counseling. And they also want to have recipes adjusted from their traditional recipes to more kidney-friendly recipes. I just talked about the insights from the diversity advisory boards. As I said, it's really important to understand more about the insights of various different communities. Travere is also partnered with Black Health Matters and other diversity organizations to develop awareness and education about rare kidney disease, including clinical trials and resources both online and at virtual summits. Travere continues to work with our kidney advocacy groups, nephrologists, policy experts, and patients to bring awareness about issues in rare kidney disease, including patient challenges, empowering patients, and diversity in clinical trials. Recently, a roundtable was convened with leaders from Health and Human Services and Congress, hosted by NephCure Kidney International and Travere, in partnership with the American Association of Kidney Patients. This roundtable brought together government, industry, rare disease, and nephrology community leaders to discuss policy recommendations and upcoming novel therapies in rare nephrology. These recommendations will be informed by reports from the three work groups which convened last August and September. A white paper summarizing the roundtable discussion and final recommendations was released last October. Travere also is considered where our clinical trials are located to ensure that they're situated in areas near diverse patient populations. And finally, we have expanded diversity in our own patient advocacy team, as well as in many areas within Travere. Travere is committed not only to addressing diverse patient communities within our Travere work and imperatives, but also to make diversity a universal imperative in rare disease. Travere is a founding sponsor with Black Women's Health Imperative on a new rare disease diversity coalition that had its initial meeting last year. The RDDC brings together rare disease experts, patient organizations, health and diversity advocates, and industry leaders with a deep knowledge of the medical, industry, regulatory, and cultural challenges facing people of color with rare disease. The RDDC is poised to achieve action in the years to come by reducing racial disparities in the rare disease community, identifying and advocating for evidence-based solutions to alleviate the disproportionate burden of rare diseases on communities of color, and helping to achieve greater equality with the rare disease community. To tap into the collective experience and expertise of the various stakeholders, the RDDC initially convened work groups to study and discuss needed progress in 4 key areas for people of color living with rare disease. They are correcting delays in diagnosis and treatment, improving patient and provider education and engagement, improving the state of research and clinical trials, and advocating for government policy. This work continues in 2021 and beyond. Thank you for your time today to provide an update on where industry has worked with patients to ensure that their voice and perspective is valued and incorporated into everything that we do. We continuously seek to understand the diverse perspectives of rare patients to courageously forge new paths that can make a difference in their lives and provide hope for today and tomorrow. Thank you.
Kathy, we have some questions from our viewers. Travere Therapeutics' ongoing duplex study is the largest interventional study to date in FSGS. Can you share how the company's commitment to diversity, inclusivity, and patient engagement has helped lead it to its current success?
Yes, thank you. So diversity includes many aspects: gender, ethnicity, age, where one lives, etc. And FSGS affects both pediatric and adult patients, male and female. It also affects African Americans at a high prevalence. So we wanted to make sure that we were having a diverse patient enrollment. We did this in a multi-channel approach. We worked with adult and pediatric nephrologists so that they can engage their patients. We also worked with groups like patient advocacy groups in order to bring more awareness about the clinical trials and what FSGS is. We also collaborated with organizations like Black Health Matters to bring awareness about kidney disease, FSGS, and the duplex trial to African Americans. And we were able to have healthcare at their healthcare summits, various presentations and resources available, as well as a social media campaign to bring more awareness about kidney disease and FSGS and the duplex trial. Now that the duplex trial is completely enrolled, we continue to bring awareness about FSGS and kidney disease to the African Americans by working with these groups and others like Black fraternities and sororities.
Kathy, to our last question. AAKP actively engages with industry partners on clinical trials, from the development of trial design, endpoints, identification of potential barriers to enrollment and/or retention of participants, to trial awareness campaigns to support enrollment. How valuable is it to you to have patients engaged in trial development?
It is extremely valuable to bring patients in at the beginning. Patient voice and their perspective is crucial to understand things like how many tests need to be done, what type of tests, especially when it comes to invasive tests like biopsies or even blood tests, the frequency, how many times that a patient has to go to a clinical trial site, what type of services may be available to them, such as home health care, telehealth, and even access to transportation. Also, the patient perspective is really important on study materials, things like the informed consent, patient brochures, study guides. All of that needs to have the patient perspective to make sure that all this information is understandable, it's easily digestible, and is available for them so that they can have a really good conversation with their doctor to see if a clinical trial is right for them or not. These are just some of the activities that make it really important for a patient to help an industry to have a successful trial.
We appreciate Ms. Machuzak for taking the time to share her insights and her expertise. Thank you.
We come together every day to help patients, families, and caregivers of all backgrounds as they navigate life with a rare disease. On this path, we know the need for treatment options is urgent. That is why our global team works with the rare disease community to identify, develop, and deliver life-changing therapies. In pursuit of this mission, we continuously seek to understand the diverse perspectives of rare patients and to courageously forge new paths that can make a difference in their lives and provide hope today and tomorrow. At Travere Therapeutics, we are in rare for life.
Thank you again for joining us at this Global Summit. Our next session is entitled Emerging Research in Kidney Disease with Global Implications, Kidney Disease Management and Preemptive Treatments for Diabetic Kidney Disease. AAKP and GW are very honored to have with us two leading medical experts from Bayer Pharmaceuticals, Dr. Daniel Wilson, who serves as Senior Medical Director at Bayer, and Dr. Ikenna Agba, who serves as the Executive Medical Director in Cardio and Renal U.S. Medical Affairs at Bayer. And what I'd like to do is have a dialogue and ask several questions of these experts that have been sent in from patients and from researchers and medical experts around the world. But the first question that I have for you each as medical experts is this. I know a lot of folks will ask questions about clinical trials and research in the pipeline, but I'm interested in asking this on behalf of patients. Can you tell me how your direct experiences with patients suffering from kidney disease informs what you do each day, based on your understanding of what patients have to balance in order to pursue their aspirations and their goals while managing disease? Thank you.
Well, there are two pivotal events that have influenced my decision to pursue this space and influences my work every day. I trained and practiced medicine in Houston, Texas, many years ago. And during that time, I was what they call an internal medicine hospitalist. So I took care of patients who were admitted to the hospital. And during that time, I was exposed to a lot of patients who they called, quote unquote, undocumented immigrants. Because of that, their immigration status, they were unable to participate in Medicaid. So these patients had end-stage kidney disease and needed dialysis, but were unable to get dialysis. And so the only way they were able to get treatment was to come into the emergency room when they were volume overloaded, basically so volume overloaded that they had trouble breathing. And at that time, we would admit them to the hospital and do an emergency dialysis for them so they can breathe easier. And they would be discharged a couple of days later and have to repeat this pattern every 1 or 2 weeks. And seeing them go through this was really disconcerting to me. And I always wished at that time that there was something I could do to delay these patients from getting into end-stage kidney disease. And that's been one of my biggest motivation in my work. The second event is I have a close family member who has stage 4 kidney disease and is very close to needing dialysis. And it's my passion to be able to develop new treatments that can slow down this progression of their kidney disease.
As a nephrologist, I frequently have had to sit down across from a patient and to tell them that they have advanced kidney disease and that they may come to the point where they might require dialysis. That's a very difficult discussion, not only for the patient, but also for the physician. I found over the years that many of my patients were really unaware that they had kidney disease. They were unaware that there were therapies that could help delay the progression of kidney disease. And I think that what we really need to do is we really need to focus on kidney disease at multiple levels. We need to inform patients. We need to work with physicians to recognize the factors that lead to progressive kidney disease, and we need to screen more patients to ensure that we can diagnose patients early and focus on delaying progression of kidney disease and delaying or preventing kidney injury.
So building off of these insights that you each have, can you tell me then the importance that you believe patient choice in care treatment have for patients who are trying to manage the disease and work with their doctors to come up with the best solutions that suit them while they pursue their goals?
So over the past 20 years, we've seen little development in the area of new medications to treat chronic kidney disease. But fortunately, over the last several years, the last 5 years, we've seen that now have medications that have the potential to slow progressive kidney damage and to reduce kidney injury. We have other medications that are coming down the line and that soon should be available to further contribute to reducing progressive kidney damage. We need these medications to become available to patients. Kidney disease carries a tremendous burden for an individual patient and also for a family. And we need to ensure that they have access to treatments, to physicians, to healthcare systems to slow or prevent progressive kidney damage.
Well, I definitely feel that having choice is very relevant for patients. Just to give you a comparison, diabetes space, there's 74 approved medications in the U.S. Today, and 12 different drug classes of drugs approved for diabetes. But patients with diabetes and kidney disease, over 20 years, there were no new medications approved in this space until 2 years ago. And with the approval of a new class 2 years ago, and potentially, hopefully later this year, approval of our investigational agent, these will be only 2 new classes approved in the last 20 years to treat diabetic kidney disease, which is a more severe and more dangerous disease than diabetes alone. So I think it's really important for patients and families to have access and choices for new treatment options.
For our patient and caregiver audience, can you tell me some of the things that are going on at Bayer that give you inspiration to show up every day at work with enthusiasm? And what is it that's going on in terms of innovation and treatments that patients around the globe should know so they could gain some enthusiasm or some hope from what you are working on every day?
Bayer as a company has made a huge investment into the cardiorenal space because we recognize it's a disease state that with high unmet need and high burden in the United States. Not only are we investing in new potential medications to slow down the progression and slow down mortality in this space, there's been significant investment made to raise awareness around earlier testing and screening to diagnose patients earlier in order to slow down progression to end-stage kidney disease. So Bayer is not only investing in new treatments, but they're also investing in disease state awareness so people know about this disease. We're even working on tools to help patients have better conversations with their doctors, ask them to check for the right tests, to understand what's going on with their kidneys. And so we're also partnering with various medical societies and patient advocacy groups such as yours in order to increase awareness around this space.
Well, I'm fortunate to have joined Bayer at a time where our research and development is focused on kidney disease and delaying progression of kidney disease. Over the course of the last 5 years, Bayer has been engaged in a very large clinical trial to determine if we could reduce cardiovascular events and as well as progression of kidney disease in patients who have chronic kidney disease and diabetes. This really is the largest clinical trial ever performed in patients with chronic kidney disease and diabetes. We had the opportunity to report out the results of the first part of this large clinical trial in October of 2020 at the American Society of Nephrology meeting. That's the major scientific congress for kidney doctors. That the information and the outcome of that study was also published in the New England Journal of Medicine. This was a culmination of a concentrated 5-year effort to focus on delaying the progression of kidney disease and reducing cardiovascular events. The trial had a positive outcome, and you'll soon be hearing more about this medication.
And here's a question for policy leaders and elected leaders around the world who may be listening to you today. What are the developments that are going on in diabetic kidney disease that will help relieve the burden on society and governments in terms of the costs, both direct and indirect, that they should know about? And along with that, can you tell me the types of things, both in the near term and short term, that you think elected leaders and appointed leaders across the globe should be aware of in terms of innovation in diabetic kidney disease?
Fortunately, I think our government and to a certain extent other governments are now recognizing the severity and the impact that kidney disease has on patients as well as their healthcare systems. In the United States, in 2020, we had an executive order that began to focus us on developing therapies and approaches and to treat patients with kidney disease. In other words, we're accelerating our efforts to identify kidney disease and to provide appropriate therapies for patients. We need to ensure that this effort continues. We need to ensure that this effort is supported by our government and by our healthcare providers in order to reduce the number of patients that go to develop severe kidney disease and require dialysis. We have the potential to improve healthcare. We have the potential to reduce healthcare costs by addressing this in a concentrated way. Our quality agencies, the national quality assurance groups, are now recommending that patients with diabetes, at least once a year, have a screening to determine whether or not they have chronic kidney disease or whether or not they have early signs of chronic kidney disease. Kidney disease is asymptomatic, and you need a laboratory test in order to determine if a patient has early kidney disease. So a simple, inexpensive urine test and a simple blood test will enable physicians to screen patients appropriately, make early diagnosis, and help us prevent progression of kidney disease.
Yes, we're actually partnering with various health systems within the United States to provide them with tools to identify high-risk patients earlier. That way they can potentially intervene earlier to prevent worsening of their kidney disease. And so we're also trying to work with them to encourage updating their health information technology or their electronic health records to remind them to do the screening, the guideline recommended screening for patients. That way, if patients have kidney disease in addition to their diabetes, that they could be diagnosed earlier and treated earlier to prevent progression of their kidney disease. Kidney disease, unfortunately, has been a disease that's been very under-recognized, under-diagnosed, under-treated. And so, and even though it's a serious disease, there's been a lot of inertia in terms of diagnosing, treating the disease. So we're trying to work with health systems and physicians groups to help them identify these patients earlier.
And finally, there's been a major shift over the past 10 years towards patient-centered medicine. And while for some folks that might be rhetoric, for folks that are in the private sector, and especially in the pharmaceutical industry, we know that's a substantive commitment to patient-centered medicine. Can you tell us why patients should be excited to be participants in clinical trials and in research, and why their insights actually matter from your perspective at Bayer Pharmaceuticals?
From our perspective, we always try to put the patient first in everything that we do, whether it's in developing a drug or in coming up with our medical strategy. It's really important to incorporate the patient perspective in what you do. Because ultimately, the drugs and therapies we develop, the number one aim is to benefit patient. How would you know what is benefiting a patient without getting their perspective or getting their view? So we make a very concerted effort to work with patients, patient advocacy groups, or different medical societies that work with patients to gather their insights and their perspectives in all the drugs that we're developing, and when we're developing our medical strategies on how to improve access to these new medications.
I've been impressed that many of our professional organizations are now including patients on committees to help us better understand the impact that disease has on them and has on their activities of daily living. Similarly, I've now seen that some of our major scientific congresses routinely include patients to give their perspective on the need for additional research or the outcomes that arise from different clinical trials. I think we need to continue with incorporating patients and advocacy organizations to move us forward. Patients give very interesting perspectives on clinical research, on their disease that sometimes are missed when we develop a clinical trial. So I continue to support patients and advocacy organizations in terms of working with us to ensure that not only do we have positive outcomes from our clinical research trials, but that we have outcomes that are important to patients, that we recognize, the factors that contribute to improved quality of life and incorporate that into our clinical trials.
Thank you very much, Dr. Wilson and Dr. Agba, for joining us at the Global Summit. We very much value your involvement, and we appreciate the partnership with Bayer Pharmaceutical, AAKP, and GW in this summit and in many of the other activities that we have underway. We especially appreciate your comments on the importance of patients, their insights, and their involvement and engagement with Bayer and with other companies to make certain that kidney patients are involved in the solutions and treatments that are being developed for them. This issue of diabetic kidney disease is of such fundamental importance to patients around the world and to AAKP that at this point in our Global Summit, we've decided to go ahead and rerun a very special presentation that was done for us by Dr. Susan Quaggan, who's the president of the American Society of Nephrology. Dr. Quaggan joined AAKP late last year on a session on diabetic kidney disease, or DKD. Richard Knight and I have been very involved with Susan over the years. She's a very strong patient champion and somebody who really understands that patients must be involved in the solutions that are being developed for them, because without their voice, essentially, they really don't have a choice. Dr. Quaggan serves as the chair of ASN's Diabetic Kidney Disease Collaborative, and she's the director of the Feinberg Cardiovascular and Research Institute and chief of nephrology and hypertension at the Department of Medicine at Northwestern University. It's a very special pleasure for us to repeat this presentation by Dr. Quaggan.
Well, thank you very much, Paul, for that wonderful introduction. And I want to thank both Paul Conway and Richard Knight for the wonderful invitation to be with you today. Mr. Knight and Mr. Conway asked me to present today on a new initiative that is happening at the American Society of Nephrology that I am very excited about. It focuses on diabetic kidney disease, and we are known as the DKD-C. To set the scope of the issue, we're in the midst of a pandemic right now and very difficult times. But preceding this pandemic, I think everybody in the audience knows that there's been a long-standing epidemic of diabetes throughout the world, and there will be one for many, many years and decades to come. Now, this is an old slide that I've chosen to show, And in 2015, there was an estimated 415 million people in the world living with diabetes. And said another way, that is 1 in 11 adults. If we focus on the United States alone, there is an estimated 48 million individuals living with diabetes. Now, the majority of people with diabetes have type 2 diabetes. However, irregardless of whether you have type 1 or type 2 diabetes, 30 to 40% will develop diabetic kidney disease. And this is a staggering number. And in fact, many people in the public really don't recognize the impact of kidney disease in diabetes. So, what can we do to prevent kidney disease and diabetes? And this slide talks about sort of standard of care. This standard of care existed when I was a nephrology trainee, and that is now 30 years ago. And so for a number of decades, the recommendations really did not change very much. There is no cure for diabetes, and there is no cure for kidney disease and diabetes. However, there are ways to slow the progression of kidney disease and to slow the progression to kidney failure. And I think most people know that these things include excellent blood sugar control, and this is a combination of diet, exercise, and medications. Excellent blood pressure control. And in particular, there is a class of blood pressure medications that have a long name. They're known as renin-angiotensin-aldosterone system inhibitors, and this includes the ACE inhibitors and the ARBs, the angiotensin receptor blockers. And I can tell you, I remember 30 years ago, sitting in a room, a classroom, hearing the results of this landmark trial that showed for the first time a new type of drug that could really dramatically slow the progression of kidney disease in patients with diabetes. Incredibly exciting, and I can still visualize it. It had such an impact on me. Despite us knowing for over 30 years now that this therapy is really beneficial, a recent study showed that patients with diabetes who should be receiving these medications as standard of care, in fact, only 30% of patients were receiving them. So this is this is a real issue, and we need to understand why these therapies haven't been adopted, why they're not prescribed, and why they're not getting to the patients who need them. In addition to these therapies, certainly looking after heart risk factors, looking after lipids and other things are also important in diabetes. So this is one real issue, getting the medications that are needed to patients. The second issue, which is actually very exciting and is energizing, is that there are a number of new therapies that have now entered the market. And it really is time to change history of diabetic kidney disease. Over the past few years, there have been a number of new therapies that target the kidney specifically. In particular, a class of medications known as SGLT2 inhibitors, or sodium glucose transport inhibitors, that were originally designed and discovered through research. And the thought was it could help blood glucose or blood sugar control by promoting sugar loss in the urine. However, the clinical trials done in thousands of patients showed that it's not really good at lowering blood sugar. However, they are tremendously powerful at protecting the kidney in patients with diabetes. So a truly kidney-targeted therapy. In addition, these drugs also have profound and powerful effects on protecting the heart in patients with diabetes. In addition to this really exciting new class of drugs, there are a number of other new players on the scene, and these include GLP-1 agonists, GLP-1 receptor agonists, a new study that was stopped early because of positive effects looking at finerenone, which is an aldosterone mineralocorticoid receptor inhibitor. And all of these are showing powerful protection of the kidney and also of the heart in diabetes. And interestingly, it appears that the SGLT2 inhibitors have additional effects even in patients who don't have diabetes but also have kidney disease. Based on all of this information, the scope of the problem, we know there's an epidemic of diabetes, staggering numbers of individuals who have diabetic kidney disease. We know that for the past 30 years, patients with diabetes have not been getting the best care. So now with these new therapies, there was a real passion, a real desire to ensure that we get these new therapies to patients who need them. So the American Society of Nephrology launched a task force known as the Diabetic Kidney Disease Collaborative. And I show an image here of all the members of this task force, which I have the privilege to chair. On the left-hand side, I think known to many of you here, Dr. Patrick G., who is an ambassador and on the board of directors at AAKP and is our patient voice and advocate on the task force. David Cherney, standing next to him, who is a nephrologist at the University of Toronto, world-renowned diabetes and diabetic kidney disease researcher and physician. Next to him is Dr. Catherine Tuttle, who is both a nephrologist and a diabetes doctor and endocrinologist, and she works in Washington State, and another expert researcher and physician in diabetes and diabetic kidney disease, Alan Kleiger, who has been on the task force of numerous committees at the American Society of Nephrology, including the COVID task force, bringing his expertise. I'm standing next to Alan. Next to me is Ray Harris, who is the past president of the American Society of Nephrology and the Kidney Health Initiative co-chair, nephrologist at Vanderbilt. And then finally, Chip Brocious, who's the chief of nephrology at Arizona, also a researcher and nephrologist interested in diabetic kidney disease. So when we launched this collaborative, we had a charge, and the charge is to develop strategies to promote the rapid and universal adoption of these powerful new therapies, such as the SGLT2 inhibitors that I talked about a couple of slides ago, to make sure they are provided to all patients who need them. So our objectives to, accomplish this charge is to empower and engage nephrologists and the kidney care team so that they prescribe these new therapies for patients with diabetic kidney disease. We want them to take charge. In addition, we want to promote partnerships that are absolutely critical between nephrologists and other healthcare providers that look after patients with diabetes. This includes primary care physicians, endocrinologists or diabetes doctors, and heart specialists or cardiologists to truly encourage a team-based approach to patient care, which we feel is so important. To develop educational resources for patients, for healthcare providers, to ensure there is a rapid adoption of these new powerful therapies. And also to work with policy and regulatory agencies as well as payers to make sure that it's possible for patients to receive these medications and for all patients to receive them. So how are we doing this? So the task force you saw, you aren't seeing an incredible group of staff, people at ASN who help bring this all together. Over the past couple of years, this task force has met weekly on virtual meetings and more recently every other week. We hosted an in-person strategy conference in Washington, D.C. in January of this past year, and stakeholders who were present were patients, the National Kidney Foundation, our partners at AAKP, nephrologists from around the country. There were representatives from payers, from health systems, from the FDA, from human health services, from pharmaceutical companies, and our research partners at the National Institutes of Health. And out of this very energizing meeting, we've developed a white paper with a long list of deliverables and a description of subgroups to help us accomplish the charge. And this includes an educational materials and advocacy subgroup, a patient-oriented project subgroup, a pilot project subgroup, meetings and collaborative subgroup. We are in the midst of 3 webinars. The first was hosted in August, and this was spearheaded by Patrick G. With a number of patients and nephrologists and endocrinologists talking about diabetes and kidney disease and management in the time of COVID-19. And if you didn't get an opportunity to log into that webinar, it's available on our ASN website and freely downloadable, and it was phenomenal. Our second webinar is scheduled for September, and this one is going to focus on nephrologists and the kidney care team to really empower and engage the kidney care team to adopt these therapies, start prescribing them, and to talk to patients about them. And in December, we're going to have our multidisciplinary webinar inviting our cardiology, heart colleagues, endocrinologists, to discuss the newest standards of care to ensure that we slow the progression of kidney disease and diabetes, and also slow the progression of heart disease in our patients. What I've talked about today, and I can't tell you how excited I am about all of these new therapies. They are going to transform the history and the course and the trajectory of kidney disease and diabetes. However, despite their ability to really dramatically slow the progression of kidney disease and prevent patients from ending up on dialysis for years and over a decade, we can't stop. We're only going to stop when we cure diabetes and when we cure kidney disease. So we need to continue to work together, partners with AAKP and ASN, to advocate for more kidney-focused funding with our NIH and NIDDK partners. And I can't tell you, and I think everybody here knows, that Congress listens to patients. And I would also encourage you as patients and providers to consider enrolling in clinical trials, and to be sure to check out the clinicaltrials.gov website. And it's only when we get great representation in these clinical trials will we really be able to make an impact in this disease. So my final slide, I just want to finish and say that partnering with patients is absolutely essential for success of this initiative, of this collaborative initiative. Patients absolutely have the most powerful voice. And if you have any interest in getting engaged with the DKDC task force or learning more about it, please reach out to us and continue to work with AAKP, or you can email the Executive Vice President, Todd Ibrahim, at ASN. I absolutely know that together we will win this good fight, and together we are all going to sock it to kidney disease. Again, I want to thank Paul and Richard Knight for the incredible invitation to participate in this very important meeting. Thank you.
Thank you very much, Dr. Quaggan, and we appreciate you allowing us to rerun your special session that you did for the American Association of Kidney Patients on diabetic kidney disease. At this time, we'd like to introduce you also to Dr. Catherine Tuttle. She serves as the Executive Director for Research at Providence Healthcare. She's a professor of medicine at the University of Washington, and she's the co-principal investigator for the Institute for Translational Health Sciences. Dr. Tuttle also gave a special presentation on diabetic kidney diseases to the American Association of Kidney Patients. Because this issue, diabetic kidney disease, is such a profound issue in the kidney community, and for patients that are being diagnosed at an increasingly earlier age and in minority communities, we think it's especially important to provide as much programming as possible in this area. This is now a presentation of Dr. Tuttle on this same issue, diabetic kidney disease.
Hello. I'd like to thank the American Association of Kidney Patients and George Washington University for the opportunity to present here at the second annual Global Kidney Summit. I'm Dr. Catherine Tuttle, and I'm pleased to talk about treatment for CKD and diabetes. And I'll be basing my presentation on the newly released KDIGO guidelines that have recently been updated based upon emerging clinical evidence in this field. Here are my disclosures. My objectives today will be to review therapeutic approaches for treatment of chronic kidney disease and diabetes, to recognize use of newer glucose-lowering agents to reduce chronic kidney disease and cardiovascular risks, and to discuss the importance of comprehensive care for patients with diabetes and CKD. I'd first like to start off with the definition, because oftentimes people are confused about what is diabetic kidney disease versus diabetic nephropathy. Well, they're really not interchangeable terms. So diabetic kidney disease, also known as DKD, is a clinical diagnosis based upon albuminuria, low estimated GFR, or both in diabetes. So DKD is really chronic kidney disease and diabetes, but not a specific pathologic phenotype. Whereas diabetic nephropathy is used to specify classic glomerular lesions in diabetes, such as glomerular basement membrane thickening, mesangial expansion and nodules, podocytes loss, and endothelial disruption. So for the purpose of this discussion, we will be talking about DKD or CKD in diabetes, because the clinical trials that have informed this update have been based on a clinical diagnosis, not on a specific pathologic phenotype. So first off, I'd like to start with a consideration of what are the risks of diabetic kidney disease. In nephrology, our conventional focus has been on progression to end-stage kidney disease, clearly a very important endpoint. However, only 10% of patients who develop diabetic kidney disease will progress to end-stage kidney disease. Instead, most will actually die of other causes without reaching end-stage kidney disease. About half of cardiovascular diseases, but importantly, a third of infections, particularly of pneumonia and sepsis, which are particularly relevant now in the era of COVID-19. And we will be awaiting the results of what happens to this high-risk group in the COVID era, which will probably become an even bigger issue as we go forward. I'd like to start out with the fact that despite the serious risk of diabetic kidney disease, there are very low rates of kidney disease awareness and detection in the current era. And this is true whether or not a person has diabetes. So as you'll see on the left panel, this shows awareness over the past 20 years. And even in patients at the highest risk of end-stage kidney disease, awareness is still only about 40% among patients and providers alike. As a result, we're doing very poorly with detection. In 2 large US healthcare systems with a cohort of about 2.6 million patients between 2006 and 2017, albuminuria or proteinuria was measured in only 15% of patients with diabetes and CKD, and in just 5% of patients with diabetes who were at risk and did not yet have CKD. So in order to improve outcomes, we have to clearly do a much better job of being aware and detecting the condition to begin with. The KDIGO guidelines start out with the fundamentals of providing comprehensive care to patients with diabetes and chronic kidney disease. And as you can see at the bottom of the pyramid, it really rests on healthy lifestyle as well as control of conventional risk factors for chronic kidney disease and cardiovascular disease. That includes glycemic control, blood pressure control, and lipid management. And now we're recommending for most patients that they also receive an SGLT2 inhibitor along with the renin-angiotensin system inhibitor for kidney protection. And in some patients, antiplatelet therapies to reduce the cardiovascular risk. And again, I will remind you that cardiovascular diseases are more common than kidney disease events. So we really need to be addressing both of these important conditions if we want to improve outcomes that matter to patients. With regard to lifestyle, clearly, healthy lifestyle is fundamental to treatment of both diabetes and CKD, and we have recommended that a protein intake be limited to 0.8 gram per kilo per day for those with diabetes and non-dialysis CKD. Higher levels of protein have been associated with CKD progression, and this level of protein intake will maintain good nutrition, while at the same time not increasing the risk of kidney disease progression. We'd also like to emphasize the importance of plant proteins because for any given amount of protein, plant proteins are more kidney protective than animal proteins. Once patients start hemodialysis, there are protein losses and catabolic conditions that occur with dialysis, and they then need a higher protein intake, which is why we then switch to recommending more than a gram and up to 1.2 gram per kilo per day. The other important lifestyle intervention that is critical for patients with diabetes and CKD is limiting sodium intake to less than 2 grams per day. This has been around for a long time, but considering the importance of blood pressure control on mitigating CKD progression in diabetes, we are emphasizing the importance of limiting sodium intake and have provided some practical tips about how to do this. We'd also like to emphasize that the current standard of care really is an ACE inhibitor or an angiotensin receptor blocker. And this standard of care has been in place for some 20 years since the original National Kidney Foundation KDOQI guidelines came out for diabetes and CKD. And the importance of initiating these therapies because nearly 20 years in, we're still falling short on treating most of the patients who would benefit. We also have some recommended strategies for mitigating risks, such as hyperkalemia or an increase in creatinine, with the goal of trying to keep patients on these therapies whenever possible. and that we would reduce or stop these agents only as a last resort if we haven't been able to manage these complications. These were the original trials in type 2 diabetes and CKD that evaluated the angiotensin receptor blockers. You can see these studies were published in 2001, so nearly 20 years out. And these were the last treatments prior to SGLT2 inhibitors that had been approved for the treatment of CKD and diabetes. One tested losartan in the RENAL trial and irbesartan in the ID&T trial. And while risk was reduced, you can see the risk reductions were modest, 16 and 20% respectively, leaving a very large absolute residual risk. Now, how well are we doing with the standard of care? Not nearly well enough. This is another report from Cure CKD on medication use in patients with CKD in two large U.S. healthcare systems, the UCLA and the Providence healthcare systems across 5 Western states. And as you can see, while ACE inhibitor and ARB use increased over time, even in the most recent era, only about 14% of patients with CKD overall were receiving an ACE or an ARB. And in those with diabetes, CKD, and hypertension, perhaps the hardest indication to use these agents, ACE inhibitor or ARB use was just 25%. So one of the reasons that our patients are not benefiting as much as they could is that we are underutilizing the only agents that we had approved for diabetic kidney disease in the past 20 years. And even among those who have received them, the risk reduction is relatively modest and not more than 20%. So clearly there has been an enormous unmet need for better treatments. There have been many new therapies under study for diabetic kidney disease. Time does not permit us to have a detailed discussion, but I just wanted to give you an example of the kind of approaches that have been taken. But where we've really seen deliverance is actually with the newer anti-hyperglycemic agents. And at the time these studies first came out, they were rather a surprise, but they've really delivered in remarkable ways that we haven't seen in some 2 decades. This is just showing the clinical trials of diabetes drugs over the past 7 years. This is 2013 to 2020. So as you can see, we've studied an enormous number of these agents. Now, most recently, the drugs of particular interest have been the SGLT2 inhibitors shown in the pink box and the GLP-1 receptor agonists shown in the orange boxes. These trials have mostly focused on cardiovascular safety and then cardiovascular efficacy, but importantly, they generated data from secondary outcomes on kidney disease that showed remarkable benefits that, again, at the time these studies first came out, were quite surprising. And then the Credence trial reported last year was the first trial with an SGLT2 inhibitor conducted in patients with diabetic kidney disease, which was the first time in the history of nephrology we've had a trial stopped early because of overwhelming benefit. And that's what I'll be talking about next. So first off, in the interest of time, I'm going to give you the USA Today headliner version and then show you selected data to back up the claims. So first off, in the cardiovascular outcome trials of these agents in type 2 diabetes, not only did we learn that they were safe from a cardiovascular perspective, but they also delivered in terms of superiority, meaning they reduced risk of major adverse cardiovascular events. And these include the 3-point MACE, that is the so-called atherosclerotic events of myocardial infarction, stroke, and cardiovascular death. But most importantly, they have significantly reduced the risk of heart failure events. And for 2 of the 3 agents tested so far, have also been shown to reduce cardiovascular deaths. With regard to kidney disease, across the board, they decreased macroalbuminuria, decline in GFR, and end-stage kidney disease. And even in patients with pre-existing kidney disease, these cardiovascular benefits and kidney disease benefits are present. So they really hit the sweet spot in patients with CKD who are at risk of both of these important outcomes and deliver what we want, reduced rates of death, and among the living, maintaining better health. This is the main result from the Credence trial. This trial was conducted in people with diabetes and CKD with eGFR between 30 and 90 and macroalbuminuria with UACR or albumin to creatinine ratio greater than 300 and less than 5,000 milligram per gram. And these patients all received the standard of care. So in contrast to usual practice, 99.9% of patients in credence were receiving an ACE inhibitor or an ARB. And on top of that standard of care, there's another 30% reduction in the major outcome, which was end-stage kidney disease, serum creatinine doubling, a marker of kidney disease progression, and death attributed to either CKD or CVD. As I pointed out, this was the first trial stopped for overwhelming efficacy. And I'd also like to point out that the FDA approved canagliflozin, the agent used in the CREDENCE trial, for the treatment of diabetic kidney disease, and included not only the indication to reduce kidney disease endpoints, but also to reduce CVD death. And this is the first time we've ever had a drug approved to prevent death in patients with kidney disease. So this was really a landmark study for multiple reasons. This is just showing the primary outcome by various subgroups at different levels of GFR, higher and lower albuminuria, and the benefits are clear across the strata of eGFR and albuminuria. In a subsequent meta-analysis that included the cardiovascular outcome trials where the CKD endpoints were secondary and the CREDENCE trial in which they were primary, you see across the board, however we wanted to combine the events, there was a benefit of the SGLT2 inhibitor class, shown by the large diamond to the left of the line of unity, showing reduced risk. There had been a theoretical concern that SGLT2 inhibitors could increase risk of AKI, and whether in the CREDENCE trial, shown on the right, the bottom bullet in the forest plot, or in the meta-analysis with the CREDENCE data combined with the cardiovascular outcome data, we actually see reduced risk of acute kidney injury in the range of 25%. So not only are the agents safe from an AKI perspective, they actually are beneficial in terms of reducing risk of acute kidney injury. How might this be working? The first cardiovascular outcome trial to report kidney outcomes was the IMPA-REG trial shown on the left. As you can see, the baseline GFR was 76 because these patients were selected for heart disease, not kidney disease risk. And from this baseline of relatively normal GFR in the placebo group shown in gray, you see progressive decline over time. Whereas in the IMPA-treated patients, whether at the higher or lower dose, we see an abrupt initial decline in GFR of about 5 mil per minute, but then this stabilizes over time so that by the end of the observation period, GFR was higher in the IMPA-treated patients than in the placebo patients. When we looked at CREDENCE, a group that was selected for kidney disease, you can see they start with a lower baseline GFR as expected, 56, but you still see the pattern of the abrupt early decline, about 5 mil per minute of eGFR with stabilization over time. This really harkens to a hemodynamic mechanism, really the only explanation for an abrupt decline so quickly within a week or two of starting the agents, but preservation in kidney function over time. This is just a reminder of some renal physiology about why this might be so. And I'd first like to start out with a review of what happens to renal hemodynamics in diabetes. Early in diabetes, we see actually increased GFR or glomerular hyperfiltration, but even when GFR declines, remnant nephrons or remaining function units in the kidney are still hyperfiltering at the single nephron unit level. This is because blood flowing into the capillary, the glomerulus, is increased because of dilation of the inflowing or afferent arteriole, and because the downstream or outflowing arteriole is relatively constricted. So when I teach our medical students, I use a faucet and hose analogy, and that the upstream end is like having the faucet turned on, and the downstream end is like kinking the hose, so that in between there's very high pressure. And we have known for 40 years this is a major mechanism of progressive kidney injury and diabetes. When we give an ACE or an ARB, they decompress the glomerulus by dilating the downstream artery, unkinking the hose, but we still have the inflowing artery at pumping blood into the glomerulus at a higher than normal level. In diabetes, there's also increased glucoseuria, which is taken up in the proximal convoluted tubule by receptors called SGLT2 transporters. These transporters also take up sodium with glucose, so that in diabetes, because of the increased uptake of glucose in the proximal tubule, there's increased uptake of sodium such that downstream in the tubule, there's less delivery of sodium chloride to the segment called the distal convoluted tubule, shown in the figure by the little box area. And in the specialized area called the macula densa, less sodium is taken up because less is delivered. And this has a very important effect on the inflowing artery. If you look at the blown up box, the uptake of sodium in this segment requires active transport by a sodium-potassium ATPase. When ATP is used, it generates adenosine, but adenosine is not a waste product in this situation. In a paracrine fashion, meaning right next door, it moves from the macula densa to a receptor on the inflowing artery, where it basically turns down the faucet. It's a relative vasoconstrictor. So when we give an SGLT2 inhibitor, shown on the right, we block glucose and sodium reabsorption in the proximal tubule. More of these solutes transit downstream to the distal tubule, the macula densa where the box is. We restore sodium uptake, we start using ATP, generating adenosine, and we clamp down the inflowing artery. So we take care of the other limb of this. This is why we think the combination of an ACE inhibitor or an ARB with an SGLT2 inhibitor has shown such remarkable effectiveness for reducing CKD progression in diabetes. There are likely many other mechanisms. This is not by any means suggesting that this is the only mechanism, but it is a major mechanism and one that we can understand in terms of how these agents work in terms of driving CKD progression. Time will not permit a detailed discussion of other mechanisms, but this one is clinically relevant and has implications for how we actually apply the therapies. This is just showing the main cardiovascular outcomes in the credence population. On the top, we have CVD, death, and heart failure in a primary and secondary prevention cohort. In the bottom, the MACE, the atherosclerotic events. And in both primary and secondary prevention cohorts, we see benefit. This was the first time that a primary prevention cohort, that is a group of patients who did not yet have a cardiovascular event, were shown to have kidney protection. The cardiovascular outcome trials only benefit had been shown for primary prevention. So the other thing that credence delivered was information to the cardiovascular community that these agents could prevent the primary onset of heart disease. And for the kidney disease community, that even in patients with established diabetic kidney disease, we can reduce cardiovascular events and cardiovascular mortality in a group at very high risk. Again, we don't have a lot of time to talk about the interplay between the heart and the kidney, why this drug acting on the kidney would have such profound benefits on the heart. But clearly, the natriuretic effect and the diuretic effect are important for heart failure prevention. However, the benefits are beyond what we've seen with other diuretics. So there are many other hypotheses being tested. There's a mild ketosis, which from the standpoint of cardiovascular fuel energetics is favorable. That is, beta-hydroxybutyrate is a preferred myocardial fuel. There's also increase in oxygen delivery because the kidney begins to make more erythropoietin. So these are things that may improve cardiac function above and beyond what we can account for by natriuresis. And again, we don't have time to go into the details of this. These are active areas of investigation, and I'm sure that you'll be hearing more about these potential mechanisms as time goes on. And the mechanisms are important because they will drive the clinical application and optimal use of these agents. Let's now turn to the GLP-1 receptor agonists because they're close on the heels of the SGLT2, and these drugs are also delivering in big ways for our patients. They were similarly studied in the cardiovascular outcome trials for type 2 diabetes, first for safety, but again, they met the safety bar, and now they've been shown to also show superiority with reducing risk of major adverse CVD events. However, their benefits are really confined to atherosclerotic events. There's no harm to heart failure, but no benefit. However, they are very potent in terms of reducing risk of atherosclerotic events, and two agents in the class, liraglutide and semaglutide, also have indications to prevent cardiovascular death. With regard to the secondary kidney outcomes in the CV outcome trials across the board, they decrease macroalbuminuria, and they've been shown to reduce GFR decline from early to late stage CKD. Unlike the SGLT2 inhibitors, these drugs can be used in patients with very low GFR. SGLT2 inhibitors to date have only had studies report out for patients with GFR as low as 30, whereas in the GLP-1 receptor agonist trials, for example, in the dulaglutide studies, we've gone down to a GFR as low as 15. And these benefits for cardiovascular and kidney disease have been demonstrated in patients with pre-existing CKD, including those with very low GFR down to 15. This is a cardiovascular outcomes trial meta-analysis showing from these studies the effect on kidney disease outcomes. Again, the diamonds to the left of the bar demonstrate benefit, reduced risk, and you can see overall it's about 17%, but remember these are cardiovascular studies, so they were selected for cardiovascular risk, so less opportunity to reduce kidney disease risk, but everything goes the right direction. When albuminuria is taken out of the endpoint, so the bottom panel just showing worsening of kidney function, similar magnitude of risk reduction, but just missed statistical significance because in a population of people who don't yet have kidney disease, albuminuria is the more common outcome, therefore easier to impact with a treatment intervention. However, Award 7 was a clinical trial of dulaglutide compared against insulin glargine for glycemic control in people with type 2 diabetes who had moderate to severe CKD. So these patients had stage 3 or 4 CKD. If you look at the panel on the left, you see the baseline GFR was 35, much lower than any of the other trials I've shown you, even for the SGLT2 inhibitor class. In the insulin-treated group, you see progressive GFR decline over the 1 year of the study, whereas the 2 doses of Dula, either higher or lower dose, produced GFR stabilization. And in the right panel, we just show a bar graph of change in GFR at 26 and 52 weeks. And you can see substantial GFR decline in the insulin-treated group, whereas actually there was no significant decline in eGFR in either of the Dula groups. And the between-group comparisons are also highly statistically significant. This is a pre-specified exploratory analysis where we also looked at so-called hard outcomes of either 40% GFR decline or end-stage kidney disease. And you can see that these events overall were reduced by more than half with the highest dose dulaglutide group. And if you look at the subset with macroalbuminuria, the highest risk group, you see that actually the hazard ratio was 0.25, so 75% risk reduction. And this observation held in even the group with the GFR below 30, between 15 and 30. This paper is winding its way through publication, but these data I can show you because they were presented at both ASN and ADA and are in the public domain. So this gives very strong rationale for testing these agents in a phase 3 trial. And that, in fact, has begun. It is the FLOW trial, testing semaglutide, a GLP-1 receptor agonist, versus placebo in patients with diabetes and chronic kidney disease down to a GFR of 25. How might this work? Again, we don't have time to go into the details, but yes, there is biological rationale. They work very differently than SGLT2 inhibitors. These agents probably act primarily through an anti-inflammatory mechanism and an antioxidant mechanism. And interestingly enough, this may be mediated not only by resident kidney cells, but also by invading cells such as macrophages and T lymphocytes that are actually recruited into the kidney in a pro-inflammatory mechanism for DKD progression. So to summarize the benefits and harms of SGLT2s and GLP-1s, and we actually in the guidelines also show the DPP-4 inhibitors for comparison, are shown here. So where we have the most evidence is actually for SGLT2 inhibitors in terms of particularly heart failure, but also some benefit on atherosclerotic events and clear kidney benefits on reducing risk of end-stage kidney disease and GFR decline. We do have issues with regard to some side effects, particularly genital mycotic yeast infections and diabetic ketoacidosis, possibly amputations with canagliflozin, but we've recommended risk mitigation strategies so that these patients can be safely treated and avoid these side effects. With the GLP-1 receptor agonists, I would say that they are second in line, but mainly because of not enough evidence, not negative evidence. Again, important effect on atherosclerotic, reducing atherosclerotic effects. No harm for heart failure, but no particular benefit. They are anti-albuminuric. They do slow GFR decline. And we're testing, and hopefully we'll learn soon about their effect on hard kidney disease endpoints. The main side effects here are primarily gastrointestinal, nausea and vomiting. And most patients will develop a tolerance to this over time. So starting with a lower dose, coaching them through the initial month or so of treatment usually is successful. The DPP-4 inhibitors just have not delivered in terms of any of the either cardiovascular kidney outcomes. They do lower albuminuria, but this has not translated to effects on GFR or other kidney endpoints. So at this point, they can be an adjunct to glycemic control and can be used with low GFR, but are not believed to have true kidney protective effects like the other two classes. So with regard to the hierarchy of therapy, we're dialing in now again to that pyramid we started with, the base of healthy lifestyle, activity, nutrition, weight management. With regard to glycemic control, if the GFR will tolerate it, metformin still is a first-line therapy, along with an SGLT2 inhibitor. And then for patients who have not achieved glycemic goals, or perhaps who have not had optimal albuminuria reduction, or who cannot tolerate metformin, we then recommend a GLP-1 receptor agonist be considered, and then really everything else down below. So I'll wrap up by saying our long-term standard of care for treatment of CKD and diabetes is an ACE or an ARB, but these agents remain strikingly underutilized in clinical practice, which is an area that needs to be addressed along with new therapies. The new therapy on the block is an SGLT2 inhibitor for CKD and type 2 diabetes with GFR greater than 30. And the indication is not just glycemic control, but more importantly, to prevent GFR decline, end-stage kidney disease, heart failure, atherosclerotic CVD, and CVD death, the big stuff. And in fact, these drugs don't do very much for glycemic control in patients with low GFR, but they're still beneficial for patient protection, that is preventing the major events of diabetic kidney disease. GLP-1 receptor agonists are very effective anti-hyperglycemic agents, even with low GFR, in contrast to the SGLT2 inhibitor class. And they also have organ protective effects, primarily preventing atherosclerotic CVD, and emerging evidence that they lower risk of albuminuria and GFR decline, and we'll soon learn if there are true effects on hard endpoints. And finally, we want to emphasize the importance of patient self-management, providing education and team-based care in order to give the full 360 of comprehensive care for the best outcomes for our patients with diabetes and CKD. And with that, I thank you.
I'd like to thank all of our speakers today speaking to the issue of diabetic kidney diseases. We're especially pleased with the presence of Bayer Pharmaceuticals at the Global Summit and the efforts of all researchers around the world who are working on this issue. It's timely, it's important, and again, it's impacting people at a younger age and disproportionately in minority communities. Together we can and we will work to solve this issue. Thank you.
I had a lot of bad days with gout, but that one took the wedding cake. Even with medicine, my uric acid was still too high to stop painful gout buildup and joint damage. But then, my doctor recommended Krystexxa. That was a good day.
Krystexxa is a prescription medicine for adults with gout whose symptoms are not controlled by other gout medicines.
I found out that Krystexxa can start dissolving years of gout buildup within 24 hours of the first treatment.
Serious, life-threatening allergic reactions can occur. Tell your doctor right away if you have any symptoms during or after treatment. Krystexxa is not recommended if you have high levels of uric acid without a history of gout. The most common side effects were gout flare-ups, allergic reactions, nausea, bruising, sore throat, constipation, chest pain, and vomiting. Do not take Krystexxa if you have a rare disorder called G6PD deficiency or favism. Your doctor may test for this before you start Krystexxa.
I received Krystexxa for about 6 months. Now I'm in control, not gout.
Ask your rheumatologist about Krystexxa.
for joining us for the 3rd Annual Global Summit, Global Kidney Innovations, Expanding Patient Choices and Outcomes, a collaborative partnership event presented by the American Association of Kidney Patients and the George Washington University School of Medicine and Health Sciences. I am Leanne Williams, an AAKP ambassador from Louisiana. This past April marked 5 years of dialysis for me. I was diagnosed with end-stage renal disease 1 month before I was set to earn my bachelor's degree. I am currently on home hemodialysis, but I did over 1.5 years in center before converting to home. The flexibility of being home has allowed me to earn 2 master's degrees while on dialysis. Being a part of AAKP allows me to learn and expand my outreach. As the largest patient-led and focused kidney organization, they provide invaluable access to resources, patient meetings, webinars, and research to educate patients, caregivers, families, congressional members, and healthcare and industry professionals. With a background in research, but also being a patient, I know firsthand the process involved in creation and development of new innovations and devices. But I understand why the patient perspective is even more important in the process. Both in the United States and globally, developers must understand that as patients, we are the ones who have to live with the innovations they develop. AAKP is a vigorous champion of patient consumer choice. This means we believe patients should not face barriers to access to kidney care solutions that best align with their ability to pursue aspirations such as work and career, having a family, home ownership, and a secure retirement. Today, I am pleased to introduce an AAKP ally and partner, Renuka Upalari, Vice President of Research and Development of Renal Care at Baxter International, for our session on a global need to support an ever-growing home dialysis community, innovation and access in dialysis. Ms. Upalari, can you tell us your view on the importance of patient-consumer care choice and how it impacts the marketplace and innovation?
The key to long-term success of any therapy is to have the patient involved and engaged in their own care. However, we know that from USRDS data that 60% of incident dialysis patients end up starting dialysis on an urgent basis. And majority of them end up with a central venous catheter and start in hospital or in center hemodialysis. At this point, the patient has no choice. We believe that a comprehensive education mechanism that the patient can have access to long before they have to start any dialysis or transplant is the right way to go so that the patients are educated about their choices. And this is a problem that we face all across the globe. And at Baxter, we are addressing this by offering many digital education tools. One example of this is an app called My Kidney Plan. And the patients can download this app and go through content that's tailored for their own learning needs. And this app provides them an opportunity to explore all the various treatment choices that are available to them in a very objective fashion, so that the patients then feel empowered, educated, and confident about participating in shared decision-making with respect to their treatment.
Would you please explain the value of patient insights and engagement in next-generation product development?
As the global leader of Baxter's renal care R&D team, I can assure you that the first and the most important step we take before we start any product development process is to listen to the voice of the patient. We understand that kidney disease is a very personal journey, and it's different for each patient. And we want to make sure that we support the patient through that journey. We also recognize that the kidney disease affects patients from people of diverse backgrounds, whether it is age, gender, geography, culture, or economic background. And we want to make sure that the products and services we develop address all of these groups. And we accomplish this by partnering with healthcare professionals and patient associations around the world. And in our product development process, we speak to user groups and we make sure our clinical trial participants represent the diversity of our patients who will use our products. And you can see this sort of partnership come through very visibly in some of the service programs we offer, such as PD Travel Club. And sometimes this sort of engagement is not so visible, but it's fully and wholly represented with the products and services that we offer.
How has the COVID-19 pandemic impacted your work, especially in terms of home care solutions for dialysis patients?
The COVID-19 pandemic has created a major and lasting impact for our patients. We know that kidney patients are one of the most vulnerable population, high risk with a lot of comorbidities. And even as we have the vaccine now, we know we're not out of the woods and we need to continue to keep a watchful eye. One of Baxter's priorities during this pandemic has been to make sure that we can remove any and every barrier to doing dialysis safely at home. But we also recognize that this is an effort we need to engage the community in and partner with organizations to have a healthy mix of advocacy as well as innovation. On the advocacy front, we are working and listening to key nephrologists to hear their issues around catheter placements. And we are working side by side to lobby to make sure these sorts of placements can happen in the appropriate amount of time. On the innovation front, we are working on broadening access to our remote patient management tools that we have. And as of today, we have over 43,000 patients whose dialysis information on a daily basis from home is sent to the clinicians so they can provide the therapy and the care on an ongoing basis from a remote site. And we are expanding on providing these tools so that they can not just get the basic therapy, but have enhanced care with remote patient management.
Please tell us how you stay connected with the patients and healthcare professionals you serve, and how that specifically impacts our views on the burden of kidney disease.
Our mission at Baxter is to save and sustain lives. And this is our driving force, our North Star in every patient and customer engagement, every business decision we make, every product development activity that we do. We believe that we are in the business of solving critical and difficult patient problems. And we know that we can only do this successfully by engaging and partnering with the patients themselves and their care providers. So we want to thank our patients, healthcare professionals, and organizations such as yours to partner with us in fulfilling our mission.
We appreciate Ms. Upalari for taking the time to share her insights and experience. Thank you.
Thank you for joining us for the third annual Global Summit, Global Kidney Innovations, Expanding Patient Choices and Outcomes, a collaborative partnership event presented by the American Association of Kidney Patients and the George Washington University School of Medicine and Health Sciences. My name is David Rodriguez. I am an AAKP Board of Director, Executive Committee member, and an AAKP Ambassador for the state of Texas. I am also a kidney transplant recipient for almost 10 years, with 3 years on hemodialysis, and a patient advocate for 13 years. My journey as a patient has reminded me the importance of access to kidney care innovations and the principle of patient's care choice as a health consumer. Patients play a critical role, both here in the USA and globally, in creating the demand for innovation and more choices because patient lives are in the balance. Our highest expectations is to reinforce the need for patient consumers to raise their voices in the process and create the demand for new diagnostics, devices, and biologics in their independent countries, and have a united patient consortium that can support the demand globally and support patients in countries where healthcare systems and/or infrastructure may not support patient consumer choice and access to care treatments. Being a part of AAKP allows me to be the voice for my community and the state of Texas, and around the country through my personal experience, and promote chronic kidney disease awareness around the globe. Today, I am pleased to introduce a longtime friend and an ally of AAKP, Regional Cito, President and CEO of CareDx Incorporated, for our session on emerged research with global implication, advancement in cell-free DNA testing to improve post-transplant care. Ladies and gentlemen, Mr. Cito.
Hi, my name is Red Cito. I'm the President and CEO of CareDx. I'm really proud to be here today presenting and talking at the third event between AAKP and GW. I'm really excited because I was present during the inaugural event, and we just think it's a fantastic initiative that's been undertaken. Firstly, I'd like to thank the leadership team at AAKP. It's been a really tremendous partnership working together with Richard, Paul, and Ed, and what you do every day in and out means a lot to us and for the patients all across the world who are watching today. CareDx has been around for more than 20 years, and our mission has been simple, and our vision is really to be the leading partner for the transplant ecosystem. In terms of our mission, it's really about how do we improve organ outcomes, and it's something that's driven by innovation, and that's what more than 500 employees across the globe focus on day in, day out. How do we serve you, the transplant community, and the transplant patient? And this is part of the management team. As we looked over the last 12 months, it's been a difficult period around the world, and everyone's been impacted by COVID. But just know, front and center to what we do day in, day out has been about how do we support the transplant ecosystem, the transplant patients, and the transplant community. We thank all the carers and providers who have been looking after the patients during this very difficult time. And so, just to highlight some of the key parts of CareDx, I mean, in the last few years, we really have become involved with the transplant company. And today, if we look at the kidney space, more than 1 in 4 patients are involved with CareDx and with our marker, which you'll hear about later on, called AlloSure. And the reason we've been around is because we've been known for innovation. And so we were the first to bring gene expression profiling in transplant. We were the first to bring donor-derived cell-free DNA in transplant, and that's what you'll hear a bit about today as well. And we're the first, actually, and only company to bring multimodality approval, that is combining technologies to bring incremental clinical utility. This is so important for us as a company that drives innovation, to bring things that mean a difference to clinicians and to patients, and ultimately, how can we do better to serve you? And that's really important for us. As a result of that, I can share that on the heart side, more than 90% of centers are involved in using our offerings, and more than 75% of kidney transplant centers today use AlloSure. We're really proud to be serving patients, and again, to be such a core part of each transplant center. And so really this highlights and showcases what we do on the patient journey. We have a focus not just on one part of what patients go through, but in all parts. And this is what we call the patient journey, looking at pre-transplant, peri-transplant, and post-transplant. And on the pre-transplant side, we actually are actively involved in the waitlist management area through a group called XinCare, which has been part of CareDx over the last 2 years. We also have the latest type of HLA typing the only type of NGS or next generation sequencing called hybrid capture. This means that the tests don't have to repeat in the HLA type because it's the most sensitive test in terms of being no repeats. And so we're really proud to bring this innovation on the typing side as well. If we move in actually on the post-transplant side, we have AlloSure, which is a marker looking at cell injury, and it's really transformed what has been done in the transplant community on the kidney side. More than 150 centers of the 200 in the United States actively use AlloSure, and we're really proud to be the company that's brought this, particularly with our transplant focus. What you'll see here is some of the other offerings we're bringing, and what we found is by having more than one offering, we can actually increase the clinical utility in how we assess a transplant patient's organ status. And I think what we have here is iBox, which is a prognostic algorithm, which is derived and come from the latest and leading center institution in Paris. We also have AlloMap, which is gene expression profiling, which is built off the many years of experience we've had with AlloMap on the kidney, on the heart side. And then we have several other different types of tests. And UroMap is an example of a urine test that we're also developing, which came out of Cornell. The important thing is, as we look at this patient journey, we also have a very strong relationship with the centers, which we just talked about, these 150 plus centers. And what we've tried to do also is improve the workflow. So as anyone who's worked in a hospital setting or a patient, operational workflow, EMR records are so important. And so what we have here is a direct connection through 90 plus centers through AutoCare. And recently this year, we also acquired a company called TransChart. And so now we're more than 90 plus transplant centers with an EMR focus. And we also help centers with what we call quality management. And we have a company called XenCopy that helps out there as well. And some of you may have seen this. So really for us, it's following that patient journey and being involved at every critical juncture for you, the patient, and also with the hospital setting ecosystem. And so if we think of the kidney patient who's at end stage renal disease, there are really only sort of two options. You continue on dialysis, or you look at kidney transplant. And I think without a doubt, the kidney transplant option is one where provides a much improved quality of life, and at the same time, it also has a much longer survival period, up to 10 years now. So we're really seeing a real shift in the whole transplant community of how do we increase the number of available organs, how do we get more patients on transplant. It's actually the basis of a major initiative which was announced about 2 years ago, and something which we see continued progress. It just shows how important it is to look at transplantation in kidney patients. And so we have this opportunity to get a transplant, which is great news, but at the same time, 1 in 5 transplants do fail. And so that's not good, right? These are such precious organs, and it takes such immense time to get these, and there's such a long wait list. So us as a company, how do we try to improve that survival outcome? How do we ensure that any form of injury or potential rejection is picked up earlier? So that was one of our deliberate missions as a company. How can we help out in this space? And so if we look at our technology, it measures donor-derived cell-free DNA, and essentially this is looking at cells that are released during the course of injury or death, and it's not something that should be elevated in most patients. What we have is AlloSure is the first analytically and clinically validated donor-derived cell-free DNA test, and really we brought this into the space. And it's hard being a trailblazer, because when you bring new technology, when you bring new innovation in a space which hasn't had a lot of new innovation or new technologies, it truly means that you have to shape the space. And we're really proud that there's been such a rapid and early adoption at more than 150 centers believing and using AlloSure. And I think more than 60 of these centers actually have a protocol which is AlloSure specific. So in many cases, it's really, really hard to get protocols, and this broad adoption, it's because of our ability now to say, is something happening when you have this elevation? Because it tells the clinician that there should be a high level of scrutiny and also monitoring this patient, because you shouldn't be having an elevation of donor-derived cell-free DNA, because it's a marker of cell injury. And so if we look at AlloSure from a clinical perspective, there are centers that look at how do you do biopsies in a surveillance perspective. That's fewer and fewer in the United States now. And then you look at what are some of the non-invasive forms. And so historically, there's been serum creatinine. There's also been DSA looking at different forms of injury or potential rejection. What we found through multi-center prospective studies, we're the only company that's done that, again, multi-center prospective studies, is that what AlloSure has been able to demonstrate is a more accurate test and also an earlier predictor than what we've seen with serum creatinine, and also with the prediction of de novo DSAs, which is a precursor of DSA. So this has really been a pivotal moment for the field, as we now have the ability to do a non-invasive test, but also provide unique insights much earlier and more accurately. And so if we think of that from a clinician's perspective, myself being a physician, what does this mean as we monitor patients? What does this mean with these precious organs that we've been provided, and the fact that 1 in 5 still fail after 5 years, and that really isn't acceptable. And I think it's something that what can we do more of? And so with AlloSure and as a biomarker, what you can see here is that if it is elevated, there's a form of injury. It could be indication of rejection, but what's important here is that it allows that point of intervention by the clinician. And so there's either adjustments in medication, there's more intensive monitoring of the patient, and there's further workup. But what you see then is once that patient and that graph starts improving, then you can see a decline also in the AlloSure measurements. And so it's a tool that is used in terms of surveillance to allow the ability to detect if there's a change in the status of the organ, and that's really important. It's such a precious gift. And my aunt's on her waiting for a third, and I think everyone at KDX has such a special sort of association in the transplant space. I recently hired someone who is based out of Florida, and her daughter is a young kidney transplant recipient. And so for us, we really live this in our mission. And so I think that's why AlloSure continues to be such a powerful new form of innovation for the space. And the important thing is, we're a company that is driven by bringing good science and innovation. And so we're the only company that does multi-center and has done multi-center prospective studies. And that's really important, because you don't want to just do a test in one center. You want to do multiple centers as you develop this technology. On top of that, you want to look at things prospectively. That is, you measure these in patients as doing an actual study, and not trying to look retrospectively after at patients. And I think that's really, really important. What we found is we're really good at generating good innovation, but we're even better at generating good science. And what you can see here is we've got the most number of publications on this space in terms of transplant donor-derived cell-free DNA. And more importantly, AlloSure is the test that has set all the reference standards. So we talk about different protocols. We talk about monitoring this thing such what we call relative change value, which tells, should you be even more concerned because the test has changed above a certain threshold between measurements. We created that standard working with transplant centers across the United States. We continue to bring these reference standards, which is so important, multiple publications, which indicate, how do we have early detection of de novo with de novo DSA as a precursor for DSA. And, when you get ambiguous rejections, how can you tell if they're clinically relevant or not? So the importance here is that as a company is that we believe in innovation, and we've been the first at every stage. But more importantly, we continue to drive that innovation and generate insights both for the centers, the patients, and the physicians. And it's so important for us. And so this slide I want to share because I actually showed it 3 years ago at the inaugural meeting. And also it reflects a board discussion we had, which is we were being asked, should we go into other areas or should we stay in transplant? And, my response at that time and now as CEO is that, we're 100% transplant focused. And really, when we were challenged upon that, what difference will you make as a company, right? And we said, what we want to do is improve that organ survival. And then how do you do it? Like, is it something that's theoretical? Is it something that's really real? And so for us, we said, if we know that there isn't always this standardization among treatments. And so that was really important for us to, as we led to AlloSure, to have this sort of protocol and surveillance to understand how do we get standardizations across different institutions. The other one is compliance adherence. Without a doubt, one of the major risk factors for not having an organ survive is if there isn't good medication adherence. And so this compliance adherence has been something that we've developed tools and actually been actively monitoring through services such as AAKP and our patient care managers. And then we talk about immunomodulation, either being oversuppressed or undersuppressed, can often lead to adverse sequelae. So for us, it's really important to actually make some investments in developing studies in this area. The point being is, if you have a strategy which is really to help patients and improve organ outcomes, then you really have to have a process and approach to do it and truly deliver on it and do it on good science. And that's really important for us as a company. And so we've heard about AlloSure, but AlloSure was something we brought more than 3 years ago, and we have moved on from there because the new innovation, and we're the only company in the United States that's had multimodality approval in transplant, and we showed that on the heart side at the end of last year, and now we're doing it on the kidney side because we want to continue to bring innovation for kidney transplant patients. And so what this does is combine technologies to increase the clinical utility for physicians, and so there's a more accurate test, and you get additional insights as part of that. And we demonstrate that on the heart side, and what we're now doing on the kidney side is similar, which is combining different technologies. Here we have the AlloSure, which is a donor-derived cell-free DNA, as well as AlloMap, which is a gene expression profiling test, which looks at the immune status of the patient, and then iBox, which is a prognostic algorithm. Now, what we've added since then, which you hear about more in the future, is three additional tests. One is called UrinMap, which is urine test, which I mentioned earlier, which is also looking at acute cellular rejection, but also a tissue test called HistoMap, which is the latest form of innovation which has come in the space. And then also we have a infectious disease test called AlloID. So what we want to do is bring multiple offerings across multiple modalities to bring incremental value, incremental clinical utility for the physician, so that ultimately the patient will benefit, and ultimately so we can change the fact that 1 in 5 kidney transplant organs will fail within 5 years. That's our mission and goal, to see how we can help. And so as we look at the patient engagement, and obviously we have so many patients across the globe that have dialed in today, we believe that you also have a role. And we have developed what we call our direct-to-patient approach, because we feel that we've brought great technologies, we have great relationships with the centers, but we want to develop that relationship with the patients even further. And so what we have here is just one example of some of the offerings we're bringing. This is called the AlloCare app, and it's something where you can do a couple of things. It allows medication adherence, and we talked about how do we improve that adherence. This is a way of ensuring compliance. The second area that this can help out is looking at different biometrics, which you can capture on a daily basis as part of this. And thirdly is including scheduling as you look at AlloSure. The important thing is we continue to add things to this app, and this can be used not only in post-transplant patients, but also in pre-transplant patients and across different organs. And I think as we've moved in this digital world post-COVID or during COVID, I think the more chances and interactions we have on a digital basis is so important for us. So we continue to work with patient groups to bring offerings. And just so you know, AlloCare app was designed and developed not by us, but by transplant patients, transplant centers, transplant physicians giving their input, and we put it together. So we're really proud to bring the AlloCare app, and this is something that it just has an incredible uptake since it was rolled out at the end of last year. And so one of the other offerings we have is RemoTrack, and this was something that during the peak of COVID last year in March at the onset, we had outreach from multiple centers and patients. CareDx, how can you help us during this time of COVID? Because we have to go into get our blood drawn or get our test, whether it's in a lab or whether it's in an out external phlebotomy, whether we multiple patients there, or maybe a chance where we now can no longer get our biopsies in some patient settings. And so there was an outreach of how can we help. And so within a matter of a week, we as a company were able to put together this offering called RemoTrack on a national basis of where we could help out this community and say, we will give you a remote offering, the safety of your house. And so blood draws could be done there. The important thing about this is a service that was asked for by patients for safety, asked for by the centers, and we as a company, without a thought for cost, without a thought of how we're going to roll this out, said, how do we find a solution? How do we find a solution? That's what we do at CareDx. I mean, if it's patient, we're patient focused and we're patient centric. And I think that's why conferences and meetings such as this are so critical to continue that patient story. It's so you all have an incredible voice, and that's one that I think you should continue to use. Of how can companies do more to partner with you? Because our goal is to be that leading partner. And so as we sort of conclude, this presentation. I want to again thank AAKP. I want to thank GW for this opportunity. It's the third meeting. I'm so happy to see this progress. But one thing you should know about us is we continue to embrace working with the transplant patient community, and we during this time of remote offerings, we've continued with patient education, and I think we've delivered over more than 20 different presentations and webinars during the course of the pandemic, and thousands of patients have benefited from these. And for us, once again, CareDx has been around for more than 20 years. We're going to be around for the next 20. Our mission is patient-driven. So thank you again for the time to talk about CareDx today. I'm extremely proud to be the CEO of this company, and because of the fantastic people we get to engage with. Thank you again.
Mr. Pseudo, we have several questions to ask you. How do you tell the difference between patient DNA and kidney DNA?
AlloSure uses single nucleotide polymorphisms, or commonly known as SNPs, to distinguish between the donor and the recipient. The SNP is a variation, that is a change among individuals at a single position in a DNA sequence. AlloSure looks at a panel of carefully selected SNPs and uses then an algorithm which is able to discriminate between donor and recipient DNA. And the important thing to note is, as we look at these SNPs, we look at changes across every single somatic chromosome. We're the only company that looks at these changes across all, and that's why it's so important to have this type of technology, but one that's been developed from a transplant basis.
Our next question: what happens if I am high risk for active rejection with AlloSure?
If you have an elevated AlloSure, it's not normal. There is something that's happening which could indicate a form of injury or could be a form of rejection. What typically happens is the physician will then do additional workup to exclude whether it's an infection, to do additional blood tests to exclude whether it could be a form of rejection. But this is really a way of telling you something is not right in what's happening, and that this measurement or this detection of this donor-derived cell-free and this elevation tells you that something is actually happening. So this warrants and requires investigation.
And Mr. Pseudo, one final question. What is the difference between AlloSure and my routine labs?
AlloSure really is the latest form of innovation and technology which allows you to actually detect forms of injury in the kidney much earlier and also more accurately. So if we compare that, for example, to creatinine, which is often a later test, and injuries actually happen to the organ already. So for us, it's really important if we want to improve the ability of detection of injury to a kidney transplant, then we need to be able to detect that injury earlier. And so that's why AlloSure is such a powerful diagnostic tool.
We appreciate Mr. Pseudo for taking the time to share his insights and expertise. Thank you.
We come together every day to help patients, families, and caregivers of all backgrounds as they navigate life with a rare disease. On this path, we know the need for treatment options is urgent. That is why our global team works with the rare disease community to identify, develop, and deliver life-changing therapies. In pursuit of this mission, we continuously seek to understand the diverse perspectives of rare patients and to courageously forge new paths that can make a difference in their lives and provide hope today and tomorrow. At Travere Therapeutics, we are in rare for life.
joining us for the third annual Global Summit, Global Kidney Innovations, Expanding Patient Choices and Outcomes, a collaborative partnership event presented by the American Association of Kidney Patients and the George Washington University School of Medicine and Health Sciences. My name is Glenda Roberts, and I am an AAKP ambassador for the state of Washington. Being a part of the AAKP has enabled me to elevate the patient voice in three ways: education, advocacy, and communicate with the community. As an ambassador, I'm able to raise the patient voice, not just my own voice, but it creates an opportunity for me to invite other patients and care partners to educate researchers, innovators, regulators, and investors about the needs and preferences of people living with kidney disease. So when I call on you, please say yes. I've also had the honor to serve with other AAKP ambassadors as we advocate with congressional leaders for policies and enhancements that benefit our communities. Being a member of the AAKP Speakers Bureau has created opportunities for me to tell our stories in a variety of settings intended to increase more organ donors and encourage more innovation. To remind us that as patients, we play a critical role both in the U.S. and globally in creating the demand for innovation and more choices because our lives hang in the balance, and to encourage our community to participate in research that drives those innovations and insights to produce better choices for people living with kidney disease. Professionally, I serve in a variety of roles at the University of Washington. I am the Director of External Relations and Patient Engagement for the Kidney Research Institute, as well as the Center for Dialysis Innovation. And I am also the Chief Strategy Operations Officer for the Justice, Equity, Diversity, and Inclusion Center, JEDI, for Innovative Research at the University of Washington. But for me, this work is personal. I was diagnosed with kidney disease when I had been out of college for less than a week. Many people know my story about how I used diet and exercise to slow the progression of my disease before I undertook therapies that included in-center hemodialysis, peritoneal dialysis, and transplantation. But what you don't know is when the doctor told me that I had kidney disease, I asked three questions. First, what caused it and how long had I had it? He said, I don't know, probably about 10 years. I said, what kind of kidney disease do I have? He said, I don't know. And then I said, well, how do we treat it? And he said, we start dialysis. Well, you all know that I took a different route. But I think the important thing here is that unfortunately, not much progress has been made in the last 60 years. This has been a one-size-fits-all approach, and my personal journey has introduced me to the importance of access to kidney care research and innovation, like those that are currently being investigated and pursued by the Kidney Research Institute and the Center for Dialysis Innovation. Today, I am pleased to introduce a wonderful friend and ally of AAKP, Dr. Jonathan Himmelfarb, co-director of the University of Washington Center for Dialysis Innovation, director of the Kidney Research Institute, a professor of medicine, and an adjunct professor of bioengineering. Dr. Himmelfarb is also the co-principal investigator for the Kidney Research Institute, or KPMP. KPMP is an ambitious, multi-year project funded by NIDDK. Its purpose is to understand and find ways to treat chronic kidney disease and acute kidney injury. But from a patient perspective, KPMP recognizes that kidney disease is not a one-size-fits-all experience. Its goal is to define the right treatment for the right patient at the right time. Dr. Himmelfarb will speak to us today about emerging research with global implications, identification and diagnosis of kidney diseases, the kidney Precision Medicine Project. Dr. Himmelfarb, we look forward to your comments.
My name is Jonathan Himmelfarb. I'm a nephrologist and a professor of medicine at the University of Washington. And I'd like to thank the AAKP for the opportunity today to discuss with you the Kidney Precision Medicine Project, which is a very exciting NIH-funded project looking for breakthroughs in kidney health. And I'm hopeful that we can find a breakthrough in kidney health together. Well, what is the Kidney Precision Medicine Project, or KPMP? It's a multi-year collaboration of many leading research institutions around the United States who have convened together to study patients with important kidney diseases that often lead to kidney failure. And our goal is to understand the mechanisms of the two most dominant conditions that affect the public health related to kidney function in the United States. These are acute kidney injury, or AKI, and chronic kidney disease, or CKD. The goals of the Kidney Precision Medicine Project ultimately are to identify new treatments and better treatments for the most common types of kidney diseases that will have the most impact on the most people living with kidney disease. In order to accomplish that goal, our plan is to ethically collect kidney biopsies from participants in the study who have these conditions, either acute kidney injury or chronic kidney disease. And with those kidney biopsies, we will create what's called a kidney tissue atlas in health and in disease to better define what's going on in the kidney that can help us identify these new treatments. And by doing this, we also hope to identify new subgroups, meaning of all the people with chronic kidney disease, for example, or acute kidney injury, can we classify each of these individuals in a way that will give a better understanding of what's really causing the disease for that individual person. That's really the goal of precision medicine. And critical to the success of the Kidney Precision Medicine Project, from the get-go, we have recognized the need for patient engagement in every activity. Patients really are at the core of the Kidney Precision Medicine Project. And patients sit on all of our important committees and working groups and are very active in defining how this whole consortium works. Now, how do patients fit into this structure of this complex research project, the KPMP? The primary mechanism is through what we call the Community Engagement Committee, or CEC. And this committee is central to almost everything that happens inside the KPMP. The membership of this committee consists of patients, scientists, and clinicians together. And together they deliberate on all the important issues in KPMP, and they advise every aspect of the consortium and of the work that gets done. They advise the leadership. They, again, are connected to all of our different committee activities. Many of the committees, when they're grappling with an ethical issue or a problematic issue, will say, well, let's see what the Community Engagement Committee thinks about that. So this has become perhaps the most influential committee in all of the Kidney Precision Medicine Project. And since the goal of KPMP is to conduct cutting-edge research in an effort to help patients, we want to design the study to answer the questions that patients have for us. And patients want to know, what do I have? What will happen to me? What can I do about it? And what does it mean for my family in many cases, as many kidney diseases have a familial or a genetic component. And most patients prefer what we call a precision medicine approach. And that means for a given individual person with kidney disease, what's the right intervention, or the right treatment, in other words, for the right patient at the right time, rather than one size fits all, where we would treat whole groups of patients the same and some would benefit from that treatment and some might not. What's the best possible intervention or treatment for me with my condition? That's what patients really want to know. And that's the essence of what we call precision medicine. Now, why would an individual with kidney disease want to participate in KPNP? Recognizing that this is a research project, it involves undergoing a kidney biopsy, so it involves taking some personal risk, where the goal is to provide information for the greater good. So this study really involves altruism. It involves people trying to help others and not necessarily getting personal benefit from participating in this study. In order for this study to be ethical, it's important that there be a rationale that makes sense for why somebody would want to participate in the study. And the rationale really has to do with what an important public health problem kidney disease is. We know it's now the 10th leading cause of death in the United States, that many millions of people, both in the United States and globally, have chronic kidney disease or develop acute kidney injury. And furthermore, most of the people who end up on dialysis or getting a kidney transplant, their disease was attributed to hypertension or diabetes. They're disproportionately African American. African Americans are roughly 12% of the US population and at least 33% of the population of people that end up on dialysis. So it's one of the greatest healthcare disparities that we have in our society. Many people of recent West African descent carry genetic risks that may account for that excess risk of kidney disease, and we want to be able to understand that to mitigate that risk and improve the health care for African Americans. For so many people that have kidney disease that's attributed to diabetes or attributed to high blood pressure, the standard of care does not include a kidney biopsy. So many people go through life knowing they have kidney disease. The kidney disease is getting worse, and their physicians did not recommend a kidney biopsy. So we don't really understand at the tissue level inside the kidney what's really going on, what are the mechanisms that are causing the disease process. We do know with acute kidney injury that these episodes that are increasingly frequent, especially among people in the hospital, that this can be very morbid and even mortal, cause mortality. And also we've learned that episodes of acute kidney injury, even when it seems like somebody has recovered well, can contribute very substantially to the subsequent development of chronic kidney disease, or for those people who already had chronic kidney disease, it can cause that disease to progress much faster. Unfortunately, there have been very few new effective therapies that have been developed for both chronic kidney disease and acute kidney injury in the absence of understanding inside the kidney at a tissue level. And that's the problem we're trying to address with the Kidney Precision Medicine Project. So to improve the public health, we really do need these research level biopsies for these very common diseases that afflict so many people. Now, there is risk to undergoing a kidney biopsy. And so our patients have concerns, and we, from the get-go of even thinking about this project, the National Institutes of Health convened panels of patients with kidney disease as well as ethicists to evaluate whether this study was an ethical study. And after a lot of consideration, the patient participants in the early phases and also now on our community engagement committee and the ethicists have all concluded this study is a highly ethical study. Even though there's limited benefit to the individuals who are going to undergo a biopsy and participate in the research, there's a very large benefit to society. That is only ethically okay if the information that we're going to obtain greatly exceeds the potential risks. And that means that we have to absolutely minimize the risks in every possible way for participants in this study. And we really have to honor and value every single person who participates in this study. As one of our patients on the Community Engagement Committee recently stated, the patient participants are the heroes of this study. So that's critically important for this study to be an ethical study, and that is embedded philosophically in everything that we do. We want to enhance safety, minimize discomfort, and minimize or eliminate any costs to individuals from participating in this study. Now, the issue of cost came up and was brought up by our patients on our community engagement committee, that if you are altruistically asked to participate in a study and you agree to in a study, and you undergo a kidney biopsy that may or may not have been medically advisable and may not be medically necessary, as a quote from one of our patients was, "It sounds unconscionable to put all the financial here altruistic kidney tissue donor." So we took that to heart, and perhaps as a first in its kind study, we have obtained a no-fault identification insurance to ensure that participants won't be penalized by participating in this study. As I mentioned on the previous slide, we want to do absolutely everything we possibly can to ensure participant safety in the Kidney Precision Medicine Project. That's especially centered around the kidney biopsy. And so we've gone to great lengths to create criteria and protocols in this study that'll maximize safety, minimize the chances for any harm, both prior to the kidney biopsy, during the kidney biopsy, and after the kidney biopsy. This includes creating biopsy checklists that are looked at immediately prior to the biopsy by having a safety adjudication committee and a data safety monitoring committee that looks at any complications that take place, and most importantly, by creating a culture for problems and addressing those problems sooner rather than later, ideally preemptively before any harm takes place. And I say with certainty that we're doing everything we can to ensure participant safety, and to date, participants have done very well in this study, and we also go through a process after the biopsy of surveying our participants to ensure their satisfaction with participating in the study. We value our participants very much. They really, truly are the heroes of KPMP. So with all the precautions that we're taking for this study, how do we expect to change the world for people living with acute kidney injury or chronic kidney disease? Well, biopsy tissue, this is a picture of how the work proceeds in this study really after the biopsy has taken place. What's called the clinical presentation, which is all the information from surveys and questionnaires and laboratory tests and looking at the electronic medical record. We amalgamate that data for each participant. We look at the pathology, the tissue, the kidney tissue under the microscope, and we use some very fancy digital techniques to really understand the biopsy tissue. And then we use really, truly state-of-the-art technologies to interrogate that biopsy tissue on a cellular basis to understand what's happening with every single cell inside that kidney biopsy that's either causing the disease process or perhaps accelerating repair. And then we will track clinical outcomes in the long term, and we'll use all these data sets together, tremendous amount of data. And that's part of why we value every participant in this study to create the kidney atlas that we talked about, these mechanism-based disease subtypes, to identify the critical cells, pathways, and targets so that people can develop better and safer treatments for the variety of kidney diseases. The consortium is a large consortium. We now have over 40 different major academic medical centers and literally hundreds of investigators working in this study collaboratively together, and all for the same common goal, which is to really understand and create new, better, safer, more effective treatments for the common types of kidney disease, acute kidney injury and chronic kidney disease. So we have a plan. We have many investigators at the leading medical centers throughout the United States working on this project. How does this project actually happen? What happens after a kidney biopsy has taken place? Well, in the middle panel here, you can see a typical kidney biopsy, which has the elements of the kidney, the tubules. You also see a lot of scarring in this particular biopsy, which is in the blue color. that you see right here. And then to the left-hand panel, you see how we can take every single cell in this biopsy and analyze what type of cell it is and what genes are being activated or what proteins are being activated in that cell. And then we can spatially localize that to where this is happening in that kidney biopsy. Is it in a period where part of the biopsy where there's scarring? Is it in a healthier part of the kidney? Is it part of an injury process or a reparative process? And then we can look at even more detail, as you see in the panel on the right, using something called electron microscopy, where we can not only look at cells, but each of the individual components inside a cell. So we have phenomenal technologies now to deploy and apply to interrogate these kidney biopsies to establish and accomplish the goals of the KPNP. And I'll show an example from one of our tissue interrogation sites here, which is from WashU St. Louis and UC San Diego. They're using a technology called single nucleus RNA sequencing, or snRNA-seq, and these are remarkable technologies that have been developed in the last decade, where you can take, as you see on the left-hand side here, the kidney tissue. This is a kidney here. You take the tissue and you break it down into the nucleus that contains the DNA from every single cell in the biopsy, and then we process this through these new assay technologies that have been developed, and we use these very fancy bioinformatic approaches to identify every single cell type in the kidney. And as mentioned before, we can then look at what genes are being expressed and upregulated or downregulated in each of these individual cells inside this kidney biopsy. And this is but one technique that we're using inside the Kidney Precision Medicine Project to interrogate these valuable research quality kidney biopsy tissue sections. Now, it's relatively early going in this study. This is intended to be a long-term study, but already we're seeing suggestions that this study is going to be a game changer. One thing that we're seeing is that in many of these biopsies that wouldn't have taken place necessarily for clinical purposes, even though we separate out clinically acute kidney injury from chronic kidney disease, when we look at the pathology, at the tissue under the microscope, and when we look at these single cell techniques and other molecular techniques to see what's going on in the kidney, there's some convergence. So although these are clinically considered separate syndromes, the same drivers of injury or the same drivers of repair we are tending to see, which suggests that there may be some therapies for one that would be beneficial for the other condition. We're also seeing that when seasoned clinicians look at these cases and all the clinical data and think they know what's going on, and then they see the biopsy that might not have been done for clinical purposes, in many cases, the pathology diagnosis is different than what people thought before the biopsy. And in some cases, although, again, participants are participating because they are altruistic and they're not expecting to have personal benefit from participating in this study, we're already seeing, in some cases, that the biopsy review is changing management for some individuals who are participants. So these are early signs. They're not definitive, but it makes us hopeful that this research project is going to be a game changer in the long run. One of the important principles for the Kidney Precision Medicine Project is we want to make this data available as a community resource for the entire research community. And in fact, beyond the research community, ultimately for patients and for clinicians as well. And so as soon as the data is validated and quality controlled and curated, we're putting that data into a data repository and making it available on the Kidney Precision Medicine Project database on our website. And already there's more than 1,500 dataset files, which many researchers are downloading to advance the cause of coming up with new treatments for these particular types of kidney diseases. And our thinking about this study is this data should be a community resource for many types of external stakeholders. So we also want to create tools, online tools, that we will put on the website that will make it easier for a variety of different kind of users to use this data. That includes patients as participants. Ultimately, we hope patients, even if they're not participants in KPMP, can learn from these data sets. Pathologists who normally look at kidney tissue under the microscope, clinicians who take care of patients, and then various kinds of researchers. So we anticipate creating the tools that will allow each of these kinds of stakeholders to obtain value from this community resource. This slide shows how you can access on our website the data repository if you want to download data. We have de-identified the data that's publicly available, which means it can't be used to identify the participants, but the data can be used to understand and to treat kidney disease, hopefully in the future. The goal of KPMP is to be inclusive and collaborative from the outset, and so we've created many different vehicles or mechanisms by which the data can be used by this large community, and we reach out as well to other research projects so that the data can be shared between them. It's our common goal to come up with better treatments, safer, more effective treatments for these common kidney diseases. I want to emphasize in closing that this project, the Kidney Precision Medicine Project, really is unique in the world of precision, in part because we have engaged the entire community, patients, clinicians, scientists, and ethicists from the get-go, from the outset, and in every aspect of what we do. And in this study, patients really are equitable partners who have an active voice in the entire research enterprise. The culture promotes priorities and safety of patients first, and we are addressing big public health problems that really most commonly lead to end-stage kidney disease or kidney failure. So if we can make an impact on these diseases, it will have a large impact on the most people that we could impact from a public health perspective. The Atlas has a clinical orientation, so it will teach us about the kidney and how it functions in health, as well as the kidney and how it functions in disease conditions. And we are creating next generation tools, including next generation digital kidney pathology, using very deep biological profiling with the tissue interrogation cytomics technologies, and also using machine learning and artificial intelligence to better understand injury and repair with these kidney diseases. So once again, I'd like to thank the AAKP for the opportunity to talk to you today about this very exciting research project that's in the early phases, but shows tremendous promise for the future. And our goal is really, truly impact the lives in a positive way of people living with these common kidney diseases. Thank you for your attention.
Thank you, Dr. Himmelfarb. We have a couple of questions for you. How has engaging patients as stakeholders in the design and execution of this research project proven invaluable?
Well, I would even take that question a bit further and say without active patient engagement and participation, this study couldn't take place. This study really does treat patients as equitable participants in the research in every different way. And in addition, our Community Engagement Committee, which consists of patients who are not enrolled in the study, but help us design the study, implement the study, and work collaboratively with every aspect of the Kidney Precision Medicine Project, every committee with the governing bodies. The patients on our Community Engagement Committee are just critical to the entire function of the entire consortium. So we are grateful for the patient participation, and beyond grateful, we recognize this study couldn't take place because of the nature of the study without the kind of patient engagement that we have been experiencing.
Dr. Himmelfarb, we have one more question for you. Why does the Kidney Precision Project matter to a larger audience of patients worldwide?
Well, kidney disease doesn't obey geographic boundaries. So if we take chronic kidney disease, for example, it's estimated that about 37 million people in the United States have some degree of chronic kidney disease. On a global level, it's estimated that about 850 million people have chronic kidney disease. So the proportion of people with chronic kidney disease globally is very similar to the United States. And the same is true for acute kidney injury. So if we can come up with better treatments, safer, more effective treatments for acute kidney injury and chronic kidney disease, if we can develop a better, more enhanced molecular understanding of the drivers of these disease processes, and we can classify these diseases better for individuals, it will ultimately help the public health, not just in the United States, but really the global public health as well.
We appreciate Dr. Himmelfarb for taking his time to share his insights and expertise. Thank you.
I had a lot of bad days with gout, but that one took the wedding cake. Even with medicine, my uric acid was still too high to stop painful gout buildup and joint damage. But then, my doctor recommended Krystexxa. That was a good day.
Krystexxa is a prescription medicine for adults with gout whose symptoms are not controlled by other gout medicines.
I found out that Krystexxa can start dissolving years of gout buildup within 24 hours of the first treatment.
Serious, life-threatening allergic reactions can occur. Tell your doctor right away if you have any symptoms during or after treatment. Krystexxa is not recommended if you have high levels of uric acid without a history of gout. The most common side effects were gout flare-ups, allergic reactions, nausea, bruising, sore throat, constipation, chest pain, and vomiting. Do not take Krystexxa if you have a rare disorder called G6PD deficiency or favism. Your doctor may test for this before you start Krystexxa.
I received Krystexxa for about 6 months. Now I'm in control, not gout.
Ask your rheumatologist about Krystexxa.
Good afternoon. My name is Paul Conway, and I serve as the co-chair of the Global Summit, and thank you for joining this session. This session is entitled Emerging Research with Global Implications, Advancements Toward the Artificial Organs, or in this case particularly, Artificial Implantable and Wearable Kidneys. Our first guest comes to us from the American Society of Nephrology, a longtime AAKP ally, Dr. Mark Lim, who serves as the Vice President of Research, Discovery, and Innovation at ASN. He also heads up the oversight of the project called KidneyX, which is a prize competition in the kidney space, which since its founding in 2018 has awarded 50 innovators with prizes for unique contributions in the areas of implantable dialysis devices, dialysis infection prevention, and other discoveries that have profound implications not just for patients, but also for their families, the research community, and the country. Mark is a really dynamic leader. He has a great background in the federal government, where he has overseen major research programs and major projects. He's a great patient advocate, a good friend of AAKP, and a really solid person in the areas of science and the production of complex solutions. Mark, go right ahead.
Hi, my name is Mark Lim. I'm the Vice President of Research, Discovery, and Innovation at the American Society of Nephrology. Really want to thank AAKP for this opportunity to present at the 3rd Annual Global Summit. Really to share both where KidneyX has gone and where we're planning to take KidneyX, with the goal of continuing to catalyze really innovations so that we have more options for people with kidney diseases. I'll be doing most of the presentation, but much of this presentation is on behalf of also Molly O'Neill, one of my colleagues who won't be able to join us today, who's the KidneyX coordinator. In terms of disclosures, both of us are full-time employees of ASN. Molly doesn't have any disclosures to make. I'm a non-paid voting member of the Scientific Advisory Board for the organization listed there. Particularly for this audience, it really goes without saying why innovation is needed for people with kidney diseases. I think the need for innovation was even more amplified during the COVID pandemic, in which really our patient community needed more innovations, both those on dialysis, those who are transplant recipients. So there's just definitely an opportunity for innovation, but there's also an increased need for different types of innovative tools, innovative drugs, innovative diagnostics. Fortunately, we've actually seen a wealth of innovations starting to come into the marketplace. Many of them are becoming tools that are available to both clinicians and to patients, both from, you can see on the left, from precision medicine, both looking at different drugs that are recently approved by the FDA, drugs that are also in the pipeline, as well as new diagnostics. On the right, you can also see just really a lot of innovations happening on the devices side, primarily for the ability of on kidney replacement therapy, where it's either portable dialysis, safer ways of doing dialysis, which you can see in the center, or even just the goal of actually having an artificial kidney. These are just some of the many examples of where innovations are really starting to come and become more available to people with kidney diseases. But unfortunately, if you look across in terms of the investment landscape, the kidney ends up being still kind of low compared to other disease areas. This is data that was kind of culled together off of 2 different venture capital databases, and we linked both what you could use as renal or kidney health to see what's in there. And you can see it's still quite low, whether it's renal, kidney health, or combined, over the years. Even though you do see a slight increase, it still does fall behind other disease areas. So for this reason alone, the KidneyX, also known as the Kidney Innovation Accelerator, was started a couple years ago as a public-private partnership between the U.S. Department of Health and Human Services and ASN, really to not just spur innovation, but really accelerate it in the prevention, diagnosis, and treatment of kidney diseases. KidneyX does this really kind of from 3 different pillars. One is we try to identify those innovations that have the greatest unmet need for people with kidney diseases, and we keep focused on that and being able to try to fill that unmet need. We take in kind of a partnership approach then to also kind of bring together networks and experts both through ASN and as well as with our other partnering organizations. And our third role is really to support those entrepreneurs along a pathway to the kidney patient, really all with the goal to sustain a robust marketplace so that innovations continue to come and become available to people with kidney diseases. So we take it from two different angles. One is looking at the kidney innovation just kind of an ecosystem. One is where we can take innovations that may have even been used in other areas such as cancer or cardiology and try to steer them towards those unmet needs that are identified. The second one is, when you have innovators already within this ecosystem, we want them to continue innovating, really focused on people with kidney diseases. And that's really within the role of what KidneyX does in addition to its other partners such as NIH and others. The second angle is to try to figure out a way and it's to de-risk kidney innovations. And of course, these two aren't necessarily separate pathways, but they're obviously linked. One is to address technical challenges, regulatory questions, and that's where we bring together scientists, our partners at NIH, our partners at FDA, our partners at CMS, as well as other global regulatory agencies and as well as experts to come together and see if we could start to anticipate where there may be regulatory science challenges and see if there's opportunities to bring the community to try to address them kind of proactively before the innovators kind of hit that potential bottleneck. The second one is really just by creating some more stability in the kidney innovation space is really to just get investors as well as potentially companies really excited about being involved and participating, contributing to the kidney innovation sphere. The first one, the addressing technical challenges, regulatory questions, is something that, at least for now, one way we're addressing it is through the Kidney Health Initiative, which I'll explain in the next slide. So as Ed mentioned before, the Kidney Health Initiative is another public-private partnership between ASN, the US FDA, and about 120 different organizations focused on kidney innovations. Really, the focus is to address regulatory science issues that could go anywhere from endpoint measurements, where there might be a lack of clarity or consensus on how do you measure both safety and efficacy of different novel tools or novel drugs. We also incorporate through the Kidney Health Initiative's Patient Family Partnership Council, a couple of different efforts to look at patient-reported outcome measurements and make sure those are also available to the community so that they can use those as part of their trial design or part of their research. One of the tools that has come out in 2018 is what we call the Technology Roadmap for Innovative Approaches for Renal Replacement Therapy. That is kind of predicting what patients and clinicians would need for kidney replacement therapy, both from a technology angle, and then trying to incorporate, since we have the chance to, also patient preferences. And you can see that there's kind of in this box on the right, both what we were able to work with these groups to identify and prioritize were different ways that patients want to see improvement in their quality of life. And it's a mix of the different technological approaches, whether it's enhancing dialysis, whether it's really shifting to portability, wearability, and you can see kind of it goes on to eventually, an artificial kidney, which I'll talk about a little bit more. The technology roadmap is something that really kind of sets a foundation for how we're going to monitor what happens in the future and also guide the innovator community along that roadmap so that both patients, regulators, researchers, clinicians kind of see the progress of technology development and innovation. Another good example of where KidneyX was trying to get more information in terms of what are the most unmet needs is what happened just last year with COVID, and it's still kind of continuing on this year. ASN convened a panel in collaboration with a lot of its federal partners, which you see on the right, as well as a couple of the dialysis and kidney care facilities, to look at what was happening during the first wave of the COVID-19 pandemic. So this workshop was held in July of last year, and some of the example findings, recommendations are listed there, which are relevant to like needs for innovation. One was hospitals estimated that there was about a 25% increase in the need for dialysis machines, just to make sure, based on what happened during the first wave and what they're anticipating in terms of future waves of the pandemic, One thing that's kind of repeated throughout the report, which is available on ASN's website, is that the logistics for managing both people, the machines, the disposables and consumables was a significant challenge. And there was a big call out for both supply chain, human resource inventory management systems, particularly since a lot of staff were also reluctant to remain in these COVID-19 positive rooms. So there's obviously a lot of opportunity here for innovations, and that's something that we helped support in terms of, or helped address in terms of one of our prizes. So this is an example of where we've gone up to this date. You can see from 2018, that was where our roadmap was published. And to support what was described in the roadmap, we had two different, what we call redesign dialysis prizes. You can see some of the winners that are on the right. We also had what we call the Patient Innovator Challenge to see, what are the different patient solutions. And you can see also some of the examples again, kind of on the map on the right. As I mentioned before, we saw an opportunity where we could look at innovations coming from patients as well as the care facilities to help support the safety and the resiliency of kidney care during the COVID-19 pandemic. And we had 15 prize winners that were just recently announced a couple months ago. Again, there's some examples to the right. And more recently, we just closed submissions for our first phase of what we're calling the Artificial Kidney Prize. I'll go into a little bit more detail about that over the next couple of slides. The artificial kidney is something that we see is inevitable as a technological solution, where, basically, we're looking at replicating the functioning kidney. We do know that, at-home dialysis is increasingly becoming a viable option, and, particularly reinforced during COVID, it's necessary for patients to make sure that they're maintaining their kidney care. Redesigned dialysis phase 1 and 2 addressed it. We're looking much more further down the line at the artificial kidney, which could be, you could kind of think in concept of both a wearable or an implantable concept that, and we're keeping open in terms of the multiple approaches that could be used, coming from the science and technology folks, whether it's in engineering or regenerative medicine, xenotransplant, or even just kind of keeping it open to, what are areas that just haven't been conceived yet, knowing that we have some time to see if those are solutions that can get us there. The one thing that's very different also in terms of mindset is that the artificial kidney, it requires a patient-centered design, and we are both aligned to our past roadmap as well as developing a roadmap to an artificial kidney. One thing to think about in terms of artificial kidney is you have to think about it almost like a drug, because it is a treatment. So you have to have that mentality of, who is the patient that would receive benefit? What is that utility and benefit for that patient? And we've actually seen kind of two different angles, which can still be connected. One is improved health outcome, as well as an improved quality of life. Hopefully we get both, but those are two areas that we need to kind of work with patients to better understand. And more importantly, what are the patient preferences for this artificial kidney? There's going to be some changes in lifestyle, whether they have to go in for maintenance, and what is that willingness in terms of a potential lifestyle burden on both themselves and their care partners? What is their access to maintenance services? Is there a place where they can get either, just to get it assessed, whether it's an artificial kidney, whether it needs to be, improved? That's an important part, particularly given that it's going to be something that's going to be potentially implanted or wearable. And then understanding the patient preferences, it allows us to understand what are the trade-offs in terms of risks and the benefits. Where are the risks too high that it's not worth going down? And where do the benefits outweigh the risks? And making sure we have patients tell us what that is. Obviously, the more practical side is we also have to kind of understand, from understanding which patients would most benefit, the reimbursement and out-of-pocket costs are something that we need to design in almost from the start to make sure that we're not designing artificial kidneys that are just too expensive for either the healthcare system or the patient that has to pay for it or their families. So as I mentioned earlier, KidneyX just closed its submissions for the first phase of the Artificial Kidney Prize just in March. We hope to announce the prize winners in September 2021 around a summit. We'll have details about that summit. It's publicly available to attend. In terms of the applications themselves and kind of our Really, this first phase was really to see what is who is working on what, and how far are they at, and really awarding prizes for those that have gone really moved the artificial kidney landscape further. What we were hoping for were integrated concepts. So we were hoping that we would actually see folks who are developing an artificial kidney, not just part of one. We were hoping for a diversity of approaches. As I had mentioned, we think the artificial kidney can be created by a multitude of approaches, whether it's mechanical engineering or cellular engineering, regenerative medicine, xenotransplant, and others. And we saw quite a diversity of approaches we were excited to see. I think more importantly, we were hoping for multidisciplinary teams, knowing that it's going to take a bunch of different scientific sectors to come together to create an artificial kidney. And we saw that. I think one of our last nice to haves was that we'd have international interest. And as you can see on the right in that map, we were able to get applications, some of them from around the world. You can see them highlighted in green. I think some of the smaller ones that you can't see were partners coming together from Israel and Singapore. So we were pretty excited at the interest as well as the broader artificial kidney community. We did receive 31 applications. Again, as I mentioned, several of them were big team approaches. We're right now in the judging and reviewing process, and look forward to announcing who the winners are in September 2021. This will be followed by a second phase, and we'll announce the scope of that second phase also in September of this year, with a March 2022 submission date. Again, all of this is to be confirmed. This will be in support of a $6 million total prize purse, in which we'll announce the winners exactly a year from when we're announcing the first one, September 2022. Our goal is really to start aligning what I had mentioned earlier about the Kidney Health Initiative's roadmap on the artificial kidney, and making sure that we're supporting the goals as well as kind of what was the aspirations of that roadmap. So I'd like to thank you and everybody for your time. Again, our goal on the right is to make that future state a lot closer. We know in order to get there, it'll require investments. We'll definitely need patience along the way to not only help design the artificial kidney and other innovations, but also tell us what other innovations are needed. We think, all of the approaches, particularly with artificial kidney, require a multidisciplinary approach. We do look forward to both your insight as well as your feedback. And your participation. Our emails were at on the last slide. Please reach out to us, either Molly O'Neill, who's the Kidney X coordinator, or myself over at ASN's Research, Discovery, and Innovation. Thanks again for your time.
Thank you very much, Mark, for your presentation. I have a quick question for you. Based on your background as a professional managing very complex solutions in the federal government and working with a tremendous number of private sector innovators, I'd like you to comment on how you see a global patient consortium that's coming together to drive and support innovation, how that can have an impact on the regulatory and payment landscape long before these devices make themselves available to patients in the marketplace. If you could comment on that, I'd appreciate it.
Yeah, that's a really good question. In terms of having the patient voice, the patients are the ultimate beneficiaries of all these innovations, whether it's a drug, whether it's artificial kidney, and we have to make sure that we're meeting the needs of the patient first from the beginning, and we only understand the patient need by having them tell us and describe to us not only what do they need, but how do we get there. Particularly with people with kidney diseases, the care partners are also very important. So it's not just the patient themselves, but also their social network. As we look at people with kidney diseases as well, there's also a need to understand both also the social network, their access to services, their ability to pay, or the willingness of payers to pay for these different options. It's not just telling us what is needed, but it's also important to have the patient voice throughout the whole process to make sure both the innovators are still addressing the patient need and not, I'd say, shortcutting the prioritized preferences so if cost is important, if ability to access services from their home is important, we have to make sure that these innovations continue to also address those needs, not just from a biological perspective, but also just, I would say, both a benefit and an ability to take advantage of these options. And if we force a patient to significantly change their lifestyle to adopt a new innovation, I'd say we're probably starting off on the wrong foot.
Thank you very much, Mark. We appreciate your time and the full support of the American Society of Nephrology for our efforts at the American Association of Kidney Patients and for the Global Summit. Our next speaker is Dr. Shubha Roy, who comes to us from the University of California at San Francisco, where he serves as a professor of the Department of Bioengineering and Therapeutic Sciences and Surgery. More importantly, he serves as the head of the Kidney Project, where he works alongside Dr. William Fazell of Vanderbilt University on an artificial implantable kidney. He's quite the patient advocate, a very good friend of AAKP, and we actually partnered as an organization with the Kidney Project in 2018 because the American Association of Kidney Patients believes so strongly in the advancements of science and innovation and for a future that includes artificial implantable organs, namely the kidney. Dr. Roy, go right ahead.
Thank you, AAKP and George Washington University, for the opportunity to provide an update on the Kidney Project. This update will cover some of the recent developments as well as the background on the Kidney Project that has set as its goal the development of a new technology to treat kidney failure. As you can see, our goal is to develop an implantable bioartificial kidney. What is this? This is a compact device that is surgically implanted in the abdomen to provide continuous treatment, and it combines a hemofilter unit to remove toxins from blood with a cell therapy unit, which we call the bioreactor, to provide the other primary functions of a healthy kidney. It operates continuously, as I have mentioned. Because it's implanted, there are no external connections. It allows for total freedom of mobility. By avoiding the through-skin connections, we minimize the risks of infection from outside. Because the bioreactor has kidney cells, it will provide more physiological therapy than dialysis would. And because the cells are protected inside the device, the patient's immune system and the cells are separated from each other, which means there is no need for immune suppression drugs. And the device can be instrumented with sensors to not only monitor its function, but also report on the status of the patient's health. The idea of the implantable bioartificial kidney is that it would get surgically implanted through a surgical procedure not very different from a kidney transplant, connected to the blood vessels, and then the waste would be directed to the bladder to pass out as urine. And this vision of the bioartificial kidney has driven us over the last decade to advance the technology to make this happen. The work we are doing here is building on the pioneering cell therapy work that was conducted by Dr. Humes at the University of Michigan in the late 90s and early 2000s. What he did was to actually take conventional dialyzer technology, dialyzer filters, dialysis machines, except he connected two of them together to mimic the architecture of the kidney's nephron. The filter to remove the toxins in the kidney is called the glomerulus. Here we call it the hemofilter. Blood comes into the hemofilter, generates ultrafiltrate, which is then directed to the next stage of the device, which we call the bioreactor, which mimics the kidney's tubule. The bioreactor is lined with kidney cells that perform the primary functions that a native kidney does. And these two components together provide more complete renal replacement therapy. So we are mimicking the architecture of the device that Dr. Humes developed over 2 decades ago, but making it available for the larger community that needs to be treated continuously and at home for kidney failure. So this is the fundamental question that we've been working on, is how do you take the renal cell therapy work that Dr. Humes did, which is being implemented here on the left side of the screen, and make it an implanted continuous therapy device for the vast majority of chronic kidney failure patients, which is shown on the right. And this is what we call the Kidney Project, and that is the effort that has driven our team over the last decade and a half. And the approach we are taking is an engineering solution. What I mean by that is that we are taking the known knowledge that's out there and meticulously integrating it, refining it, optimizing it to create a device that can provide therapy. We took this approach because, unlike discovery science, which requires elements of chance and requires a lot of fundamental discovery time to get to a meaningful result, the engineering solution allows us to bring a talented team together and get to a solution that can provide treatment in a shorter period of time than most discovery science-based projects. Here you see a slide of a rover that will go to Mars and a team of engineers and technicians putting it together. It does take time. It does take resources in terms of money, but fundamentally, once it's done, it's going to go to Mars and it's going to work. It's not waiting for a new principle of physics or chemistry to be discovered. And we contrast this to some of the other basic science approaches that may result in a breakthrough, no doubt, but may take a much longer time to get to patients. The fundamental technology we are using to miniaturize the concept of the renal cell therapy device that Dr. Humes demonstrated at the University of Michigan over 2 decades ago is what we call silicon nanopore membranes. This is a technology that has been adapted from semiconductor microelectronics. The same technology used to make your phones, your laptops, and the like, and you can use this technology to precisely create a new membrane geometry that outperforms the conventional membranes that are used in dialysis today. Because of the precise geometry, you can have a membrane that is highly selective. Toxins from blood, just as your normal kidneys would do it, and it's highly permeable. What that means is that it requires very little energy to achieve that filtration, such that you actually do not need electromechanical pumps. You can run this just off the body's own blood pressure alone. And because it's silicon that can be modified on its surface by surface chemistry techniques, you can make it highly biologically compatible. So this technology, the SNM, as we call it, allows for a biomimetic filter unit that can operate with just the body's own blood pressure without the need for significant energy driving requirements, and can be operated for a long time inside the body because it's biocompatible. Now, I will take the opportunity to share a video. This video will showcase some of the research highlights that my team have worked on over the past few years. This video is from the lab of my colleague, Dr. William Fizel at Vanderbilt University Medical Center, and it showcases the research work that has to go in towards the development of an artificial kidney, in this case, both the mechanical filter and the cell therapy unit. Please watch.
The future is looking brighter for patients with kidney disease. Not only are new medicines and treatments slowing progression of disease, but new treatments for kidney failure are coming soon as well. Researchers have made breakthrough progress growing kidney cells in the lab for cell therapy of end-stage kidney disease. Long before researchers grow new kidneys in the laboratory or transplant them from animals into people, a combination of cutting-edge nanotechnology and living kidney cells will free patients from the tether of dialysis and provide the benefits of kidney transplant to everyone with kidney failure. Let's see how this universal donor kidney works. Kidneys filter the blood to separate wastes from healthy blood and then concentrate wastes from the whole body into 1 to 2 liters of urine each day. The biohybrid kidney does exactly the same thing, unlike dialysis with its heavy machines and batteries and gallons of water, which can never be implanted.
The cells that make up the kidney's filter are extraordinarily fragile, and leakiness of the kidney's filters underlies almost all of the kidney disease that results in kidney failure and the need for dialysis. Those cells are exceptionally fragile. They do not grow in the dish.
So Dr. Fizel and his team designed a new kind of artificial filtration membrane based on the size and shape of healthy kidney cells. This membrane is the first completely new technology in renal replacement in over 25 years. The collaboration with Dr. Shuvo Roy allowed this idea to progress from concept to FDA application. However, it's not just the kidney's filter cells that misbehave. Most human cells really don't look or act in a lab dish the same way they do in a healthy person. The tubule cells that concentrate wastes from the whole body into a little bit of urine don't reabsorb salt and water and don't excrete toxins when grown in an artificial environment.
This isn't just a problem for artificial kidneys. Drug companies can't use cells in a dish to test for efficacy or toxicity.
And medical doctors have to use entire animals to examine mechanisms of disease and effect of treatments. Solving the problem of cell culture stress solves many problems. Dr. Fizel felt that part of the problem was that cell culture was vastly different to a healthy body. Plastic lab dishes are hard, human tissues are soft, kidney cells have fluid flowing over them. Cells in a dish are still. We culture kidney cells with serum, but in the body, the cells don't really get exposed to serum. Dr. Fizel started testing these simple factors one by one and in combination.
Testing these factors, it's like a centipede driving a bus. If there's 75 feet on the brake pedal and you take 1 foot off, the bus still doesn't go forward.
The cells certainly look different on soft materials than on hard plastic, but they didn't seem to reflect these changes in the proteins they expressed, the key proteins. Enter serendipity. Rachel Evans runs the cell culture in Dr. Fizel's lab, and she had tested one batch of cells seeded on soft materials to see if they were making proteins to reabsorb sodium, and they were not. However, she had kept a second batch of cells to test if something went wrong with the first tests. She kept changing the cell culture medium on them until a few more weeks had gone by. Far longer than most people grow this kind of cell in the lab. She ran the test again on these cells that had been in the dish for weeks, and the cells had started to make the sodium exchanger proteins, a basic function of natural kidney cells. From there, the team went on to examine the signaling pathways that governed the response to soft versus stiff materials. By manipulating those pathways with drugs, they were able to coax the cells into pumping salt and water just like they do in a kidney. From the start of the project, we have tried to improve on what we accomplished to strive every day for a better life for patients with kidney failure.
70 years ago, we treated polio with an iron lung, but medical advances have put the iron lung out of the clinic and in a museum, and we strive to do the exact same thing for dialysis machines.
I hope you saw the range of disciplines, the amount of work it takes to build components of the bioartificial kidney. In this slide, I focus on just the mechanical part. You may recall the little silicon membrane that was referenced in the video. Here, we are now talking about moving it from a small filter unit towards something that would get closer to patients. On the top left, you'll see a photograph of a mini prototype of a filter. And on the right-hand side is a schematic showing where blood goes in and out and where the ultrafiltrate comes out. And we have spent time to design, optimize this device so that it can be operated in the benchtop and preclinical settings. Here, we've actually implanted that device into this animal, and you see a catheter sticking out. So we can test the performance of the filter after implantation. We ran that filter through a dialysis machine on the outside. Note, the filter is already implanted. The little tubing that you see is the catheter that goes to the dialysis machine. And we are able to run dialysis in this animal over the course of a few days. Some key points. There was no external blood pump. There was no blood outside the body, but we were able to perform hemodialysis. We did not need to use systemic anticoagulation like heparin. The design of our filter and the coatings of the filter are optimized such that the blood flows without causing thrombi or blood clots. And as such, when it was not connected to the machine, the pig, in this case, was able to move freely and drink freely. And what you see on the right is the data over the course of 3 days. And you should note there's no loss of albumin, no loss of protein over those 3 days. We did have a urea and creatinine clearance that was comparable to commercial dialyzer filters. But again, we did not use a blood pump. And there's a slight decrease on the 3rd day for clearance. This is very exciting for us because it shows us that we can make a filter that can operate just under the body's own blood pressure without systemic anticoagulation and provide toxin removal from blood, making us excited that we can build the hemofilter component of the bioartificial kidney. So next we looked at the cell therapy unit, which we call the bioreactor. You see a schematic of the bioreactor on the left and being implanted on the right. And what you're seeing in the middle are the cells that are put into the bioreactor. Each of the little gray squares that you see on the right-hand side are human kidney cells that were isolated from a cadaver kidney and grown in culture and then inserted into this bioreactor device. We put the bioreactor device into the animal and closed up the animal. And the cells in the bioreactor were kept in the animal for 3 days. In this case, we implanted the bioreactor in the region in the neck so we could monitor any potential complications readily via ultrasound. And what you see on the right is the cells have grown and are alive after 3 days of implantation. Why is that exciting? We've actually put human kidney cells in our device and implanted that into a pig. And we did not need any immunosuppression drugs. If we did that without our device, all the cells that we would implant would die because the human cells and the pig's immune system would reject them. But our membrane has the capacity to provide immunoprotection. And by protecting the cells, you can avoid the need for the anti-rejection drugs. And just like the hemofilter, we again did not need heparin or other anticoagulant drugs, and the device operated just under the pig's own blood pressure. So we now have taken the advances that we've learned from the filter by itself and the advances we've learned from the bioreactor by itself, and now we have embarked on the next stage in our journey. That is to integrate the filter unit with the bioreactor unit. What you see here is one of our first prototypes showing the filter and the bioreactor integrated together into a prototype implantable bioartificial kidney. The top half is the filter, the bottom half is the bioreactor. And there's silicon membranes, the S&M, and the cells to provide both filtration and cell therapy. I should stress, this is a prototype and it's a mini-scale prototype. It does not have enough membrane area or enough cells to provide sufficient treatment for a kidney patient yet. So there's more work to be done, but it shows that we can actually build them and integrate them together. Here we show the timeline of the kidney project from early stage conceptualization in the early 2000s, where we basically looked at the work that was done with the external renal assist device, the renal cell therapy device. We developed the silicon membrane technology and showed its proof of concept. And then we moved into preclinical work and optimization, where we deconstructed the project into a bioreactor development portion and a hemofilter development portion. And you can see for the bioreactor, we took on 3 key tasks, and for the hemofilter, we took on 5 key tasks that were successfully completed last decade. And now we are finishing up the bioreactor and moving into the integration phase. It is not trivial to integrate, but we'll have to integrate the 2 components and also scale up the device. What does that mean? It means we have to put sufficient cells and sufficient membranes to provide renal replacement therapy. It's not discovery science, it's engineering optimization. It does take time, and there will inevitably be areas we need to refine our work, but we are very hopeful that these are all tractable issues. Once we've shown that we can integrate the device in us and provide therapy to a preclinical model that has compromised kidney function, then we can move on to thinking about the first human tests. I show this slide and also point out the challenges. One has been the unusual past year of the pandemic. It has impacted our supply chain, it has impacted the pace of progress, and we are very fortunate that now we're beginning to come out of that and ramping up the pace of our work. We're also challenged by the need for funds. This work is obviously meaningful to many of the patient community, many of the physician community. Unfortunately, we are not at the stage that we are readily accessible to the investor community because they feel like we need to develop our technology further and demonstrate its feasibility in humans. But we are also challenged by being further out than the basic science proof of concept, which is where traditionally research projects get their grant funding either from NIH or National Science Foundation. So we try to work creatively with funding agencies, with donors, with patient groups like AAKP to encourage the resources to come to projects like ours so we can get this done and completed and advance towards patients in the coming years. I will end by saying that the progress we've made to date is due to a number of resources and people. So we have received early stage funding from the National Institutes of Health and other federal agencies. We've been fortunate to also been able to attract foundation funding and also donors, small dollar donors to some larger dollar donors that have continued to support us to move the project forward. But we need to be able to get this done. To get this done, my colleague, Dr. William Fizel, shown on the top right, and I encourage all members of the AAKP community to reach out to the various stakeholders and encourage them to support mechanisms that will allow us to complete the development of the implantable bioartificial kidney. We have a great team. I encourage you to check out our website, and thank you so much for this opportunity.
Thank you very much, Dr. Roy. AAKP enjoys our partnership with the Kidney Project and your longtime support for our efforts here at the Global Summit and as the nation's largest kidney patient organization. Our next speaker is Dr. Vic Gura. And Dr. Gura is the founder of the Wearable Artificial Kidney, or WARK. He is also coming to us from Cedars-Sinai Hospital, where he has directly treated kidney patients and knows full well the burden of kidney disease on individuals and their families. And this is why he has been a champion and an innovator of artificial wearable organs and artificial wearable kidneys. Dr. Gura understands that treatments must align with the aspirations of patients. And that's why he has taken so much of his personal time and resources and invested them in solutions that are tailored for patients. Dr. Gura is joining us by video in a rebroadcast of a presentation that he gave to AAKP late last year. This broadcast has been extremely popular with patients around the world, and it provokes some pretty interesting questions about the feasibility of wearable kidneys, how patients are demanding solutions that are not in a dialysis center, and the great work that's being done by engineers and modelers around the world in efforts similar to Dr. Gura's to try to bring this solution to bear for patients. Dr. Gura, go right ahead.
I would like to thank AAKP and the University George W. AAKP is a wonderful organization, and it's a very good channel for all the patients to have some say or some organized input on the issues that are affecting them and the rest of the nephrology community. So I think that the folks that take the time and their efforts to do that are doing a fantastic job. I also want to thank Dr. Raj Dominic from the University of Washington for his leadership in doing a great organization and a great nephrology division. Let's get started now with my disclosures. Here are my disclosures. A wearable artificial kidney, why do we need it? How does it work? Does it really do the job? And those are the main questions I will I'll try to answer. Why do we need it? When I'm in a room telling a patient that dialysis is necessary, it's a very difficult time for me, for the patient and the families, their friends that are around, hopefully, in this difficult situation. And the questions that usually come up are, what can I expect? How long do I have before I'm gone? Does it hurt? Can I work? Do I need help? Who's going to pay for this? And my answers, the answers of any practicing nephrology for these questions, are unfortunately not very good. So what are the unmet needs in dialysis, and what are we trying to accomplish? We want to reduce the mortality, improve the quality of life, reduce the cost, improve access to the technology, and make life and care more simple, because it's a quite complicated endeavor that inconveniences the life of the patients when they have to start doing this. So here is a list of all the many problems that affect the life of a patient when they are on dialysis, with sitting on the chair, doing time, the pill burden of swallowing a large amount of pills, fluid restriction. If they drink too much, we have to remove a lot. If we remove a lot, they cramp. If we don't remove enough, they choke with water in their lungs. They go a lot to the hospital. Most of the patients on dialysis are fatigued, are disabled, and cannot hold a job and be gainfully employed, and most of them have problems with even doing their activities of daily life. So these are things we want to solve in a wonderful document called the Roadmap for Improvements on Dialysis that has been developed in the community. These issues are clearly stated and are the guidance of we need to solve these things. And I can tell you here now that the WAC solves most, if not all of these, quite successful, and I hope I will make that point now. In the roadmap, we want to have a improved volume control, no sodium retention, less hypertension, no hyperkalemia, no metabolic acidosis, improved serum albumin, improved sleep patterns. We want to reduce or eliminate the need for pills and phosphate binders, improve appetite and nutrition, decrease need for blood pressure drugs, and decrease morbidity and mortality. Well, this was written by a kidney doctor. But if you ask the patients, the order in which these things are spelled out is a little different. Patients want more quality of life. They care more about how they live whatever time they have than not necessarily how long they have. We have to respect that as kidney doctors, but the idea is that as a physician, I confess that's what I am, I believe that if we address these issues, each one of them, when it gets solved, then quality of life improves. And I'll discuss that a little bit further. So lately people say, well, why don't we do this at home? And if we do it at home, people will be better off. And if we also would dialyze more frequently, longer, we can improve quality of life. But the way dialysis is structured today, you simply cannot do more dialysis unless you're doing it at home. And if you live in Beverly Hills with 5 bedrooms and 2 people, you can definitely put more than one machine in your house. But if we are 5 people in 2 bedrooms, then it becomes a little bit more complicated. So those of us that sit around saying, oh, we have to do more dialysis at home, I would like to tell you that it's simply not doable to the extent that the powers to be and the organizations want us to, because the technology doesn't allow it. You need more rooms, you need more space, you need water. Many people want somebody to assist them because the technology is complicated, or because they don't feel very well with doing it and they want somebody around. And we don't have enough nurses and technicians. And if we want to expand the amount of dialysis chairs available in dialysis units, there's no political or budgetary ability to simply double the amount of dialysis clinics that we have so people can come more open. let alone the fact that patients don't even want to go to more often to a dialysis unit to begin with. They want their life back to do what they want to do instead of sitting around in a chair. So we said, well, how can we solve this? And I've shown this slide many times, and forgive me for being repetitive, but this makes the point. If we miniaturize things like the clock to the wristwatch and the big computer to a more powerful device that is in the palm of your hand with a smartphone, we should convert a big machine that weighs a couple of 100 pounds, is operated with an electrical outlet, and requires 40 gallons of water per treatment into something that people walk around with. So we did that, and we went from the large machine to a belt that you could walk around with and work the batteries. So this belt worked with blood in red that comes through a pump into the dialyzer, and then in blue it goes back into the patient. The dialysate in green goes into the dialyzer, comes out in yellow. It's regenerated and purified through those yellow circles that contain chemicals that cleans the dialysate, and it keeps going in a loop. This way, instead of using 40 gallons of water, we went to 300 cc's, and this was the diagram of the WAC in its second version, version 2.0. This is version 1 that was trialed in an animal in Cedars-Sinai. This is version 2, and the first human trial was done in Italy with Professor Ronco in blue. And in the middle, you have a patient that was strolling in the park. This is a little park in the Vicenza Hospital where Professor Ronco works. And in the slide above, in the picture above on your right, you can see mother and daughter both on dialysis. Mother with a regular dialysis machine like we have today, and a daughter with the version 2.0 of the wearable artificial kidney. The second human trial was done in the United Kingdom, and we have patients that are wearing the device and walking around. With the tie on, there is the late Hans-Dietrich Polashek, a most gifted engineer that mentored us and helped us a lot to bring the WAC to where it is today. And Professor Andrew Davenport, the gentleman with the butterfly tie, and he was another great mentor and collaboration that we are very successful to collaborate with. And then we did the first FDA trial in Seattle with the help of Jonathan Himmelfarb and a wonderful team in University of Washington. And here is the first human beings in the United States, and the first woman in the United States dancing with a wearable artificial kidney while getting dialysis, not sitting in a chair, not attached to anything. And this is the WAC 2.0. So this is the WAC 2.0, and when we use it, patients told us it's too heavy, it's 11 pounds, it's still not small enough. And although we were very happy with the lady in the blue box in the bottom, in the sense that we proved that the concept is doable, but there were still ways to go because patients were still not willing to walk around with this device and move around. So we learned in London that in 8 hours we removed all the toxin indicators that we needed to remove quite efficiently in 8 hours. and we removed enough urea and creatinine over 8 hours. So we said, well, if we can do this over 8 hours, why do we need more equipment to keep removing this over 24? So we went back to the drawing board and we said we're going to have a day version in which we remove the heavy components that you can see here on the bottom. And we went from 11 pounds to 2 pounds. To that end, we also had to improve the device. On your left is the old WAC pump from the version 2.0 that gave us a lot of technical problems. So we kept going to the version 3, and that in the middle is pump 3 of 18 pumps we kept building and improving until we came to what you see on the right hand side, where we have the latest version of the WAC pump, which is fundamentally different from what we had in the 2.0, and it gave us a lot of advantages in how the device performs. So going to the drawing board, we said, okay, how do we make this smaller and more convenient for the patient? So this is one of the several sketches that we're starting to redo the WAC from the 2.0 to the 3.0. And we came up with a daily version that you wear around during the day. It weighs 2 pounds only, but it has a blood coming from the patient from the catheter into the dialyzer and going back, and the dialysate goes into one canister of sorbents, and then it goes back to the dialyzer in a circle. And this bag that contains the extra fluid that is removed is out of the bed. And we'll show you what happens when this is outside of the belt but still hooked up. So during the night, the belt hooks up to the 3 containers of chemicals that do the job that needs to be done in 8 hours. So these 3 guys work over 8 hours to do what they need to do. Thanks to the new pump, our rate of removal of fluids is going to be much more effective. And then we started to play around with different models on how this is going to look, looking at different things that people put on their own bodies. We looked at belts that people put things in, and we even looked at a dialysis patient that hopefully might have a wearable kidney on a backpack and go fishing. I do not believe that the 3.0 will allow you to do that. Maybe another iteration, but at least I want you to know that we were thinking of how we do return to the patients in normal life, where you can go fishing if you want to. You can go. I'm not sure I can bring the WAC to scuba diving with the WAC on, but that doesn't mean we cannot try. And we look at different models of things that people put in their bodies to carry things, from a holster to carry a gun, to vests that can be worn in the field, and we even looked at different possibilities as where in the body you put what. And at all times, what we wanted is to give patients normalcy on how to do things. So we did a mock of the WAC in its version 3.0, and here we have one of our beloved designers. This is Lance, who did a fantastic job, and you'll see that. And we look, how can we give normalcy so you can move around, walk around with this, hopefully wear it under your shirt, so it's not obvious for people to see this. Many patients have expressed that they don't want to be seen with the device on their body walking around and people pointing fingers. We have to respect that. So with that in mind, we work a lot to see how we can make it not only light but discreet to allow normalcy. And we try to figure out where do we put what. So I told you that the waste bag with the pump that puts the waste into that bag are out of the belt. So they hook up here, but they can go in your pocket or in a table when you don't want to remove fluids. So this gives to the patients the ability to remove fluid if and when they want to. So it gives flexibility and choices to how to do this. And I'll explain that about the choices a little bit further. So this is one model, mock model that we produced with our designers of how the wearable will go. And you may notice that the parts are to the sides, so the person wearing this can bend forward without the impediment of these things in their belly. And we do need some suspenders so this doesn't fall. And you may notice that the catheter with blood, even though it's placed in the chest, like usually it's tunneled under the skin and goes and exits here, so you don't have a line of blood that can get entangled with things. And then you can open this and remove components as we would train the patients to do, and this is very easy. So it doesn't need a lot of manual dexterity or issues. And the fluid removal is done by a little pump with the bag, and you can roll the bag when it's empty and put this in your pocket. Now, if you have an elder patient in a nursing home, it doesn't really matter too much. But if you're working in your office, you can hook this thing up here and remove fluid. Then you want to go to Starbucks, you unhook this, the bag is now full, you go to the bathroom, empty the bag, you have your coffee, and this is not hooked up, so you have less weight on you, and you can go to the bank or to your Starbucks or to walk in the park, and then you come back to your office and you hook this back and keep removing fluid. So it gives patients choices on according to their lifestyle. If you have an elder patient in a nursing home, probably it doesn't matter too much. But if you're an active person that wants to have a significant life and do significant work, then this is a great advantage. This is an elder patient in this modeling that hooks up the night module during the night when he is asleep. But this lovely guy is here watching TV, removing fluid when he's at home, and then when he decides that he needs to take his stroll in the park or go to the bank, he takes this off, and when he comes back home, he removes fluid again. And for the purpose of showing you this, we have to do it above the shirt, but we will strive to make it small enough so it goes under the t-shirt, under the dress, under the garment, so they don't have to be exposed to other people noticing this if they don't want to. People may choose to wear the device like this, and it allows quite significant amount of activity. For elder patients, you can, if you're younger enough and you hold the your whack under your t-shirt as opposed to above the t-shirt, but if it would be under your t-shirt, you wouldn't see this. And you know, you can go and take a hike, so to speak. And at night, you can put it with a night module inside a pillow or a teddy bear. And what are the advantages that we have for these patients? I mean, so, okay, it looks nice. Does it do the job? So this is a table that would take me a long time to discuss. But the advantages is that we remove enough fluid so patients can drink whatever they want, whenever they want. And we can remove it. They can eat all the salt they want because this thing removes enough salt. So you can add salt to have a normal meal. We have shown in all the trials we've done so far that we remove enough phosphorus to make phosphate binders obsolete. So you don't need phosphate binders, and this has more than one profound effect. And if you don't have fluid overload and you don't have a salt overload, it stands to reason that they will not have swelling of the legs, shortness of breath, pulmonary edema, and go less to the hospital. You don't need needles that are painful, and most patients I know don't enjoy getting too thick needles stuck in their arms at all times. So those are some of the many advantages of this device. So patients can eat whatever they want. This lady was wearing the WAC in Seattle, but she could eat pizza, French fries, and drink cola to her heart's content. This is a trial of WAC 2.0, and you can eat a banana or cheesecake. This lovely guy is walking around eating whatever he wanted and no need for phosphate binders. Let's talk about money. As stated by our good friend Eli Friedman, the world cannot afford end-stage renal disease. It's unsustainable. And some of the economic advantages of the device we're bringing in front of you is savings of whatever. The last time we looked at this is already close to $6.5 billion a year in just making phosphate binders obsolete. The charges for phosphate binders are about $900 per month. And if you do the math today, you go to $6.5 billion in savings just in making one drug alone obsolete. So we would have less hospitalizations, less hypertension, less cardiovascular disease, no phosphate binders, and a numerous amount of economic advantages with this device. So this lady would be wearing this under her shirt, and we went from where dialysis is today to the 2.0 to what we would like to see in the future. And this is what we are doing, not in the distant future. This is what we're building as we speak. Hopefully the trial of the device, similar to what you see in this picture, will occur still this year. And this is not the brainchild of Victor Gura. There are numerous excellent scientists, technicians, nurses, physicians that have been collaborating over a very long pathway to bring this to where we are today. And this is my time to thank them and you for listening.
I'd like to thank all of our speakers today who spoke to the issue of artificial implantable and wearable kidneys. The fact is that innovations are happening here in the US and around the world. And this is very important for those who have been impacted by kidney disease, and especially those who face kidney failure. Not everyone is eligible for a kidney transplant, and far too many people wait on the organ donor list, waiting their lives for a kidney to become available. But for these people who are suffering and for their families, it's very important that innovation move forward and that we bring artificial organs to the forefront and make them accessible in the consumer market. The individuals that you just heard from are some of the leaders of that effort, and we are quite proud as AAKP and George Washington University to be working so closely with them and to have them here today with us at the Global Summit. Thank you.
Thank you for joining us for the 3rd Annual Global Summit, Global Kidney Innovations, Expanding Patient Choices and Outcomes. This is a collaborative partnership between the American Association of Kidney Patients and the George Washington University School of Medicine and Health Sciences. I'm Lana Schmidt. I'm an AAKP board member, I'm on the executive committee, and I'm an AAKP ambassador. As an 18-year kidney patient warrior on dialysis for over 13 gruesome years, and now a 5-year kidney transplant recipient, I know firsthand what it's like to try and get your head wrapped around the idea that unless you get a transplant, there is no other option except to stay on dialysis until you die. A very sad reality. We need a surge of research into kidney disease and transplantation to stop patients from uselessly suffering and prematurely dying because we don't have the proper medical care in place. Kidney patients have started to speak up about their need for improved medical care, demanding more research and more options to receiving a kidney transplant so that they can have a productive life. Being part of AAKP has offered me the opportunity to have my voice heard and raise kidney awareness from a patient perspective. I've been able to publish articles in magazines and newspapers, conduct TV and radio interviews, speak on kidney disease issues, participate in webinars, meeting with my congressmen and my senators on Capitol Hill and virtually, being a part of research studies, and so much more. Join AAKP, whether you're a kidney patient, a caregiver, a nephrologist, a surgeon, a nurse, a doctor, a social worker, a dietitian, so that you can be a part of raising the level of medical care for kidney patients. Today, I am pleased to introduce an AAKP ally and partner, Katharina Schrieb, Senior Director, Head of Autoimmune and Oncology at Sangamo Therapeutics, for our session on Emerging Research with Global Implications, Personalized Cellular Therapy to Advance Kidney Transplantations. Ms. Schrieb, you may start your presentation.
Hello, everybody. I'm very excited to present you today some of our programs at Sangamo. My name is Katharina Schrieb. I'm the Senior Director, Head Autoimmune and Oncology Clinical Science at the company Sangamo. We are a genomic medicines company committed to translating groundbreaking science into medicines that should transform the life of patients with serious diseases. Here you see some of our programs in rare diseases, CNS, oncology, and autoimmune indications. So, some time ago, Rachel and Jonathan shared with us their experience around kidney transplant. We are really grateful to work together with the kidney disease patient advocacy community like the AAKP to learn about the experience of patients and also collaborating with you in developing a better patient-facing material like ICFs or even study protocols. So today I would like to present you one of our programs, the so-called Steadfast program. When patients are transplanted with kidneys, it sometimes happens that the kidney transplants are mismatched. So patients need to receive a transplant which is not actually having the same immunological marker as their body. This happens in 21 to 26% of all transplanted organs. And our goal with the program, the TX200 product, is to promote the immunological tolerance and for the renal graft, and also to help preserve the graft function and reduce the risk of graft loss. Very importantly, also, we hope to reduce with that program and that product the need for systemic immunosuppressive therapy. So the rationale for using regulatory T cells is the regulatory T cells are specialized white blood cells important in helping the body's immune system to function normally. Their main role is to regulate and reduce unwanted immune responses and inflammation. So Tregs can allow white blood cells to protect the body from harm, or function as kind of gatekeepers and can direct other white blood cells to cease fire to ensure the immune system does not mistakenly attack one's own healthy organs. How is that steadfast concept designed? So when a patient decides to go into the trial, a sample of his white blood cells is taken and prepared as a personalized cell therapy, so genetically modified to express the HLA-2 receptor. Then the patient gets transplanted, and after some time, the individual product for him, the TX200 study drug, is infused again to this patient. So the steadfast participants timelines, as said, a patient who decides to enter into the trial is getting screened and tested, then gets the leukapheresis, so this blood sampling of white blood cells. The product is engineered, and the patient gets his transplant. And then after some weeks, the TX200 infusion takes place. The patient is then followed up with a normal study follow-up procedure. The control patients will undergo the same procedure without getting the study drug. What do we expect to learn from the steadfast study? So in renal transplantation, we hopefully want to show that CAR-Tregs are a safe treatment for kidney transplantation, that CAR-Tregs allow the donated kidney to function while sparing the need for these strong immunosuppressive medications. And beyond then, we will also get invaluable knowledge about antigen-specific CAR-Tregs, about their safety and tolerability, about also the proof of mechanism in patients, like localization of that product in the body, the activation and the stability of the Treg function, as well as the persistence of the cells in the circulation, and also the multiple mechanisms of action for immune regulation. So what are the inclusion and exclusion criteria? Inclusion criteria are male and female patients between 18 and 17 years can enter the trial. They should have the diagnosis of end-stage renal disease and currently are waiting for a new kidney from an identified living donor. The participants should await a single organ recipient of kidney, and they should be HLA-2 negative and able to undergo the leukapheresis, which is the sampling of the cells for the program. The exclusion criteria are HLA identical to the prospective donor. Participants with a prior organ transplant are excluded, and participants considered high risk based on an immunological test. For the donors, they should be ABO blood type compatible, and for the donors of 2x200, they should be HLA-A2 positive. So what are the outcomes of this trial? As said, the primary outcome of the trial is the safety and tolerability of the TX200 infusion evaluated by incidence and grade of treatment emergent adverse events and serious adverse events. So this will be taken for a period of 28 days after the treatment. The secondary endpoints will be the effect of the product on an acute graft-related outcome and on the long-term safety outcomes. So from the day of the infusion through the end of the study, this will be assessed. And also, hopefully, we will see the reduction of immune suppressive medications being possible with that drug. From the day of the infusion through the end of the study, we will assess whether there is any improvement with a product. Localization of the 2x200 is also a very important part. Will our product find its target organ, the kidney? And this will be evaluated specifically in week 16, but also after that. And last not least, the effect of TX200 on the chronic graft rejection. So currently we have 4 sites in 4 different countries for the Steadfast trial open so far. Yeah, with that I would like to end my presentation for the moment, and I'm happy to take your questions, and I'm grateful and would like to thank you about the participation.
Ms. Shreve, I have a question for you. In order to change status quo kidney care, we must first change how we diagnose and treat kidney diseases. AAKP is a member of the Personalized Medicine Coalition and is seeing significant advancements in personalized precision medicine. Do you feel this is the future of kidney care?
Well, that's a great question. The promise of a cell therapy like TX200 offers the kidney transplant space is that it would reduce and eliminate the need for immune suppressive regimens with a one-time treatment. And this seems like a very positive promise to the patients.
Katharina Shreve, I'd like to thank you on behalf of the American Kidney Patients Association and George Washington University School of Medicine for your time and your presentation. Thank you.
Thank you for joining us for the 3rd Annual Global Summit, Global Kidney Innovations, Expanding Patient Choices and Outcomes, a collaborative partnership event presented by the American Association of Kidney Patients and the George Washington University School of Medicine and Health Sciences. My name is Jennifer Jones, and I am an AAKP Board of Director, Executive Committee member, and Ambassador. I am also a resilience coach, speaker, and retired Marine Corps veteran. 10 years ago, I was diagnosed with membranoproliferative glomerulonephritis type 1 idiopathic after exhibiting symptoms of acute kidney injury, or AKI, while deployed to Afghanistan. Throughout my journey, I have experienced AKI numerous times due to this disease. In fact, this January, I returned to peritoneal dialysis after having 5 years with a kidney transplant. If it weren't for the nephrology team of Walter Reed National Military Medical Center, I may not be here today, and that weighs heavily on me. However, I am hopeful that one day the focus of my treatment will change from mitigating disease to preventative medicine and modalities. As health consumers and the center of patient-centered care, it is crucial that we provide input and gain access to new kidney care innovations. Being part of AAKP allows me access to the education and resources I need to not only improve my quality of life as a patient, but also the platform to use my voice and my experiences in a meaningful way to demand more innovation and more choices for myself and others diagnosed with chronic kidney disease. As an AAKP member, you can do the same. It is critical now that we as patient consumers raise our voices and create the demand for new diagnostics, devices, and biologics in our independent countries. By cultivating a united patient consortium, that demand can be supported globally for patients in countries where healthcare systems and/or infrastructure may not support patient consumer choice and/or access to care and treatments. Today, I am pleased to introduce friend and ally of AAKP, Kevin Kowaleski, Vice President of Commercial Development for Transplant Medicine at CSL Behring, for our session on Emerging Research with Global Implications, CSL Behring, a company committed to improving outcomes for transplant patients. Mr. Kowaleski, you may start your presentation.
Hello, and I want to thank the American Association of Kidney Patients for allowing me to present to your group today. It's always great to be able to present to patient groups that we can help in some way with our therapeutic product. My name is Kevin Kowaleski, and I'm Vice President and co-lead of the Transplant Therapeutic Area at CSL Behring. And today, I'm going to give you a little overview of who we, all the people that make up CSL Behring, are, and how we intend to be able to help the patients like you in the future. So there's a little legal disclaimer that I'm obligated by all of our lawyers to present to you today. Who are we? Most of you probably have not heard of CSL Behring. As we like to say, we're the largest pharmaceutical company that most people haven't heard of. We're not an everyday name, but for those patients who are helped by our products, they know us and they appreciate everything we do. But CSL is a global specialty pharmaceutical company that's focused on rare disease states. And our intention is to develop therapeutics that help patients live longer and fuller lives. CSL is actually made up of 3 subsidiary companies: Seqirus, which is our vaccine manufacturer, CSL Behring, which is the company that I work for, and CSL Plasma, which is our plasma collection organization that provides the raw materials for most of the products by which we then turn into therapeutics to help patients. At CSL Behring, everything we do is driven by our 5 key values, those being patient focus, innovation, integrity, collaboration, and superior performance. CSL Behring's legacy is more than 100 years old. Our organization was started back in 1916 by our namesake, Emil von Behring, who was the first Nobel Prize winner for medicine. As you can see, over the years, we've grown a lot, but we remain committed to our core promise to patients. As you can see, CSL Behring is a large global organization with more than $9.1 billion in annual sales. But we're committed to reinvesting significant amounts of that money to try and find new therapies to help more people. And in fact, last year, we invested over the last 5 years, $3.7 billion in research and development to try and find new therapeutics to help patients in need. Every day, the 27,000 employees of CSL Behring come to work committed to finding new therapeutics and to help those in need. And in order to provide the raw material for many of our products, we at CSL Plasma have over 270 plasma collection centers throughout the world. We have the largest plasma collection network in all of the industry. As a global company, we have a footprint in more than 35 countries worldwide. In this slide just goes to show a snapshot of all of the different locations where we have offices and staff throughout the world. In fact, our headquarters for CSL is in Melbourne, Australia, and our operations center for CSL Behring is in King of Prussia, Pennsylvania, a suburb of Philadelphia. As I mentioned, at CSL Behring, our 27,000 employees are driven by our promise to our patients, our promise to our employees, our promise to our shareholders, and our promise to our stakeholders, and all of the partners that we have in order to bring the therapeutics to the patients who need them. More than a century ago, CSL Behring made a promise to protect the health of those stricken with a range of serious medical conditions. And today, as a leading biotherapeutics company, that promise has never been stronger. As with any large global organization, we need to be focused. And for our company, we are focused on 5 key therapeutic areas. Those are immunology, cardiovascular and metabolic, hematology, respiratory, and transplant medicine. Today, I'd like to talk to you a little bit and give you more information about our transplant TA specifically. Transplant medicine has been demonstrated and proven to be an effective, life-saving therapy for those with organ failure. In the United States, in 2019, there were nearly 40,000 solid organ transplants, and about 60% of those were kidney transplants. As you can see with the graph on the left, the number of transplants over the period from 2009 to 2019 has grown 39%, and more than 23,000 kidney transplants were done in the United States in 2019. The reason so many transplants are done is because we know that they work. If you look at the graph on the right, the yellow line shows the number of deaths per 1,000 patients for patients who have had a transplant. You can see how low that is compared to the green line at the top of the chart that is patients who remain on dialysis. So we know that transplant works. However, there just simply aren't enough organs to give everybody a transplant who needs one. In fact, there are more than 600,000 patients on dialysis in the United States right now, and globally more than 1.2 million people per year die from kidney disease. Not only is transplant life-saving, it also is cost-effective. For healthcare payers around the world, spending on dialysis is a significant portion of their budget. In fact, the United States alone, U.S. Medicare spending for patients with end-stage renal disease in 2018 was $36 billion. So you can see the amount of resource that is required in order to manage patients with kidney disease. And for those patients, transplant could be a very important and viable option. So, as I've shown on a previous slide, transplant continues to grow. Globally, in 2018, there were nearly 143,000 transplants. And that's expected to grow to over 200,000 transplants in the year 2030. But the number of patients who are on the wait list continues to grow. The demand for organs simply is far greater than the supply. But there are things that we can do, and there are things that CSL Behring is committed to doing. Because organ discard, the number of organs that are actually donated but not used is still significant. In fact, about 18 to 20% of organs donated, kidneys donated in the United States, are actually discarded. And roughly only about 25% of lungs that are donated for transplant are used. Those numbers need to improve. And part of that needs to happen with therapeutics that help make these organs more viable for transplant. Additionally, legislative and advocacy efforts to try and increase donation could significantly impact the number of organs available. If you look at the global donation rates in different countries, for instance, Spain, one of the highest countries in terms of donation in the world, where nearly 47 people per million donate organs. In the United States, the number is about 32 people per million. And in other countries, such as Germany, where it's less than 10 people per million that donate. So if we can get those numbers up to closer to 35 to 40 people per million, you can see the impact it would have on the ability to get more people transplanted. Additionally, our company is focused on trying to help those patients who've already received a transplant to keep that graft longer and to keep those patients alive longer. Now, admittedly, this is a bit of a jumbled slide, this graph. However, if you look at the lowest line on this chart, which shows patients who have antibody-mediated rejection, the survival of those patients is far worse, significantly worse, than patients who don't have antibody-mediated rejection. And antibody-mediated rejection is responsible for most allograft failure for kidney patients. It's because of that our company has invested in a clinical trial that's currently ongoing, a randomized, multi-center, double-blind, placebo-controlled phase 3 study of clazakizumab, which is a novel anti-IL-6 monoclonal antibody for the treatment of chronic antibody-mediated rejection. This new product, if approved, would have only once monthly subcutaneous dosing. Additionally, if this product is approved, it may be the first new product approved for kidney transplant patients in the United States in over a decade. Patients need products like this, and it's companies like CSL Behring who are delivering upon the promise to bring new therapeutics to market for those patients who need them. It's through studies like the IMAGINE trial, looking at clazakizumab as a treatment for chronic antibody-mediated rejection, that we believe that we can deliver upon the mission that we have for the transplant TA at CSL Behring. And that mission is very simple: to become a recognized leader in transplant medicine by 2030 by bringing innovative products to market that dramatically improve patient outcomes through better graft availability and long-term graft and patient survival. So I hope that this information today was able to give you a little better idea of who CSL Behring is. And I'm very hopeful that for those of you who are either have or will be getting a kidney transplant in the future, that someday that we may be able to help you and that our name may be more recognizable in this community. Until then, thank you and stay safe.
We appreciate Mr. Kowaleski for taking the time to share his insights and expertise. Thank you.
Thank you very much for joining the American Association of Kidney Patients and George Washington University School of Medicine and Health Sciences for this, our third annual Global Summit on Kidney Disease Innovations. The engagement of this audience worldwide is fundamentally important to the success not only of our future summits, but more importantly, to patients who are suffering from kidney diseases. Around the world, the cost and the burden of kidney disease is increasing, and it's been accelerated by the pandemic of COVID-19. Medical professionals around the world are under tremendous pressure. Researchers are under tremendous pressure. Everyone is racing for solutions, not simply for the immediate and the short term of COVID-19, but for the long-term implications, including implications for kidneys. This additional burden on kidneys worldwide and on patients is on top of a growing epidemic of kidney diseases. What's going to solve this problem? To put it really bluntly, it's going to take all oars in the water, pulling as hard as possible. But one of the strongest forces in that equation is the voice of patients and the energy that we bring to helping solve problems, not simply for ourselves, but for those who have yet to be diagnosed, and that's what this is all about. Patients around the world working as patient consumers who are informed about the science of their disease, about the implications for their families, have a very unique role to play. Our voice is the voice that must be heard by regulators in government, payers, whether they're in the private sector or the government, and they must be heard by those who are struggling every single day to try to bring treatments to us. Our voice needs to back up and be an advocate for the medical professionals, the researchers, the young scientists, those who are thinking about getting into this space, and most importantly, those of us who know, who can have an impact on kidney disease. We must be a voice for patients that don't have the energy and may not have the knowledge or the technology to speak up to their governments. Together worldwide, we can make an impact. Let me give you some examples here in the United States, just in the past 10 years, what an organized group of patients has been able to do, working in collaboration with medical professionals. In less than 10 years, we've been able to make HIV to HIV organ transplants possible, so those who are suffering from HIV can have life-saving kidney transplants. We changed the law. We've been able to get immunosuppressive drug coverage for the life of the transplant. Just in the past year, that was a 20-year fight, but kidney patients made that happen working with their elected professionals. And kidney patients worked diligently with labor leaders and the U.S. Department of Labor to make certain that the Family Medical Leave Act was interpreted and extended to those individuals who are called to be living organ donors, the selfless heroes that donate their organs and their kidneys to keep patients alive. Right now, we're fighting in the U.S. Congress to make certain that all kidney donors, all living kidney donors, whether they're insured or not insured, are provided with the protections of law here in the United States to make certain they're not discriminated against in life insurance, disability insurance, and health insurance. It's a proud battle, and we're going to win it. These are just a few of the examples of what we've been able to achieve here in the United States, working as a united front of patients with other stakeholders in the kidney community. We are absolutely convinced, as you've heard from our European partners and our European kidney allied patient groups and other patient groups around the world, we are convinced that we can help drive solutions and get those solutions into the hands of the medical practitioners and patients so we can save more lives, prevent more disease, and allow people to pursue their aspirations and their goals across the globe in whatever country they live in. We know that the patient voice can have an impact because it has. We know the patient voice will have an even greater impact because we're getting organized, we're using better technologies, and we have a better sense of ourselves of what we can achieve. And for the patients that are listening that haven't had a chance to get engaged yet in clinical trials and research, understand this, that the research community worldwide and the medical community worldwide, they need us. They need us right next to them. And the dynamic of viewing patients somehow as no longer having importance or the same importance or voice, that's falling away. And what's emerging is a greater sense and appreciation for patient insights, and the value that we have and our life experiences have. I ask you to join us at the American Association of Kidney Patients as we build a worldwide consortium of patients. We're driving for a lot of things. We are going to get artificial, wearable, and implantable kidneys within the next 10 years. It's one of the reasons why the American Association of Kidney Patients started the Decade of the Kidney. We declared it so in 2019, and we've dedicated ourselves by 2030 to working around the globe with researchers and medical professionals and fellow patients to make certain that we can make that happen. We're in the business of saving lives, of inspiring other people, and making certain our voice counts. Your voice counts too. Whether you're a patient or a caregiver or a family member, I encourage you, join us. It takes all oars in the water pulling in the same direction, but the greatest power in that boat is the voice of the patient and the example of the patient. So thank you very much. As a fellow kidney patient, my hats go off to you around the world. I'd like to especially thank Dr. Dominic Raj, the Dean of Medicine at George Washington University. I'd like to thank Dr. Bass, thank my fellow patients, Richard Knight, and until our next Global Summit, keep speaking, keep active. Thank you.
I think the work that is being done by AAKP is so critical to patients all around the country. Their ability to advocate on our behalf ensures that everybody understands the impact of kidney disease and what they can do to help us.
I always have fun at an AAKP event. How could you not have fun? You're with people who understand completely what you and your family are going through. So it's not just for patients, AAKP. AAKP should be for the family of patients, because when a patient has kidney disease, the family has kidney disease.
Belonging to an independent advocacy organization like AAKP gives me the confidence that I can represent them and people living with kidney disease to represent them honestly.
Our objective over the coming decade is to reach people around the globe and not just limit it to the United States, because kidney disease is a universal disease.
They encourage patients to be the voice for their care and treatment. And I don't see that as much in other organizations, and I feel like that is so necessary for patients to feel like they have a voice and they can make change in regards to their care and treatment.
It's important to be a patient advocate because to whom much is given, much is required. I was given this gift of life back in 2008 by my donor, Leanne, rest in peace. She was a deceased donor. So now if I can use my voice and use my platform and influence to impact lives, and my favorite word, why not? And why not become an organ and tissue donor today?
We spend a lot of time here, particularly in DC, in the nation's capital, talking with staff, with the legislators, and trying to help them understand exactly what the patient perspective is on anything that's kidney or renal related. It's a great honor to be able to do it. Our numbers are growing, and part of our strategy is for them to understand that we will come and visit and talk with them, and we represent the patient voice, and we want that to be heard, and that's how we do it.
People around the world who are sick and suffering with kidney disease need a voice of optimism. They need the tactics
and they need the reinforcement from fellow patients here in the U.S. to do what they do and demand a change in the status quo. And we fully intend to arm patients around the world with the tools they need to be more vocal with their governments, regardless of the ideology of their government, and to demand solutions and to defend private sector companies and investors who are willing to get into this space and deliver more innovation for patients.
AAKP opens the door so that it broadens the whole horizon. You're one person. When you belong to AAKP, you suddenly become a tribe.
Welcome to today's Healthline webinar, Coronavirus and Kidney Patients Update, a CDC expert webinar hosted by AAKP's Center for Patient Research and Education. Thank you for joining us today for an update from AAKP's trusted federal partner, the Centers for Disease Control and Prevention, including the importance of the COVID-19 vaccination and virus variants in the context of vaccination. My name is Erin Kale, and I am Director of Stakeholder Operations for the American Association of Kidney Patients. I oversee our patient education and grassroots engagement activities, including our Ambassador Initiative, which comprises highly motivated and engaged patients and caregivers around the country and globe. These individuals have a direct connection to kidney disease and wish to raise awareness and provide support to others navigating the challenges of this chronic disease. AAKP's Healthline webinars fall under our Center for Patient Research and Education. We believe patient and caregiver education is an integral part of treatment and protection of patient lives, and we work to ensure that the patient has a central role in research and guidance that are designed to determine optimal approaches and strategies for providing healthcare services, assistance programs, and access to new products and services. This is especially true during national emergencies, such as the coronavirus pandemic. At this time, I'd like to introduce AAKP's president, Richard Knight. Richard is a former in-center hemodialysis patient who received his kidney transplant over 12 years ago. Richard, I'll turn things over to you.
Thank you, Erin. First, I would like to thank everyone who has shown a concern for kidney patients and the continued threat of COVID-19. Second, I want to thank the CDC for again sharing their time and expertise with us today, as well as for their responsiveness and engagement with AAKP and the kidney community over the past year through our Keeping Dialysis Safe coalition that we've jointly shared with them and the Health Infection Control Practices Committee, HIPAC. AAKP is proud to have the CDC as one of our long-term federal strategic partners, and we're certainly honored to serve as a member of the HIPAC. As we all know, the coronavirus has been a serious threat to all Americans, especially those with underlying health conditions who are immunosuppressed, like our kidney patients. For the past year, this is something that we've dealt with. I pray for everyone who is facing or has faced the threat of this disease. As a matter of fact, it was just a little over a year ago when I was finishing up a 2-week quarantine after being exposed to COVID-19 on March 6th at a meeting I attended in New York. Since that time, AAKP has hosted a dozen webinars dedicated to different aspects of COVID-19. Today's presentation from the CDC will provide important updates on COVID-19, as well as serve as a reminder for keeping yourself and your loved ones safe and healthy. So once again, I'm asking all of you who are listening, stay connected to AAKP and share your involvement through our online efforts. Because although our reach is growing, we believe we need to educate more patients on how serious this virus is and the threat they face. But however, I want to note that the fear, uncertainty, and doubt we felt in March a year ago is rapidly being replaced with new information, a variety of vaccinations, and most importantly, hope. I will now ask my fellow transplant recipient and AAKP Chair of Policy and Global Affairs, Paul Conway, to talk about our survey research that led in part to the call today with CDC. And you should also know that Paul serves as the AAKP liaison to the CDC Health and Infection Control Practices Committee, HIPAC. Paul, I turn it over to you.
Thank you very much, Richard. And for those who are listening, I want you to know that Richard Knight and I have worked together diligently for the past 5 years to make certain that AAKP brings your voice as patients and caregivers to the table in all federal policy and stakeholder deliberations on Capitol Hill before the White House. One of the technologies that we use to do that is the latest in polling and surveying techniques. Richard Knight has been very forceful here in Washington, D.C. and around the country in making certain that all voices, especially from those communities that are not heard, are heard by the federal government and by state governments and all stakeholders. On this first slide, you'll see that going into today's webinar, we wanted to get a sense of where the kidney patient community was on vaccines. The great news is this: we know as a community what a threat COVID poses. We're ignoring voices of discontent and argument on either side of the issue, and we're taking care of business. We're getting our vaccines, and that we feel as though the increase in vaccines and the better distribution is making us more confident that things will eventually become safer for us individually and as a patient and kidney community. On this particular slide, you'll see that nearly 87% of kidney patients believe that they're confident or somewhat more confident overall that vaccines and their increased distribution have made them think that America will see the light at the end of the tunnel for the COVID-19 pandemic. And this is good news. So in this first cluster of polling questions that we did, people feel better about the vaccines for their own safety, but also that it's key to making certain that America is coming out of this long pandemic. The next couple of slides paint an even more interesting picture of this, however, in the insights of patients. We asked patients, regardless of whether they had gotten a vaccine or plan to, what were their top concerns about the vaccine itself? And here are some that you would probably think are typical, which is concerns about effectiveness and long-term safety. But right there at number 3 are the emergence of new variants and mutations, such as the UK, the South African, and the Brazil variants, and the continued risk of infections. And then the other question in this cluster was interesting, because even though vaccines are available, we asked whether or not we thought that people would be less likely to follow CDC guidelines, such as face coverings and gatherings. Nearly 88% thought that even though vaccines are available, people are going to drop the common sense protections that have been recommended for the past year by the CDC. So then we asked, what do you think the 3 biggest risks are to continued progress that might trigger a wave of new infections or renewed limits on an individual's ability to be with a family, leave home, and return to a fairly normal life? And number 1 on that list is people ignoring CDC recommended guidelines. Number 2 is that there are more transmissible mutations, and again, UK, South African, and Brazil variants. And number 3, states opening up sooner than vaccine availability. But we actually think the first 2 are quite important and germane to today's webinar. Finally, we asked folks to rate those leaders who we think, as a patient community, are the most credible to talk to highly vulnerable populations that may not have gotten vaccines yet, and that would have the most credibility in asking people to go ahead and get one. So for those pockets across America or in the patient community, who do you think is the most credible at communicating that message and encouraging everyone to get their shot? You can see family doctors and nurses are right at the top, leaders of the faith community, and families. At the bottom of that list are national elected or former elected leaders. And with this, I'll turn it back over to Aaron so we can get into the substance of the presentation today. Again, like Richard, I'd like to thank the Centers for Disease Control for their professionalism and their forward-leaning mentality in terms of engaging the patient communities across the United States over the past year. It's refreshing, it's helpful, and it's practical, because patients have an innate sense of protecting themselves and one another. They need the information to act, and CDC has been quite helpful to AAKP over the past year and ongoing. Thank you.
Thank you so much, Paul and Richard. And thank you to those who are listening who completed our survey. We very much appreciate your comments, your questions. Those insights help us to inform this webinar as well as future webinars. So thank you for participating in that poll. I'd like to now introduce our guest speakers for today's webinar. Dr. Anna Cecilia Bardosi currently serves as Medical Officer on the Dialysis Safety Team in the Division of Healthcare Quality and Promotion at the Centers for Disease Control and Prevention. She joined CDC in 2018 as an Epidemic Intelligence Service Officer in the Prevention and Response Branch at DHQP. Dr. Bardosi received her medical degree from Universidad Nacional de Córdoba and completed an infectious disease fellowship at Hospital Privado de Córdoba, Argentina. Prior to her work at CDC, Cecilia worked in infectious disease research at a large academic healthcare institution in Michigan and as a hospital epidemiologist and infectious disease physician in Argentina. Her areas of interest are infection prevention, the control of outbreaks, and healthcare quality improvements. We're also happy to have Dr. Shannon Novosad joining us again today. Dr. Novosad is a medical officer with the Dialysis Safety Team in the Division of Healthcare Quality Promotion, Centers for Disease Control and Prevention. Dr. Novosad received her medical degree from the University of Alabama at Birmingham. In 2015, she came to CDC as an Epidemic Intelligence Service Officer assigned to DHQP, where she investigated outbreaks in healthcare settings. Her areas of concentration include prevention of central line-associated bloodstream infections and increasing the safety of patients on dialysis. We're so happy to have both Dr. Bardosi and Dr. Novosad joining us today. I turn things over to you, and please let me know when you're ready for your slides to advance.
Thank you, Erin, and thank you for the introductions. This is Cecilia Bardosi, and we are really thankful also for inviting us to speak today. We'll summarize critical information for patients for the prevention of COVID-19 and update you about COVID-19 vaccination. Some of you may already be familiar with information we'll present today, but we think it's important for us to review and to ensure we remain diligent and follow recommendations to protect ourselves and protect others. I wanted to begin today by reviewing the modes of transmission of COVID-19 and how the virus is spread. Understanding these and which are the most frequent modes of transmission can help shape our understanding of the most important protective measures we should be continuing to practice in the community and in dialysis facilities. The primary way COVID-19 spreads is from person to person and during close contact. The virus that causes COVID-19 appears to spread more efficiently than influenza, but not as efficiently as measles, which is among the most contagious viruses known to affect people. People who are physically near, within 6 feet of a person with COVID-19 or have direct contact with that person are at greatest risk of infection. When people with COVID-19 cough, sneeze, sing, talk, or breathe, they produce respiratory droplets. Respiratory droplets cause infection when they are inhaled or deposited on mucous membranes, such as those that line the inside of the nose and mouth. The next way that COVID-19 viruses spread is referred to as airborne transmission. Some infections can be spread by exposure to virus in small droplets and particles that can linger in the air for minutes to hours. These viruses may be able to infect people who are farther than 6 feet away from the person who is infected, or after that person has left the space. There is evidence that under certain conditions, people with COVID-19 seem to have infected others who were more than 6 feet away. These transmissions occur within enclosed spaces with inadequate ventilation. Sometimes the infected person was breathing heavily, for example, while singing or exercising. Under these circumstances, scientists believe that the amount of infectious smaller droplet and particles produced by the people with COVID-19 become concentrated enough to spread the virus to other people. The people who were infected were in the same space during the same time or shortly after the person with COVID-19 had left. Available data show that it is much more common for the virus that causes COVID-19 to spread through close contact with a person who has COVID-19 than through airborne transmission. COVID-19 spreads less commonly through contact with contaminated surfaces. Respiratory droplets can land on surfaces and objects. It is possible that a person could get COVID-19 by touching a surface or object that has the virus on it, and then touching their own mouth, nose, or eyes. However, spread from touching surfaces is not thought to be a common way that COVID-19 spreads. And lastly, COVID-19 rarely spreads between people and animals. CDC is aware of a small number of pets worldwide, including cats and dogs, reported to be infected with the virus that causes COVID-19, mostly after close contact with people with COVID-19. However, at this time, the risk of COVID-19 spreading from animals to people is considered to be low. So now that we understand how the virus spreads, we'll discuss more about people who are at higher risk for severe illness from COVID-19, such as those with certain underlying conditions, such as chronic kidney disease. By severe illness, we mean someone who was hospitalized, admitted to the intensive care unit in a hospital, or that needed a breathing tube or machine to help them breathe, which is often referred to as intubation or mechanical ventilation due to COVID-19. The list of underlying medical conditions seen here is not exhaustive and only includes conditions with enough evidence to draw conclusions. It is a living document that may be updated at any time, subject to potentially rapid change as the science evolves, and was most recently updated last week. Healthcare providers sometimes advise patients with other medical conditions that they are also at high risk. So adults of any age with the following conditions are at increased risk: obesity and severe obesity, type 2 diabetes, chronic obstructive pulmonary disease, heart conditions, chronic kidney disease, cancer, immunocompromised state from solid organ transplant, sickle cell disease, pregnancy, smokers, and Down syndrome. Currently, there are limited data and information about the impact of many underlying medical conditions on the risk for severe illness from COVID-19. Based on what we know at this time, adults of any age with the following conditions might be also at an increased risk for severe illness from the virus. And the conditions are asthma, cerebrovascular disease, cystic fibrosis, hypertension, immunocompromised state, neurologic conditions such as dementia, liver disease, overweight, pulmonary fibrosis, thalassemia, and type 1 diabetes. Now, what do we know about COVID-19 hospitalization and mortality relative to age and underlying conditions? First, there are data showing that COVID-19 hospitalization increases with age. COVID-19 associated hospitalization has also been shown to increase with the number of underlying medical conditions, with the higher risk for adults with 3 or more conditions. This is important because we know that patients with chronic kidney disease often have other conditions that might put them at higher risk. And in relation to mortality, COVID-19 mortality rates are highest in older adults. And among persons hospitalized for COVID-19, the risk of in-hospital death also increases with age. In addition to the risk for hospitalization at the time of initial infection, patients may require ongoing care and need to be readmitted to the hospital. An analysis of more than 106,000 patients who survived COVID-19 showed that 1 in 11 were readmitted to the same hospital within 2 months of discharge. The odds of hospital readmission increase with age and the presence of 5 chronic health conditions: chronic obstructive pulmonary disease, heart failure, diabetes, chronic kidney disease, and obesity. Knowing about the underlying medical conditions that increase the risk of severe COVID-19, what general actions can people at higher risk take to reduce the risk of getting COVID-19? One of the most important actions is to get vaccinated. You should also encourage others around you to get vaccinated to protect themselves and you. Continue with normal care activities such as continue receiving your medicines and do not change your treatment without talking to your healthcare provider. And receive recommended vaccinations. And this includes not only the COVID-19 vaccination, but also other vaccinations such as influenza and pneumococcal. Other actions to take include limit your interactions with other people as much as possible. Consider avoiding activities where taking protective measures may be difficult, such as activity where social distancing can be maintained. In general, the more people you interact with, the more closely you interact with them, and the longer that interaction, the higher your risk of getting and spreading COVID-19. However, it is important to clarify that based on what we know about COVID-19 vaccines, people who have been fully vaccinated can start to do some things that they had stopped doing because of the pandemic, and this will be reviewed in more detail in the next presentation on COVID-19 vaccination by Shannon Navasad. Do not delay getting emergency care for your underlying medical condition because of COVID-19. Emergency departments have contingency infection prevention plans to protect you from getting COVID-19 if you need care. Remember the importance of staying physically active and practicing healthy habits to cope with stress, and call your healthcare provider if you get sick and think that you may have COVID-19. And lastly, take precautions to prevent getting COVID when you interact with others. In this slide, we have those precautions. I know we have been talking about some of these since last year, but we think it is important to review them and reevaluate how to best adhere to these precautions, including when visiting dialysis facilities. Get vaccinated, wear a mask, stay 6 feet away from others, avoid crowds and poorly ventilated spaces, wash your hands often, cover coughs and sneezes, clean and disinfect, monitor your health daily. And we'll review some of these in detail in the next slides. One of the most important measures to take to prevent getting COVID is to get vaccinated. Authorized COVID-19 vaccines can help protect you from COVID-19, so you should get a COVID-19 vaccine when it is available to you. Another important measure to take to prevent getting COVID is to wear a mask. Some things to remember about masks. They should be worn in addition to staying at least 6 feet apart, especially around people who don't live with you. If you or someone in your household is infected, people in the household should take precautions, including wearing masks to avoid spread to others. Do not touch the mask when wearing it. If you have to continually adjust your mask and it doesn't fit properly, you might need to find a different mask type or brand. And make sure you can breathe easily. Here we have guidance on how to choose masks. There are many options, and this has been updated recently and may be different than what you have heard in the past about the best types of masks to wear. Do choose masks that have 2 or more layers of washable, breathable fabric, completely cover your nose and mouth, fit snugly against the sides of your face, and don't have gaps. I have a nose wire to prevent air from leaking out of the top of the mask. Do not choose masks that are made of fabric that makes it hard to breathe, for example, vinyl. Do not choose masks that have exhalation valves or vents which allow virus particles to escape. And do not choose masks that are intended for healthcare workers, including N95 respirators. And in relation to the cold weather, if you wear a scarf, ski mask, or balaclava, use them over your mask. They are not substitutes for masks. We just discussed guidance related to the use of masks, but we wanted to share a little about the science behind the types of masks that best slow spread of COVID-19 and why universal masking is recommended to slow the spread of COVID-19. CDC conducted experiments to assess 2 ways of improving the fit of medical procedure masks: fitting a cloth mask over a medical procedure mask and knotting the ear loops of a medical procedure mask, and then tacking in and flattening the extra material close to the face, Each modification substantially improved source control and reduced wearer exposure. These experiments highlight the importance of good fit to maximize mask performance. There are multiple simple ways to achieve better fit of masks to more effectively slow the spread of COVID-19. So all masks should cover your nose and mouth, fit securely under your chin, and fit snugly against the sides of your face. And in this slide, we also see some examples on how not to wear a mask. Don't wear your mask around your neck, on your forehead, under your nose, and this is something that is observed very frequently among people. Don't wear it only on your nose, on your chin, dangling from one ear or on your arm. And lastly, we just wanted to review the steps to remove your mask. First, carefully untie the strings behind your head or stretch the ear loops. You should only handle the mask by the ear loops or ties. Fold the outside corners together and be careful not to touch your eyes, nose, and mouth when removing. And wash your hands immediately after removing it. And recommendations on how to clean your mask are also included in the website shown on the screen. Reusable masks should be washed regularly and they can be included with your regular laundry. This second study showed that mandating masks was associated with a decrease in daily COVID-19 case and death growth rates within 20 days of implementation. And allowing in-restaurant dining was associated with an increase in daily COVID-19 case growth rates, 41 to 100 days after implementation, and an increase in daily death growth rates, 61 to 100 days after implementation. So this highlights that universal masking and avoiding non-essential indoor spaces can help mitigate the spread of COVID-19. In this third study done in Kansas, they found something similar to the previous slide. The governor of Kansas issued an executive order requiring wearing masks in public spaces, effective July 3rd, 2020, which was subject to county authority to opt out. After July 3rd, COVID-19 incidents decreased in 24 counties with mask mandates, but continued to increase in 81 counties without mask mandates. County-wide mask mandates appear to have contributed to the mitigation of COVID-19 transmission in mandated counties. We just covered some very important information on universal masking, but let's now consider what it really means when thinking about mask use within an outpatient dialysis facility. It is very important that all people, including patients, caregiver, and staff, properly use masks for the safety of everyone in a dialysis facility. There may be moments when the mask may be removed quickly, but needs to be put back quickly. For example, when you have to take an oral medication with a sip of water. Another example is when you eat. Due to COVID-19, the facility may have developed new policies for when patients need to eat or drink within the facility, so try to adhere to them. You should only be eating or drinking during dialysis when it is medically necessary. So if you do need to eat inside the dialysis facility, the mask should be carefully removed while you're eating or drinking, and you should remask as soon as possible after eating or drinking. And ideally, when eating, stay at least 6 feet away from others before removing your mask. In a dialysis clinic, you are typically close to other patients and staff for several hours, so it is important that you feel comfortable speaking up and voicing any concerns you may have with how others wear their masks. For example, if you see that the patient who is sitting next to you or a staff member are wearing their mask under their nose, you should suggest him or her that they need to wear it properly. Because COVID-19 spreads mainly among people who are in close contact for a prolonged period of time, it is important to stay 6 feet away from others when possible, even if you or they do not have symptoms. Consider the following tips for practicing social distancing when you decide to go out. First, you need to know and follow the guidance from local public health authorities where you live. Then you need to prepare for transportation and try to consider social distancing options to travel safely when running errands or commuting to and from work or going to the dialysis facility. When using public transit or rideshares, Try to keep at least 6 feet from other passengers. However, we understand that staying 6 feet away from others is often difficult on public transportation and rideshares. That is why CDC has issued an order that requires face masks to be worn by all travelers while on public transportation. Limit contact when running errands, and stay at least 6 feet away from others who are not from your household while shopping and in lines. And if possible, use drive-through, curbside pickup, or delivery services to limit face-to-face contact with others. Choose safe social activities. It is possible to stay socially connected with friends and family who don't live in your home by calling, using video chat, or staying connected through social media. If meeting with others, please always stay at least 6 feet from others and use and wear a mask. It is safest to avoid crowded places and gatherings where it may be hard to stay at least 6 feet from others who are not from your household. And lastly, stay distanced while being active. And now going back to the dialysis facility, what does it mean to stay 6 feet away from others at the dialysis facility? It means that we need to be careful when using common areas within the dialysis clinic that may be busy. Some examples are the waiting rooms. In this case, you should choose to sit far from other patients. The scale station. This area can easily get crowded, so you should be careful to maintain the 6 feet distancing when waiting to use the scale. Restrooms and sinks. Depending on your facility, the restrooms or sinks where you wash your fistula or graft when you arrive for treatment may also be a busy place, so be sure to consider how you can maintain the 6 feet distance. Of course, dialysis stations should also be able to maintain 6 feet distance from a patient to patient. And if you are concerned about this, please talk with your care team. Their goal is to keep you as safe as possible, and conversation about COVID-19 and social distancing are very important. Make sure to communicate with your dialysis facility if you have been vaccinated and when, if you have had any COVID-19 symptoms since your last treatment or are experiencing symptoms currently, if you were diagnosed with or tested for COVID-19, if you have had close contact with someone with suspected or confirmed SARS-CoV-2 infection in the last 14 days. Symptoms of COVID-19 include cough, difficulty breathing, fever, chills, body aches, vomiting or diarrhea, or new loss of taste or smell. You need to watch for those symptoms. Some end-stage renal disease patients on maintenance dialysis report having some of these symptoms chronically or sporadically. It can be hard to tell the difference from COVID-19 symptoms, so it is important that you report any of these symptoms to your dialysis care team, even if you think they are chronic. The dialysis care team will decide if you need to be tested or dialyzed in a separate area until it is ruled out that you do not have COVID-19. Just some reminders about some other everyday practices. Remember to wash your hands before and after your dialysis treatment, as well as at any time you touch the outside of your mask while at dialysis. If you cough or sneeze while not wearing a mask, be sure to use the inside of your elbow or a tissue, discard your tissues and wash your hands. And then about cleaning and disinfection, the dialysis staff will be cleaning and disinfecting the dialysis stations and other areas very frequently during this time, but you should also be aware of other surroundings in the clinic. On several of the previous slides, we touched on the fact that it is important to speak up, use your voice, and ask staff questions. This is an important aspect of your dialysis care at all times, but it is especially important during the COVID-19 pandemic. These may seem uncomfortable at first, but we have provided some samples questions here to get you started. What is the facility doing to prevent COVID-19 transmission? Have you been vaccinated for COVID-19? Do you mind cleaning your hands again before you care for me? Just to finish, this slide shows the CDC main website that you can access using the link included at the bottom of the page to review all COVID-19 recommendations and clarify any questions. And if you click on the More tab in the upper right, it will give you the option to view any new guidance and updates. Thank you. And now I would like to introduce my colleague Shannon Novosad, who will present information on vaccination for COVID-19. Thank you.
Thanks, Cecilia. So in the 1 year since COVID-19 infections were first identified, multiple COVID-19 vaccines have been developed and put through clinical trials with the support of the U.S. government. So far, 3 have received an FDA emergency use authorization. As has already been mentioned, vaccination is a critical tool in bringing this unprecedented pandemic to an end, and CDC continues to work with states to understand roadblocks and figure out how to overcome challenges in distribution and administration to ensure that we're getting vaccines into arms as quickly as possible and safely as possible. As of March 9th, over 90 million doses of COVID-19 vaccine have been administered. You might have heard of the term ACIP in the news, so I wanted to spend a few slides discussing what ACIP is and how CDC and ACIP work together. So the Advisory Committee on Immunization Practices, or ACIP, was established in 1964 by the Surgeon General of the U.S. Public Health Service, and it was designated a Federal Advisory Committee in 1972. The ACIP develops recommendations on how to use vaccines to control disease in the United States. Committee deliberations on use of vaccine to control disease in the U.S. include multiple considerations, which are listed on the slide here, including epidemiology of the disease, which is the study of the frequency and patterns of a particular disease, vaccine safety, quality of evidence reviewed, as well as economic and implementation considerations. Notably, the committee may revise or withdraw their recommendations regarding a particular vaccine as new information becomes available. And CDC is the secretariat for ACIP, but ACIP is independent of CDC, and voting ACIP members are not CDC employees. So the committee's recommendations are forwarded to CDC's director for approval, and once they've been reviewed and approved by both CDC and the Department of Health and Human Services, they're published in CDC's Morbidity and Mortality Weekly Report, also known as the MMWR. This publication represents the final and official CDC recommendations for immunization of the U.S. population. Under provisions of the Affordable Care Act, immunization recommendations of the committee that have been adopted by the director of the CDC must be covered by applicable health plans. This slide here shows the recommendations for vaccine prioritization that were issued by ACIP during the limited vaccine supply. I'm not going to read all of these to you. You're probably familiar with these and have heard these before. But as you can see, they're divided into different phases. So 1A, 1B, 1C, and then phase 2. And they're rolled out depending on characteristics of people in each of these phases. I think what's most important to know about these phases is that when they were made, it was always thought that there would be a level of local adaptation. So that's why you probably see things happening differently in different states. These recommendations are meant to be fluid and not restrictive for jurisdictions. And it's not necessarily to vaccinate all individuals in one phase before initiating the next phase, and phases may overlap. So again, many of you may live in states that are in various stages of prioritization, and some at this point have opened up vaccinations broadly and may be in phase 2, while others may be in states that are still in phase 1C, and others may be in states that have actually adapted these differently and are using different phases. These guidelines, kind of as covered in the previous slide, again, the prioritizations are not meant to be walls or barriers between the phases, but really were meant to be a way to prioritize people at high risk of exposure or severe disease during a limited vaccine supply. And we always anticipated that there would be overlap between these vaccination phases. The COVID-19 vaccination program is dynamic, and it will require ongoing reassessment as vaccine supply and demand and COVID-19 epidemiology changes to inform the timing of expansion to subsequent phases. And ACIP and CDC have endorsed the guiding principles of efficient distribution as well as jurisdictional flexibility for the COVID-19 vaccine program. COVID-19 vaccination is a safer way to build protection. Getting the virus that causes COVID-19 may offer some natural protection known as immunity, but experts don't know how long this protection lasts. The risk of severe illness and death from COVID-19 far outweighs any benefits of natural immunity, and vaccination will help protect you by building immunity without the risk of severe illness. So there have been 3 vaccines that have received emergency use authorizations from the FDA, listed here, Pfizer, Moderna, and the Johnson & Johnson. These vaccines were tested in diverse adult populations that included minorities and older adults, and all of the available vaccines have been proven effective at preventing serious illness, hospitalization, and death from COVID-19 vaccine disease. Importantly, it's unknown how long protection from receiving a COVID-19 vaccine might last. We realize that you may have concerns about the safety of these first COVID-19 vaccines because they use new technology. These mRNA COVID-19 vaccines were developed based on years of research. So while mRNA technology is new, it's not unknown. It's been studied for decades in vaccine trials for influenza, Zika, and rabies. And beyond vaccines, cancer research has also used mRNA to trigger the immune system to target specific cancer cells. These vaccines were able to be fast-tracked because research used existing clinical trial networks to quickly conduct vaccine trials. Another critical piece was the investment in manufacturing before COVID-19 vaccines were proven effective. mRNA vaccines are also faster and cheaper to produce because they use ready-made materials. And finally, FDA and CDC are working and worked quickly to prioritize review and approval of these COVID-19 vaccines during the pandemic. So like all vaccines, the mRNA vaccines have been rigorously tested for safety before being authorized for use in the United States. The technology is new but not unknown. They do not contain a live virus and do not carry a risk of causing disease in the vaccinated person. And the mRNA from the vaccine never enters the nucleus of the cell and does not affect or interact with a person's DNA. Some key facts about the COVID-19 vaccine are listed here on this slide. Importantly, getting vaccinated will help protect you from getting sick with COVID-19. People who have gotten sick with COVID-19 may still benefit from getting vaccinated. The COVID-19 vaccines will not give you COVID-19, and COVID-19 vaccines will not cause you to test positive on COVID-19 viral tests. One caveat to this is if your body develops an immune response, the goal of vaccination, there is a possibility you may test positive on some antibody tests. So COVID-19 vaccines are being held to the same safety standards as other routine vaccines. Several expert and independent groups evaluate the safety of vaccines being given to people in the United States. Before any vaccines receive authorization or approval, the FDA carefully reviews all the safety data from clinical trials. And the ACIP that we mentioned previously reviews all safety data before recommending use. After any vaccines are authorized and in use, FDA and CDC continue to monitor their safety, and existing systems can rapidly detect possible vaccine safety problems. These systems are being scaled up for COVID-19 vaccine introduction to fully meet the needs of the nation. And additional systems and data sources are also being developed to further enhance safety monitoring capabilities. One such system, actually two are shown here at the bottom of the slide. One is vSafe, which I'll talk about in the next slide. The other one is one that you may have heard about before called the Vaccine Adverse Event Reporting System, or VAERS. It's a national system that's been in place for some time that collects reports from healthcare professionals, vaccine manufacturers, and the public of adverse events that happen after vaccination. So vSafe is a smartphone-based tool that uses text messaging and web surveys to provide personalized health check-ins after you receive a COVID-19 vaccine. Through vSafe, participants can quickly tell CDC if they have any side effects after getting the COVID-19 vaccine. And depending on the answers, someone from CDC may call to check on you and get more information. We encourage everyone who receives a vaccine to participate in vSafe. All you need to register is a cell phone. You can visit CDC's website for more information on the program. So before you get vaccinated, you should learn more about the types of vaccine and how they work. While you're being vaccinated, you should receive a paper or electronic version of a fact sheet specific to the vaccine you're being offered. And after you're vaccinated, you should be given a vaccination record card that tells you what vaccine you received, the date you received it, and where you received it. Your provider may also give you information about how to enroll in vSafe. And it's important to continue to use all tools available to stop the pandemic. So even after being vaccinated, continue to cover your mouth and nose with a mask, stay at least 6 feet away from others, avoid crowds, and wash your hands often. Before vaccination, providers should counsel patients about expected local and systemic post-vaccination symptoms. Depending on the vaccine product, the age group, and the dose, approximately 80 to 89% of vaccinated persons develop at least one local symptom, such as pain or swelling. And 55 to 83% report at least one systemic symptom, such as a fever or a headache. Most systemic post-vaccination symptoms are mild to moderate in severity, occur within the first 3 days of vaccination, and resolve within 1 to 3 days. COVID-19 vaccines may be administered to persons with underlying medical conditions who have no contraindications to vaccination. Some specific groups I get asked about frequently include immunocompromised persons, persons with autoimmune conditions, and people with history of Guillain-Barré syndrome, Bell's palsy, or dermal filler use. Clinical trials demonstrated similar safety and efficacy profiles in persons with certain underlying medical conditions, including those that place them at increased risk for severe COVID-19 compared to persons without these conditions. Persons with HIV infection or other immunocompromising conditions, such as a kidney transplant, might be at increased risk for severe COVID-19. They should receive the COVID-19 vaccine unless it's otherwise contraindicated. Regarding those with prior infections, vaccination should be offered regardless of the history of prior symptomatic or asymptomatic SARS-CoV-2 infection. And viral testing for current infection or antibody testing for prior infection is not recommended before vaccine. For those who have a current infection, vaccination should be deferred until they have recovered and criteria have been met to discontinue isolation. But there's no minimum interval between infection and vaccination. Since reinfection is uncommon in the months initially after infection, while vaccine supply remains limited, people with recent documented infection may choose to temporarily delay vaccination. For those that have received monoclonal antibodies or convalescent plasma, there's currently no data on the safety or efficacy of COVID-19 vaccine. However, it is recommended that vaccine be deferred for at least 90 days to avoid interference of the antibody therapy with a vaccine-induced immune response. So fully vaccinated people can, and before we say that, just want to make sure everyone understands what we mean by fully vaccinated. So that means at least 2 weeks after the second dose of a 2-dose series, such as Pfizer or Moderna, or at least 2 weeks after a single-dose vaccine. So again, fully vaccinated people can visit with other fully vaccinated people indoors without masks or social distancing, visit with other unvaccinated people from a single household if unvaccinated people are at low risk for severe COVID-19, indoors without masks or social distancing, and they can refrain from quarantine and testing following a known exposure to COVID-19 if they're asymptomatic. But please note that this refers to activities in the community. There may be different recommendations for the healthcare setting. For example, it is still recommended that in settings such as dialysis centers, that fully vaccinated individuals who have been exposed need to be isolated and cared for using appropriate precautions. These recommendations are reviewed frequently and will be updated as more information becomes available. This slide just gives a little more detail on what vaccinated people can do compared to unvaccinated people, and I'll read some examples. So for example, fully vaccinated grandparents can visit indoors with their unvaccinated daughter and her children without wearing masks or physical distancing, provided none of the unvaccinated family members are at risk for severe COVID-19. A second example, if a fully vaccinated individual visits with an unvaccinated friend who is 70 years old and therefore at risk of severe disease, the visit should take place outdoors, wearing well-fitting masks and maintaining a physical distance of at least 6 feet. And then continuing this example, if fully vaccinated grandparents are visiting their unvaccinated daughter and her children, and the daughter's unvaccinated neighbors also come over, the visit should then take place outdoors, wearing masks and with physical distancing. This is due to the risk that 2 unvaccinated households pose to one another. Running short on time, so I'm not going to read through all of these because I think we reviewed these, but here you can see where fully vaccinated people should continue to do. And this just talks about some of the scientific evidence behind why we make these recommendations. And it has to do with the risk of transmission of disease and development of severe disease from those who have been vaccinated. And I just wanted to point out that there is a science brief on the CDC website that's continuously updated. So a good idea to keep an eye on that to better understand where the recommendations are coming from. I think I've covered all this as well, so I just want to talk a little bit about the variants. So what is a variant and how does it occur? Viruses are constantly changing, including SARS-CoV-2, which is the virus that causes COVID-19. Changes in the genetic code of a virus are called mutations and naturally occur over time when an animal or person is infected. These mutations can lead to the emergence of new variants that may have different characteristics. So while a certain amount of genetic variation is expected to occur as SARS-CoV-2 spreads, it's important to monitor circulating viruses for key mutations that happen in important regions of the genome. Many mutations do not affect the virus's ability to spread or cause disease because they do not alter the major proteins involved in infection. However, variants with mutations that enhance the virus's ability to spread or cause disease are able to outcompete other variants. This slide here shows just 3 of the circulating variants, but probably the 3 that you have most likely heard about in the news. But really what I wanted to emphasize here that while these are the current variants of concern, there may be others or more or different variants could be targets in the future. And then this table here shows in the US the same 3 variants that were on the prior slide. So you can see as of March 7th how many cases have been reported in the US and how many jurisdictions are reporting these cases. The one most frequently reported has been B117, which was the UK variant with around 3,000 cases. We're still learning about variants and what they mean in terms of disease severity. In regards to the UK variant, this variant spreads more easily and quickly than other variants. In January of 2021, experts in the UK reported that this variant may be associated with an increased risk of death compared to other variant viruses, but more studies are needed to confirm this finding. It has since been detected in many countries around the world, and as shown on the previous slide, this variant was first detected in the US around the end of December 2020. In general, these variants seem to spread more easily and quickly than other variants, which may lead to more cases of COVID-19. An increase in the number of cases will put a strain on healthcare resources, lead to more hospitalizations, and potentially more deaths. So far, studies suggest that antibodies generated through vaccination with currently authorized vaccines recognize these variants. This is being closely investigated and more studies are underway. Some preliminary data suggest that some COVID-19 vaccines approved for use outside of the US may be less effective against the variant first found in South Africa. Some data on the vaccines approved for use in the US, I'll read here, not on the slide, but include Pfizer. And so the preliminary results from the UK demonstrate that vaccination with Pfizer vaccine was highly effective in the high 80s against SARS-CoV-2 infection and symptomatic COVID-19 during a period when this was the predominant circulating strain, so the UK variant. And similarly, Pfizer also has high effectiveness against infection in Israel when there were multiple circulating strains, when the proportion of the UK variant was increasing to around 80%. And for the Johnson & Johnson vaccine, preliminary data suggests that this vaccine may have some reduced overall efficacy against some of the variants, particularly the South African variant. But in the United States, efficacy was 72%. But in South Africa, again, efficacy was only 64%. However, important to know when you're thinking of these numbers that this vaccine efficacy against severe disease was very high and similar across all sites, including the US and in South Africa. CDC will continue to monitor these new variants for any impact on real-world vaccine effectiveness. And COVID-19 vaccines continue to be an essential tool to protect people against COVID-19, including new variants. And one of the best ways that we can impact the development of these variants is by encouraging vaccine use so that the variants have less time to develop and circulate. Those are the end. I think we hopefully have time for a couple of questions. Sorry that we ran a little bit over, but thanks, Erin. Back to you.
Thank you so much, Dr. Novosad, and thank you, Dr. Wardosi, for a great presentation. We do have a number of questions that came in, and several of them are regarding concerns that some kidney transplant recipients have. So I will get right into those. A recent article was published in the Journal of American Medical Association, which indicated that transplant recipients who are vaccinated are not building antibodies quite like the general population is. Can you speak to that? Why are transplant centers not testing for antibodies post-vaccination? What can transplant recipients do? And does this affect their susceptibility to getting some of the variants that are out there?
Yeah, I think those are all really good questions, and I think I'll say some more, but I do think the short answer is we don't know what that means yet, and I think we're still learning. In general, antibody testing is not, currently recommended to assess for immunity following the vaccination, really because we don't understand exactly what a positive or negative result would mean. And there's actually a few reasons for this. One is that there's so many different antibody tests on the market, and they all have variable sensitivity and specificity, and they just haven't been studied in this way. So it's hard to know what an actual titer or number means on the antibody response. Additionally, the immune response has many components, and the antibody response is only one part. Again, I mentioned the level of antibody protection has not been established, and antibody testing doesn't evaluate some of these other parts of the immune system, such as the cellular immune response, which also likely plays a role in vaccine-mediated protection. And then I think probably the other thing that's important that I kind of mentioned a little bit was that there are, again, several types of antibody tests. And if the test isn't looking for the right antibodies, it may not detect an immune response resulting from vaccination. And patients or providers may not always know what type of antibody test they're ordering or exactly what types of antibodies are being tested. So I think that's a long answer to give us several reasons on why we just don't know what the antibody testing means now, which is why it's not really being done widespread or being recommended. I think the caveat to that is that could change as we learn more and can really refine our understanding of what an antibody test means.
Thank you so much. And I think it's probably a good idea to reiterate here what you've been saying, that even if you have received your full the full vaccination, it is important to continue to mask and socially distance when you're out there in social settings and healthcare settings.
Yes, that's very true.
We have a couple of questions regarding immunosuppressive medications that transplant recipients are. Is there any data out there about how this may impact vaccinations or how the vaccination might impact immunosuppressive meds? Does it limit the efficacy of the vaccine?
I'm not aware of any current data that says that, and I think in general for other vaccinations that that we don't necessarily have evidence that the vaccine itself is interfering with kind of the efficacy of the medication. It's generally the concern goes the other way, whether the medication will interfere with the efficacy of the vaccine. So I think the short answer is no, we don't think so right now. But again, I think all of these are really good questions because there's still so much that we have to learn about this particular vaccine and this particular disease and know. I think I did have one slide on vaccine and immunocompromised persons, and I think the key for that is we do get questions a lot about, if people are on some particular types of immunosuppressive medications, should they not get vaccinated? Is it not going to work as well? And definitely reiterating that there's no reason to hold vaccine while you're on a particular immunosuppressive medication, but just important that your provider or whoever is giving you the vaccine kind of knows your medical history and knows all of those details.
Absolutely. Thank you. And we'll close up here with a final question. Is it true that companies like the Moderna and Pfizer that have developed vaccines are kind of retailoring their vaccine to protect against these variants? And if so, will the public be notified when those vaccines are available? And are they going through a similar trial process for those?
Yes, so definitely the vaccine manufacturers are currently engaged in a number of different studies or projects to answer questions about the vaccine, including, how long the duration of immunoprotection may be after vaccination, whether boosters are needed, and then also the very important questions of how effective the vaccines are against particular variants. And so, yes, all of that's definitely being looked at, and I think the public will be notified pretty quickly if any need is for an update for the vaccine or a booster. I do think that's one thing that I've been very pleasantly surprised with, I would say, throughout this process of vaccine approvals and studies, as I do think that the FDA and the manufacturers and other groups have done a really great job keeping the public appraised of their work and getting results out there as quickly as possible. So I think the same will happen for this ongoing work, including the work against the variants.
Great, thank you so much. Again, I want to let everybody know this webinar has been recorded. We will post it on our website. If there were any questions that we were unable to respond to, please reach out to us at info@aakp.org, and we will respond. I'd like to go ahead and close with a few slides on information that may be of interest to you. We encourage you to join AAKP as a free member. We have free membership for kidney patients, family members, and living kidney donors, and you can join online or by calling us. We also ask that you follow us on social media if you have social media accounts. Please also remember to share your email address when signing up with us, and you will be notified by email when opportunities arise where your opinions and experiences are needed to help inform innovation, advance care, and make a meaningful impact to improve lives. AAKP is dedicated to helping patients understand their condition and take control of their health care. We are proud to offer a variety of resources for both patients and caregivers, and you can visit our website at aakp.org, click on the AAKP store button at the top of the homepage, and you can either order brochures or you can download them onto your computer. We hold a number of events throughout the year, and we hope you'll join us. Here's some save the dates for this year. We have our Global Innovation Summit, May 13th and 14th, our annual policy summit on June 17th, and our national patient meeting September 24th and 25th. We hope you will join us. Registration is free, and all of these events will be virtual, and our sessions will be recorded. And if you'd like to view some recorded sessions from our previous events, you can visit our YouTube channel. We are continuing to update our coronavirus resources webpage. We'll also post our webinar recording on that page as well. And again, I'd like to thank you, send a big thank you to our speakers today, Dr. Cecilia Bardosi and Dr. Shannon Novosad, for sharing with us this very important information and updates on the COVID vaccine. We appreciate your time. Thank you so much for working with us over the last year. And we look forward to hearing more and seeing more progress with everybody getting vaccinated and hopefully returning to a more normal time very soon. Again, if you have any questions about what you heard on today's webinar, please send them to info@aakp.org, and we will work to provide a response to those. Thank you again, everyone, for joining us today. Be informed and stay safe.
I think the work that is being done by AAKP is so critical to patients all around the country. Their ability to advocate on our behalf ensures that everybody understands the impact of kidney disease and what they can do to help us.
Now everybody is fully understanding that to achieve a better quality of life, you really need to listen and take into consideration what the patient views as a better quality of life for them.
I always have fun at an AAKP event. How could you not have fun? You're with people who understand completely what you and your family are going through. So it's not just for patients, AAKP. AAKP should be for the family of patients, because when a patient has kidney disease, the family has kidney disease.
Belonging to an independent advocacy organization like AAKP gives me the confidence that I can represent them and people living with kidney disease to represent them honestly.
Our objective over the coming decade is to reach people around the globe and not just limit it to the United States, because kidney disease is a universal disease.
They encourage patients to be the voice for their care and treatment. And I don't see that as much in other organizations. And I feel like that is so necessary for patients to feel like they have a voice and they can make change in regards to their care and treatment.
It's important to be a patient advocate because to whom much is given, much is required. I was given this gift of life back in 2008 by my donor, Leanne, rest in peace. She was a deceased donor. So now if I can use my voice and use my platform and influence to impact lives, and my favorite word, why not? And why not become an organ and tissue donor today?
We spend a lot of time here, particularly in DC, in the nation's capital, talking with staff, with the legislators, and trying to help them understand exactly what the patient perspective is on anything that's kidney or renal related. It's a great honor to be able to do it. Our numbers are growing, and part of our strategy is for them to understand that we will come and visit and talk with them, and we represent the patient voice, and we want that to be heard, and that's how we do it.
People around the world who are sick and suffering with kidney disease need a voice of optimism, they need the tactics, and they need the reinforcement from fellow patients here in the US to do what they do and demand a change in the status quo. And we fully intend to arm patients around the world with the tools they need to be more vocal with their governments, regardless of the ideology of their government, and to demand solutions and to defend private sector companies and investors who are willing to get into this space and deliver more innovation for patients.
AAKP opens the door so that it broadens the whole horizon. You're one person. When you belong to AAKP, you suddenly become a tribe.
Welcome to another Healthline webinar from the American Association of Kidney Patients, titled Kidney Patients and the COVID-19 Vaccine. This is our first patient education event for 2021. Thank you so much for joining us today for important information regarding the coronavirus or COVID-19 vaccine and kidney patients. If you have been tuning into our webinars over the last 10 months, you have had access to information from AAKP's trusted federal partners like the Centers for Disease Control and Prevention, the National Institutes of Health, the Food and Drug Administration, and other key allies, including transplant surgeons. My name is Erin Kale, and I am Director of Stakeholder Operations for the American Association of Kidney Patients. I oversee our patient education and grassroots engagement activities, including our Ambassador Initiative, which comprises highly motivated and engaged patients and caregivers around the country and the globe. These individuals have a direct connection to kidney disease and wish to raise awareness and provide support to others navigating the challenges of this chronic disease. AAKP's Healthline webinars fall under our Center for Patient Research and Education. We believe patient and caregiver education is an integral part of treatment and protection of patient lives, and we work to ensure that the patient has a central role in research and guidance that are designed to determine optimal approaches and strategies for providing healthcare services, assistance programs, and access to new products and services. This is especially true during national emergencies such as the coronavirus pandemic. In early 2020, as the COVID-19 pandemic evolved, AAKP changed all 2020 events to free virtual access, prioritized COVID-19 topics, and implemented strategies to involve a wider audience. Over the past 10 months, AAKP has broadcast expert COVID-19 insights through 1 global and 2 national virtual events, a dozen webinars, and launched advocacy campaigns to highlight disparities in minority and kidney patient representation in COVID-19 clinical trials and vaccine distribution protocols. AAKP leadership has participated in numerous webinars discussing remedies for disparities in these areas I just highlighted. In fact, in 2020, over 24 AAKP patient advocate leaders received the nonpartisan President's Volunteer Service Award for their efforts to educate kidney patients on the risk posed by COVID-19. For nearly 20 years, this national award has recognized volunteer leaders who have made a substantive impact on some of the most critical problems facing the nation. Throughout 2021, AAKP will continue to honor our obligation as the largest kidney patient organization in America to provide timely education to kidney patients and their families. I'd like to introduce AAKP's president, Richard Knight, and invite him to say a few words. Richard is a kidney transplant recipient who spent time on in-center hemodialysis. Richard?
Thank you, Erin, for that kind introduction. As we all know, the coronavirus has been a serious threat to all Americans. especially those with underlying health conditions and who are immunosuppressed, like kidney patients. I pray for everyone who is facing or has faced the threat of this disease. It is constantly on our minds. I am asking all who are listening to stay connected to AAKP and to share your involvement in our online efforts, because although our reach is growing, we believe we need to educate more patients on how serious this virus is and the threat that they face. In 2020, AAKP volunteers enhanced the organization's national and global reach. How do we do this? We accomplish this by our unique virtual platforms, developing international patient group partnerships, writing clinical journal editorials, television, radio, social media, and our ever-growing Patient Ambassador Initiative. We are flattered by the growing number of ambassador programs throughout the kidney patient arena. But the uniqueness of our Patient Ambassador Initiative remains because it is led by patients who remain an integral part of AAKP. Viewership for 2020 AAKP programs now exceeds 80,000 people across 70 countries and is rapidly growing. International and national program faculty has included 90 medical practitioners and researchers and 60 patient experts. The AAKP Global Summit on Kidney Innovations, conducted in partnership with the George Washington University School of Medicine and Health Sciences, alone reached over 20,000 patients and professionals worldwide in July of 2020. Until the vaccine is widely distributed and the threat of COVID has significantly decreased, we will continue to hold our annual programs and events virtually so individuals around the country and the world can participate easily and safely from the safety of their own homes. I will now ask my fellow transplant recipient and AAKP Chair of Policy and Global Affairs, Paul Conway, to talk about our survey research that led in part to today's call. And I should also mention that Paul is the liaison to the Centers for Disease Control, Health Infectious Control Practices Advisory Committee, HIPAC, and CDC is a long-standing ally of AAKP. Paul?
Thank you very much, Richard. The basis of our webinar today actually comes from kidney patients and the unique tools that AAKP has through survey research to find out what their concerns are about COVID-19 and ways to address it. One of the primary issues right now is vaccine distribution, but AAKP has actually been surveying our patients on COVID-19 related issues, fears, and concerns for the past year. What I'd like to do now is briefly go through a series of slides with you to show you some of the key insights that led to today's program and also formed the basis of much of our programming last year around COVID-19. On this slide, you can see a question that AAKP posed to patients at the close of 2020 at the start of the holiday season. At that time, AAKP asked our patient members whether or not they were more or less concerned about COVID-19 and the risks than they had been in March of 2020. As you can see here, nearly 80% of AAKP members were more concerned about COVID-19 than they had been at the start of the year. Only 12% were less concerned and 9% were unsure. The next question on this slide that was posed at that same period of time was, how concerned are you about the risks? And fully 71% of our members indicated that they had a strong concern about the risk of COVID-19. On this next slide, you'll see another question that AAKP posed to our patient membership prior to the holiday season. At that time, we were trying to figure out how much COVID-19 had actually impacted the planning of individuals in regard to the holiday season. And on here, you can see that nearly 75% of the respondents indicated that they had actually changed their plans for how they intended to celebrate the holidays with their family and friends. 12% had not made a decision just a few weeks before the holiday season began. Only 13% indicated that there was no change of plans due to COVID. And then we asked in the drill down what the specific concerns were and the specific impacts. And as you can see, over 60% of the patient respondents indicated that they had made the decision not to travel. In this slide, you'll see specific questions that AAKP asked to find out the practical impacts of COVID-19 on friends and family of kidney patients, and also the economic impact. In the first question in the top left, you'll see that 41% of those who responded to our survey indicated that a member of their family or a close member in their circle of friends had been impacted by the COVID virus. Interestingly, on a second question that we asked on how COVID-19 was impacting patients, we asked whether or not the patients or a member of their immediate family had experienced a layoff or job loss due to the economic impacts of COVID-19. 32% indicated that they either knew somebody or they themselves had experienced a layoff or a job loss. 65% indicated no. What's interesting to us is fully 1/3 of kidney patients that were responding in this survey at the close of 2020 had already been impacted by COVID-19. In this next slide, we asked patient respondents whether or not they were planning on getting the COVID-19 vaccine when it was made available to them. 75% said yes, 7% said no, and about 18% indicated they were uncertain. That uncertainty is one of the things that AAKP is going to be focusing on in terms of patient education to increase that number, and we will also seek to educate those who are saying no to make certain that their concerns are allayed and that they hear from medical experts on the need to get the vaccination. On this slide, our last slide, we asked those patient respondents whether or not they had already received the vaccine. Only 14% indicated yes, 86% indicated no. Now, the mix of patients here are both transplant patients and dialysis patients, and those who are suffering from chronic disease who have not experienced kidney failure yet. So we have a lot of work to do. 14% of those who are eligible have received it. 86% of those who could receive the vaccine have not yet received it. And this is the charge for the kidney community. We must work as patients and as professionals together to make certain that we educate patients on the need, and we also educate patients on where they can go to get a vaccine once it becomes available in their area, and what to look for in terms of reactions and impacts so that they can keep their medical professionals fully informed. Again, these are some of the data insights that we're able to develop through AAKP's Center for Patient Education and Research. These are the same types of insights that we provide to elected leaders on Capitol Hill in both the House and the Senate and their staffs, and these are the types of insights that we share with elected leaders and appointed leaders in the new administration of President Biden and Vice President Kamala Harris. We've provided these insights in previous administrations throughout the presidential transition process, and we'll be kicking up the speed of our delivery of data throughout 2021 as the new presidential team comes into place and begins deliberating the crafting of their own kidney policies. But in the meantime, on this particular issue of COVID-19, you can trust AAKP to stay actively engaged and to make certain that the concerns of kidney patients, whether they run from clinical trials to vaccination, are fully represented in every major policy decision that's made, both in the private sector, in the research sectors, and in the federal government. Thank you very much for joining us today, and I'll throw it back over to Erin.
Thank you, Paul. I'd now like to introduce Dr. Deidre Cruz. Dr. Cruz is a board-certified nephrologist and the professor of medicine in the Division of Nephrology at the Johns Hopkins University School of Medicine. She is Associate Vice Chair for Diversity and Inclusion in the Department of Medicine. Her core area of research addresses disparities in the care and outcomes of chronic kidney disease. We are so pleased to have Dr. Cruz join us today. Dr. Cruz, I turn things over to you.
Thank you, Erin, and thank you, AAKP, for the invitation to be with you all today. As was said, I'm Deidre Cruz, and I'm really pleased to share with you all today a bit about COVID-19 vaccine basics that are pertinent for kidney patients. So when it comes to kidney disease and COVID-19, what we've seen is that Americans living with kidney disease, and especially people who are treated with dialysis or who have received a transplant, have been at increased risk for severe infection from COVID-19 and have also been at increased risk of hospitalization and death. And so it's really important now that we have vaccines available to think about how those vaccines may be able to prevent COVID-19 illness among people living with kidney diseases. For many of us, we've been concerned about how quickly it seems that the vaccines that are now available have been developed. But as it turns out, they have actually each undergone all of the 4 phases that are typically undertaken when it comes to the approval process for vaccines or any drug, really, that the Food and Drug Administration or the FDA approves. So meaning that for each one of these now available vaccines, they first started off with a phase 1 portion of the clinical trials that were conducted, where around 20 to 100 healthy volunteers were included, and issues surrounding safety of the vaccine was tested in those individuals. They then went on to phase 2, where several hundred volunteers were involved, and questions such as what are the most common short-term side effects of the vaccines were examined. And then they moved to phase 3, where thousands of volunteers were included. And it's here that in clinical trials that we can then look at whether the drug, or in this case the vaccine, is actually doing what the investigators hoped that it would do. And so in this case, looking to see whether the vaccines led to a reduction in COVID-19 infection. And then finally, once the vaccines or any type of drug that the FDA approves, once it's approved, then it goes into phase 4. And it's in this case that it's been demonstrated to be safe and effective, and that the benefits outweigh the risk. And so that's where we are with the available vaccines. And so as you may have heard, the available vaccines for COVID-19 are messenger RNA vaccines, or mRNA vaccines. So what are these mRNA vaccines? So these are types of vaccines that carry genetic material that actually teaches our cells to make a harmless piece of a spike protein. And the spike protein is found on the surface of the coronavirus virus, or the SARS-CoV-2 virus. And this is genetic material from the vaccine that ends up being destroyed by our cells once copies of the spike protein are made and it's no longer needed. And so cells will display this piece of spike protein on their surface, and an immune response is then triggered inside our bodies. And this produces antibodies to protect us from getting infected if the coronavirus enters our bodies. And so important to note that when it comes to mRNA vaccines, they actually do not affect our DNA, and they do not enter the cell nucleus. And these types of vaccines cannot give someone COVID-19. And while for many of us, this may seem like a very new technology because maybe we hadn't heard about mRNA vaccines, as it turns out, these types of vaccines have been studied for other viruses, including influenza, the Zika virus, rabies, and also CMV. And so there have been COVID-19 vaccines that have now reached Food and Drug Administration emergency use authorization. The two are the vaccine developed by Pfizer and BioNTech, which was demonstrated to be 95% effective at preventing COVID-19 infection, and the Moderna vaccine that was demonstrated to be 94.5% effective. So extremely effective vaccines, particularly compared to some vaccines that we may be more familiar with, like the influenza vaccine, which has been actually less effective at preventing influenza. Now, both of these are mRNA or messenger RNA vaccines, and they include a 2-dose schedule. And these doses are separated by 21 days and 28 days, respectively. The duration of protection against COVID-19 is actually not yet known. There are ongoing analyses of the clinical trials that were conducted for these vaccines to help us to understand how long this protection will last. And this will have important implications for things such as whether people who receive the vaccine will need to be vaccinated again, and if so, when? So after what period of time? Will it be 6 months, a year, or longer, for example, before someone would need to be vaccinated a second time in order to continue to have protection? But both vaccines were tested in diverse adult populations that included older adults and also included individuals from communities of color. For example, 9% in one trial and 10% in another included participants who identified as Black or African American. There has not been data yet on whether people with kidney diseases were included in the trials for the Pfizer or the Moderna vaccines. The Moderna study did, we know, include 9.5% of individuals who had diabetes, which, as you know, is one of the most common causes of kidney disease. And so we know that these mRNA vaccines are expected to produce some side effects after vaccination. And this is especially the case after the second dose. Some of the most common side effects include fever, headache, and muscle aches. There have not been significant safety concerns that have been identified in the clinical trials that were conducted for these vaccines. And at least 8 weeks of safety data has been gathered for the trials that have been conducted. And it would actually be considered unusual for side effects to appear more than 8 weeks after the vaccination. You'll see on the right a picture of me getting my vaccine, my first dose. And I had minimal side effects, just some soreness in the arm where the vaccine was injected, and that went away within 2 days. And so both the Pfizer, BioNTech vaccine investigators as well as the Moderna vaccine investigators did report on the side effects that were reported among participants of their trials. So in the case of the Pfizer one, pain at the injection site was the most common reported side effect. There was some redness and swelling at the injection site for some individuals. Fatigue, headache, muscle aches, and chills were also reported and were the most common sort of systemic responses or responses that happened all over the body. All of these side effects were noted to have been worse after the second dose of receiving the vaccine. And after that second dose, fever was reported in up to 16% of the participants. Notably, younger adults, as compared to older adults, were more likely to have these sorts of side effects. When it comes to the Moderna vaccine, again, they reported slightly more severe side effects or more frequent occurrence, not severity, but more frequent occurrence of side effects among the younger adults. They were, again, mostly pain at the injection site, and for some people included some swelling, including some swelling of the lymph nodes or lymphadenopathy and some redness. And these side effects were worse after the second dose. You can see that there was a difference again between these age groups for the older adults greater than 55 years of age, they had fewer of these initial type of symptoms, including sort of the pain at their injection site, than did the younger individuals. But again, there were reports, though, of fatigue, headache, myalgias, and arthralgias, as well as around 10% of the recipients of the Moderna vaccine who were in this age group did report fever. And so safety, of course, is always a concern. And for anyone who's thinking about receiving the vaccine, it's important to note that this vaccine has already been undergoing the same sort of safety processes that is the case for all of the vaccines and medications that are approved by the Food and Drug Administration. And so here, what's been tapped into are these existing systems and data sources that are used to monitor the safety of vaccines after they've been authorized for use, including those listed here. There has also been a new system that has been developed in order to monitor COVID-19 vaccine safety, in specific one called vSafe, and it includes active surveillance that uses text messaging to initiate web-based survey monitoring. So here, individuals who enroll in vSafe are then able to send in a text message if they have symptoms, and those are being tracked and will be periodically reported. And then these same individuals enrolled can provide telephone follow-up as well, or are provided telephone follow-up should they develop medically significant adverse events. So when thinking about who should or should not get the vaccine, In the category of should get the vaccine, really everyone who is eligible should probably get this vaccine. There unfortunately are no data yet on kidney patients specifically, but given the risk of COVID infection, including the risk of hospitalization and death that I mentioned earlier, the potential vaccine benefits are quite high. Those who have had prior COVID infection should also get the vaccine. What is recommended is that they wait 90 days after they first develop symptoms from that COVID infection, or were first told that they had COVID infection, before getting the vaccine. The groups of people who should not get the vaccine are it's a fairly small group, but it includes individuals who have a history of severe allergic reaction, including anaphylaxis, after having a dose of an mRNA COVID-19 vaccine, or for those people who have a documented allergy to one of the components of the COVID-19 vaccine, including those who may have an allergy to polyethylene glycol, or PEG. People who have had immediate allergic reactions of any severity to polysorbate as well should not get the vaccine, and that's because it kind of can have a similar response in those people to what it has for those who have an allergy to the ingredient PEG. The CDC, or the Centers for Disease Control and Prevention, has put forward priority groups for receiving the vaccine, but at the individual state level, states are following their own guidelines, in most cases in accord with the CDC, but with some nuances. The CDC, however, has put forward these 3 different phases, with phase 1A, including healthcare workers and both residents and employees of long-term care facilities. And then in phase 1B, frontline essential workers, including those working in the educational area, such as teachers and others who work in school systems, are prioritized, and also people who are more than 75 years of age. In phase 1C, people between the ages of 65 and 74 would be considered the priority group, and those who are between the ages of 16 and 64 who have underlying medical conditions, and also other essential workers, such as people who may have professions where they are interacting with lots of people on a day-to-day basis. And so where can you go to get vaccinated? This certainly varies by location, both on a city and a state level. But there are numerous options. Some health departments are administering the vaccines, pharmacies, and also health clinics. In some areas around the country, there are drive-through vaccination services being provided. Some employers are also providing vaccination to their employees, depending upon what sort of priority area those employees fall under. And then also some dialysis facilities across the country are rolling out vaccination programs for both their staff as well as their patients. And so there are some unknowns that remain about the vaccines that are important to highlight. The first is that, again, we don't know how long protection will last from the vaccines. We also don't know if boosters will be needed in the future, so meaning an additional dose of the vaccine in order to continue to allow those antibodies to be produced by the body and protect us from COVID-19. We don't know whether these vaccines will prevent asymptomatic infection. So the clinical trials that were conducted and have been reported included COVID-19 infection where those individuals actually had symptoms of COVID-19. But we don't know, because it wasn't part of the design of those clinical trials, whether the vaccines prevent the infections with COVID-19 that don't necessarily produce symptoms. There are many subpopulations of individuals in which we don't know about efficacy of these vaccines, including people living with kidney diseases. And we also don't know if these vaccines prevent transmission of the SARS-CoV-2 or COVID-19 to susceptible individuals. So meaning we don't know if once a person has been vaccinated, if that means that they can't spread COVID-19 to another person. And so it is important and continues to be important for us all to continue to wear masks and also physically distance to continue to prevent the spread of COVID-19 infection. And so to summarize, COVID-19 has disproportionately impacted people living with kidney diseases. 2 vaccines are now approved for COVID-19, and studies of the vaccines have not yet reported results for people with kidney diseases. Yet most clinicians do still recommend that their kidney patients receive the vaccine given the risk of COVID-19 infection to people who are living with kidney diseases. I thank you for your attention, and again, thank you to the AAKP for this invitation.
Thank you, Dr. Cruz. I'd now like to introduce Dr. Michael Allen Reese. Dr. Reese is a transplant surgeon and professor at the University of Toledo Health Science Campus, departments of urology and pathology. His areas of interest include renal transplantation and kidney paired donation. In 2006, Dr. Reese founded the Alliance for Paired Kidney Donation, producing the first non-simultaneous pay-it-forward chain of transplants in 2007. And he carried out the first global kidney exchange starting in 2015. AAKP honors Dr. Reese in 2021 with the AAKP Medal of Excellence in the Transplant Surgeon category. Dr. Reese, thank you so much for joining us today. I now turn things over to you.
Hello, my name is Michael Reese, and I'm a transplant surgeon at the University of Toledo Medical Center. But I also hold a PhD in immunology from the University of Cambridge in England. So I'm pretty well versed in how the immune system responds to different pathogens. And today I'd like to talk to you a little bit about COVID-19. The reason I'd like to talk with you is because I'm really excited. I think it's a real testament to human ingenuity that we've been able to respond so quickly and come up with the wonderful vaccines that are now available to us, particularly the Pfizer vaccine and the Moderna vaccine, these mRNA vaccines. It's the first time they've ever been used in humans, and that makes everybody a little frightened. But I want to spend a little time talking with you about why I'm super excited about them. Typically, when we make vaccines, what we do is we take a piece of a protein, or we take an injured virus. But in some patients, like immunosuppressed patients who've had transplants, those injured viruses can still be harmful and even kill people. You know, when we first came out with vaccination, it was Edward Jenner back in the 1700s, and it was identified that we could overcome smallpox, which doesn't really exist today. But do you know, it used to kill 20 to 30% of the people that got it. And if you vaccinated people, it killed about 2 to 3% of the people that were vaccinated. And so we face this difficult decision. Do I take a 2 to 3% chance that I'm going to die for sure? Or do I take a risk that I'm going to get the disease and have a 20 to 30% risk of dying? Well, fortunately, that's not the situation with COVID. While lots of people have died from it, also there are lots of people who've had the disease and who haven't died from it. So this is really about patients at risk and about trying to get herd immunity. And what I'm excited about is the safety of the vaccine. It really hasn't had any serious side effects other than that people have gotten a little sick. You know, they get a fever or that hurts in their arm. But what I like to think is something like 16% of patients will have a bit of a reaction, a fever, or feel ill with the second shot. Nobody knows this, but I wonder if those aren't the very people that would get the sickest if they actually got the virus because of the response that they're having. Of course, we'll never know that, because the wonderful thing about a vaccine is it makes it so you're not going to get the virus. And in fact, another wonderful thing about this vaccine is that while it has clearly stopped a lot of people from getting any symptoms at all, because they really only measured people who became symptomatic, it stopped all but about 1 or 2 patients out of 30-some thousand patients from actually getting very, very sick from the disease and having to be hospitalized. So this vaccine really achieves what we want it to achieve, but it's doing it in a very cool way. And in fact, I'd like to tell you a little story now about why I think it's possible that the way we were forced into using this mRNA vaccine, because we could do it so quickly, may actually have opened up a faster pathway to these vaccines, which may one day help us overcome some cancers. So I think that's just a really exciting breakthrough. It's going to prove how safe these vaccines, millions of people have received them in the United States, and there's just not reports of a lot of terrible things happening. So let's talk a little bit about the mRNA vaccine itself. How does it actually work compared to using a virus that's been harmed in some way, so it's not thought to be very effective, or by using a piece of a protein? In this case, what we do is we actually can figure out what is it that the virus makes that helps it attack us, and what is it that when we make an immune response against it is protective to us. And we now understand that this virus has a spike protein on it. What we're able to do is to take the genetic material think of it kind of like the architectural plans for a house. The DNA is like the architectural plans for that spike protein. And what we do is we've packaged that. That's what the mRNA is. The messenger RNA is the message that allows the body to read that message inside of a cell and to create the spike protein. And when that spike protein gets produced, it gets produced in a way that makes our immune system be able to respond to it in just the right way to create the best type of immune response. So we've packaged that mRNA in such a way that it's covered with things that looks like the outside of a cell. And then the parts of the immune system that we want to recognize it and grab onto it will do that. They're called antigen presenting cells. But they can also get into other cells of the body, and that's what viruses do. They get into our cells and they start replicating themselves. But when we inject just the protein into people, it doesn't get inside the cell and made inside the cell. And that's important because our immune system responds in two particular ways to pathogens and to bad things that are trying to harm us. One is those things that come from the outside world, and the other way is from things that are made inside of our cells, like cancers or viruses. Viruses take over control of our cells, but they're actually made inside the cell. And we need to figure out how to get the immune system, which is outside the cell, to be able to see it. So this mRNA vaccine puts the mRNA inside the cell. The cell itself actually makes the protein, and then it can get processed in one of two ways. It can either get processed and go out to the surface of the cell and say, hey, I'm making this bad thing, and the immune system can respond to it, or that those cells can die and other cells can eat them and say this is outside of the body, and they can present it to another part of the immune system. But what they're showing the immune system is that spike protein, and they're showing it in just the right way so the immune system responds and makes a very strong immune response, which then has memory, and we believe will protect us for a long time. But of course, we don't know exactly how effective it's going to be and how long the vaccine is going to work for us, and whether it's going to continue to be protective against the mutants that we see coming out, the mutations to the virus. But I think it's a testament, as I said at the beginning, to human ingenuity that within a matter of months, we were able to understand what is it that's infective and bad about this protein, to isolate just that little bit, and to put the mRNA into the right type of package so the immune system could take it in and then generate the appropriate immune response. And then it goes away because mRNA doesn't last very long. So it's not like if you inject a virus, that stays with you. If you inject a piece of protein, that stays with you for a long time. But if you inject this mRNA, it comes in, and the body's made to destroy mRNA very quickly, so it doesn't last very long, and it's gone. And all you have is a great immune response that's going to save a lot of lives. And so I highly encourage anyone who's watching this to get the Pfizer or the Moderna vaccine. And I would also encourage transplant patients to do that. But we're going to talk a little bit more now specifically about transplant patients and the safety of this vaccine for patients who are immunosuppressed. Thank you very much.
Thank you, Dr. Reese. I'd now like to introduce AAKP Board of Director member and Ambassador Dale Rogers. Dale is a transplant recipient, a former in-center dialysis patient, and has recently received the first dose of the COVID-19 vaccine. He is joining us today to share the conversations he had with his healthcare team when deciding whether or not to receive the vaccine. Thank you for joining us today, Dale, and I turn things over to you.
Thank you, Erin, for that introduction. And thank you, everyone, for attending AAKP's webinar. I'd just like to say that I struggled back and forth with whether I was going to get the COVID vaccination or not, and I decided that I was going to use my patient voice to make my patient choice. So the first person I talked to is my local nephrologist, and my local nephrologist told me that he thought it was going to be beneficial for me to get the COVID vaccination. But then he said, I'm not sure when you should get that COVID vaccination, if you should get it right away, or if you should get it down the road after some testing has been done on it, and they know more about people that are immunosuppressed taking it. And so we both agreed that I was going to wait and talk to my transplant nephrologist and communicate with him on what his thoughts were on getting the vaccination, and then his thoughts on when I should get that vaccination. And on December 23rd, I had my yearly follow-up with my transplant nephrologist, Christopher Blosser out of the University of Washington. And Christopher Blosser, as soon as I asked him, he said straight out to me that the pros of getting the vaccination way outweighed the possibility of possible side effects of the vaccination. And talking a little bit more about it, he encouraged me to get that vaccination just as soon as I possibly could. Other conversations that I had with people getting to about myself getting the vaccination, because I believed that each patient needs to educate themselves whether that vaccination is right for themselves or their medical professionals believe that they should get it at another time. I talked to my pharmacist. One of the thing that's talked about out in the world that you hear about is people's afraid to get the vaccination because it's a new process. And my pharmacist, when I talked to him, he told me this isn't a new technology. This is a technology that they've been studying for years and years. It was just they didn't know if they could use it on this type of process. But he told me that the vaccination was going to be beneficial to me. And he also told me that even more so than me getting the vaccination is to making sure that my caregivers and the people that surrounded me, like my family and friends, would be very beneficial to me if they got this vaccination, because then it would keep them from putting me at risk of themselves, any of them having it and being around me. So then at that point, I decided, wow, this is looking pretty strong towards when that I should get it. At that point, I was pretty determined that I should get it. And then a fellow ambassador, Kent Bressler, he sent me a link. And this link went into detail about Fred Hutch Hospital in Seattle, and also Dr. Fauci talking about that a little cure of the vaccine was better than no cure at all, and just being out there walking amongst the COVID virus, meaning that if the normal person was vaccinated and had a 95% acceptance rate and coverage, that I, being immunosuppressed, may not have that. But even if I had 10% coverage, it was better than having no coverage whatsoever. And so after reading the article, after talking to my doctors and my medical professionals, I decided that the vaccination was right for me. So anyhow, as you guys have probably seen on Facebook, I chose to get the vaccine, and I put it up on Facebook for everybody to see. I go back for my second vaccination on February 1st, and I will also post February 1st on how that vaccination affected me. Because my first vaccination, it made my arm just a little bit sore, nothing to talk about, and that's just from the needle going into my muscle. And anybody that's been on dialysis, that's had their arm poked with the straws that they stick in our arms from dialysis, wouldn't even see this needle as being any big issue. But February 1st, I will take that second vaccination, and I will keep everybody on Facebook aware of how it's affected me. They tell me that the second vaccination has more possibility of me feeling symptoms from the vaccination, but I'm yet to find that out. So I hope that everybody has enjoyed and learned something from the webinar that AAKP's put on today, and use your patient voice to make your patient choice. Thank you.
Thank you, Dale. We appreciate you sharing with us today about your experience getting the vaccination. On January 12th, AAKP deployed a flash survey to our membership to ask about top concerns and questions kidney patients have about the vaccine. We will now address some of those questions. Dr. Cruz, I'll start with a few questions for you. Are the vaccinations as currently deployed safe?
Yes, I believe they are safe. And the way that I feel assured of that is because the process of developing them has gone through the same sort of series of steps that the Food and Drug Administration requires of any new vaccine or for any new medication for that matter. And these vaccines, while they seemed, I think, to most of us to have sort of appeared on the market pretty quickly, I think it's important to note that the technology that they use with the messenger RNA or the mRNA has actually been developed even before this COVID-19 pandemic. And so when this pandemic emerged, those researchers that had knowledge of this type of technology were able to quickly go into working to develop a vaccine. And so that's why that this sort of came to the fore more rapidly than what I think many of us expected. But then even after they had developed it, the process of walking through each of the 4 steps of being able to take a vaccine from the point of testing it out in a small group of individuals, all the way up to now being able to deploy it out into the broader population, really followed all of the steps that we see happen for any vaccine that the Food and Drug Administration approves. And so given that, the safety profile is actually quite good for these vaccines, I do believe that they are safe.
Thank you for that answer. What are some of the side effects or reactions to getting the vaccination, and how common are allergic reactions?
So some of the most common side effects to receiving the vaccine include things located really at the injection site. So most people have the COVID-19 vaccine injected into the muscle, the upper part of their arm. And the most common reactions are just some pain there at the injection site, some muscle aches of that site. Usually those will disappear in just a couple of days, particularly after that first dose of the vaccine. There are reports of people after the second dose of the vaccine having more side effects, including some people having more generalized body aches from it, some people having fever from it as well. As far as severe reactions, including allergic reactions or even anaphylaxis, those were extremely rare in both of the trials, for both the Moderna vaccine as well as the Pfizer-BioNTech vaccine. And They are part of the reason why for individuals who have a history of having anaphylaxis, they are actually being advised not to receive the COVID-19 vaccine at this time. But even in the clinical trials, those types of events were extremely rare. And so for most people, the side effect profile is quite good, and meaning that reactions to it are quite limited and quite mild.
Are the current vaccinations safe for CKD and dialysis patients? Has one vaccine over another been preferred for CKD and or dialysis patients? And can you tell us why?
So when it comes to the reports of the two available vaccines, including their reports of the clinical trials that were conducted for both of them, they did not provide information about how many individuals included in the clinical trials had kidney diseases. And so we actually don't know how effective it was for kidney disease patients or people with kidney diseases in specific. And so we do know, though, that for some of the people that were included in the trials, that they did have some comorbid health conditions, such as diabetes in some cases, some of the very common comorbid health conditions that people with kidney diseases may have. Some of those individuals we know were included in these trials. The Moderna vaccine, for example, did include 9.5% of participants who actually did have diabetes. But we don't know specifically about people with earlier stage chronic kidney disease or those with end-stage kidney disease, in that those people were not specifically reported upon in these trials. That being said, given what we have seen in terms of the impact of this COVID-19 pandemic on people with kidney diseases, it is still recommended that people with kidney disease, and maybe more so than others who may have other health conditions or those who don't have other chronic health conditions, should really pursue getting this vaccine, because the potential benefits of not having COVID infection are much more likely to sort of outweigh the risk of the receiving the vaccine, even though we don't yet have the specific data about people with kidney diseases. Certainly there is hope that there will be reports as the months progress and more people are receiving the vaccine. We certainly do hope that we will be receiving information about the impact and the effectiveness of these vaccines on individuals with kidney diseases. But certainly, I think the potential benefits of them really speak to a need for people to pursue them even now while we're still gathering data about the vaccines. And then to the second part of the question regarding, is there a particular one of the vaccines that are currently available that is preferred for people who have kidney diseases? The answer to that is no. We don't have any reason to think that one of the vaccines over the other would be preferred for people with kidney diseases. And so, I would encourage people to receive the one that's available in their locale and that they're able to get the soonest of the two that are currently available.
Will the distribution of vaccinations change current protective measures recommended by the CDC, such as masks, social distancing, etc.?
So it's unlikely for the distribution of the vaccines to change those public health measures, masking, physically distancing, in the short term. But in the longer term, the vaccines are certainly the way that we get back to the previous way that we lived, where we didn't have to wear masks and we didn't have to physically distance. And so, but that will require a large number of individuals. Some estimates have been around 70% of the population to have been vaccinated in order for us to approach that place. And I think it will also require that we have seen that there's efficacy in terms of the long-lasting impact and long-lasting efficacy of these vaccines before we'll get to a place where we can do away with masks and do away with the physical distancing. And so, unfortunately, it won't be an immediate sort of a solution to those public health measures that we've all been asked to follow.
Thank you, Dr. Cruz. We have one additional question for you. Will my dialysis center provide the vaccine, or will I need to go to my local pharmacy?
So it varies by location. In some cities, counties, states across the country, the vaccines are being rolled out in pharmacies, health departments, medical clinics. In other places, there are dialysis facilities that are providing the vaccines to their patients and also to the staff working there. And so what I would encourage anyone to do would be to ask at their dialysis facility what the plans are for being able to provide the vaccine to patients there, and also to take into account what the timeline is for that plan. It could be that for a given person that they may be able to receive the vaccine from another source, such as through their local health department or at a local pharmacy, prior to when it may be available at their dialysis facility. It'll be important that the first and the second dose are of the same vaccine. So if you receive a first dose that's a Moderna vaccine, you'll need to receive your second dose. It's also Moderna. But I would encourage people to go with the first available option, regardless of whether it's at their dialysis facility or through another source.
Thank you, Dr. Cruz, for answering some of these important questions that are on patients' minds. I'd like to now turn it over to Dr. Reese to address some questions as well. Are the current vaccinations safe for transplant patients? Has one vaccine over another been preferred for kidney patients? And if so, why?
Well, we don't have any evidence yet whether these new Moderna and Pfizer vaccines are going to be effective for transplant patients. I suspect that they will be safe for transplant patients, although I guess they haven't been tested, so we don't know if they're safe or effective yet. They've only been tested in normal patients, not immunosuppressed patients. So we really don't know the answer, but they work very well for normal patients. And I think the evidence is that these will be safe and effective for transplant patients. So I'm recommending all of my transplant patients receive either the Moderna or the Pfizer vaccine. I think these vaccinations are safe because the mRNA comes in and it just makes the spike protein. It doesn't make any other parts of the virus, so it can't make patients sick. Some of the inactivated viruses that are used for vaccinations, but they're live viruses, can actually make immunosuppressed patients very sick. So I don't recommend those for my patients. But something like this is a whole new way of doing vaccinations, and I think it's going to revolutionize how we do things, because we can figure out what the immune system needs to be able to respond. Then we can just get that little tiny bit, package it properly, put it into the right vehicle, get it into the body, and the body will then make exactly what we need the immune system to do to protect us. That is so exciting to me because we haven't really been able to figure out, in many cases, how to turn on the immune system to cure us from cancers. So I think it's likely that these mRNA vaccines, after we prove that they're safe and effective with COVID, we're going to start being able to personalize medicine. So if a patient gets a cancer, we'll figure out what it is that changed in the DNA to what went awry so that cancer cells could be produced, how the proteins were changed. We'll take that little bit of DNA that was responsible for that change, we'll package it inside as an mRNA and deliver it just like we're doing with the Moderna and the Pfizer vaccine, and allow the immune system to be turned on in just the right way that it makes an immune response against that little protein that went wrong. And then the body will be able to protect itself and kill the cancer cells that are expressing that mutated protein. And I'm really excited that this is going to get us to that point a lot faster than I think we would have had we not had this terrible scourge of COVID. So the second half of the question that you asked me was, is this better than other vaccinations? And I would say yes. I think the mRNA vaccine is going to prove to be safe because it will not get somebody infected, because all we're doing is building one protein that's not an infection. People might feel some symptoms from that, but that's their body is responding to the vaccine. but it's not a virus that's going to make people sick. So I feel like it's safe for my transplant patients. My only concern would be that if it's turning on the immune system, we're actually using immunosuppression to turn off the immune system so that they don't reject their kidney. And I think it will take a little bit of work to find out if there's any risk to the kidneys from immunizing patients. But so far, there's not very good evidence that immunization leads to increases in rejections. And so my suggestion is that patients do get immunized, and we probably should measure them a little more carefully after that to see if they've appropriately responded.
Thank you for that answer, Dr. Reese. Our kidney patients who are age 65 and older and also have comorbidities, are they also recommended to get the vaccination? And have there been any issues or concerns discovered among that population?
Absolutely. So patients who are over 65 and have comorbidities are exactly the patients who should be getting this vaccine, because they're the ones who are most at risk of dying from the COVID virus. So the studies have shown that elderly patients, I don't know that over 65 is all that elderly anymore, but having comorbidities, you're much more likely to die of COVID. And this vaccine has been 100%, almost 100% effective at preventing people from dying. It's 95% effective at stopping people from getting symptomatic, but it's nearly 100% effective at keeping people from getting very sick and dying. So it's exactly the population of patients who are over 65 with comorbidities who should be getting this vaccination.
We have another question from a patient who says their kidney transplant is not functioning well. How will the vaccine impact my transplanted kidney? And should I still receive the vaccine?
Well, one of the things that we recognize is that patients who have kidney disease don't do as well if they get the virus as patients who don't have kidney disease. So that's one of the risk factors. So I would say that, yes, you should absolutely get the vaccine, because, again, you're at higher risk of dying if you get COVID.
What are the long-term effects of the vaccine, if any, on transplanted kidneys?
Well, that's a great question. We don't know is the answer. There haven't been long-term studies yet. We just started giving this vaccine to normal patients. We haven't really tested it in transplant patients yet. So the answer is we don't know. But what we do know is that it's nearly 100% effective at keeping normal people from dying from the coronavirus. So I think it's something that our transplant patients should be taking. The question is, will it be effective if the immune system has been treated in such a way to make it less effective? And if the immune system is less effective because of immunosuppression, will immunosuppressed transplant patients be able to respond appropriately? Maybe they'll need a couple extra shots. Time will tell. But I don't think we have to worry much about it harming the kidney. Other vaccinations have not led to much harm to transplanted organs. And I think my recommendation is that transplant patients receive this, and that thus far the long-term effects on the transplant kidney will be, while unknown, if I was a transplant candidate, I would take the vaccine thinking that the risk was low.
Thank you, Dr. Reese. We have one final question for you. I am scheduled to receive a living donor transplant soon. Should I go ahead and get the first dose of the vaccine, or should I wait until after my surgery?
Well, that's a great question. I think my advice to you is that you should probably get your vaccine. It depends how long before you're going to get your living donor kidney transplant. If it's scheduled, if you think you're going to get the vaccination in the next month or two, I might delay your living donor kidney transplant so that you can be vaccinated before you've become immunosuppressed. Because if you're not immunosuppressed, then your immune system can mount an appropriate immune response, create memory, and give you long-lasting protection against the coronavirus. Whereas In the immediate period after receiving an organ transplant, many transplant centers in the United States use very effective means to stop the immune system from being able to respond to transplanted organs, but that also impairs their ability to respond to vaccinations. So you might be better off to get the vaccination first and then to receive the kidney transplant, or if you get transplanted, to wait a couple of months after the transplant, so the effect of the very strong immunosuppression we use up front has been attenuated or reduced so that your immune system can respond better to the vaccine.
Thank you, Dr. Reese. We appreciate you being available today to answer some of these questions on kidney patients' minds. If you have a question that we did not get to during today's webinar, please reach out to us at info@aakp.org, and we will work with today's speakers to provide a response. We hope you have found this webinar informational. I would like to close with a few slides about additional resources and services that may be of interest to you. If you are not already a member of AAKP, we encourage you to join us. AAKP offers free membership to patients and their family members, as well as living kidney donors. To become a free member, you can join online at aakp.org or by phone. To receive all of the benefits of membership, please be sure to include your email address when signing up. As an AAKP member, you will be notified by email when opportunities arise where your opinions and experiences are needed to help inform innovation, advance care, and make a meaningful impact to improve lives. We encourage you to respond to our flash surveys and other engagement opportunities to help us elevate the patient voice and change the status quo for kidney disease care. You can also select to receive any of our 5 different electronic newsletters and subscribe to our printed magazine, AAKP Renal Life. We also invite you to follow us on our blog and on social media for all the latest news and announcements. AAKP is dedicated to helping patients understand their condition and take control of their healthcare. We are proud to offer a variety of resources for both patients and caregivers. By visiting our website and clicking on the AAKP Store button at the top of the homepage, you can find a variety of educational brochures and online tools to order or download. And you can also order materials over the phone. As AAKP President Richard Knight mentioned earlier, AAKP's events in 2021 will be held virtually. We invite you to join us at the 3rd Annual Global Innovation Summit with George Washington University, our 4th Annual Policy Summit, and our 46th National Patient Meeting, and we encourage you to visit our YouTube channel to watch presentations from all of our past events. The recording of this webinar will be made available on our coronavirus resources page. For more patient resources on COVID-19 and to listen on demand to today's webinar or any of our previous webinars that we've hosted regarding COVID-19, please visit the coronavirus resource page on our website. You can access it from the link shown here or from the red coronavirus information button found on our homepage. We'd again like to thank today's speakers for sharing with us important information and questions to ask your healthcare team when considering the COVID-19 vaccine. Thank you again for joining us. Be informed and stay safe. Welcome to today's Healthline webinar from the American Association of Kidney Patients, titled Who is at Risk? Understanding the Connection between the APOL1 gene and kidney disease and why the Apollo study is important. My name is Erin Kale, and I am Director of Stakeholder Operations for AAKP. I oversee our patient education and grassroots engagement activities, including our Ambassador Initiative, which comprises highly motivated and engaged patients and caregivers around the country and the globe. These individuals have a direct connection to kidney disease and wish to raise awareness and provide support to others navigating the challenges of this chronic disease. AAKP's Healthline webinars fall under our Center for Patient Research and Education. We believe patient and caregiver education is an integral part of treatment and protection of patient lives. We built this center with the latest polling and engagement technologies to ensure that kidney patients take a central role in informing the federal, academic, and private sector research, shaping the next generation of healthcare services, assistance programs, and innovative new treatments. At this time, I'd like to introduce AAKP's president, Richard Knight. Richard is a former in-center hemodialysis patient who received his kidney transplant over 14 years ago. He is actively engaged with the National Institutes of Health and serves on their strategic planning committee. And he is also heavily involved in the policy and stakeholder operations of the Food and Drug Administration and the Centers for Medicare and Medicaid Services. Richard?
Thank you, Erin. AAKP is honored to host this webinar today as a continuing part of our close and decades-long strategic partnership with the National Institutes of Health and the U.S. Department of Health and Human Services. At AAKP, we believe active engagement with the federal government is essential to helping all patients, especially those from communities of color. Our voice as fellow citizens and patients with unique life experiences is sought out and respected by NIH. I would like to thank the fine U.S. civil servants at NIH, including Director Francis Collins, NIDDK Director Griffin Rogers, NIDDK Doctors Robert Starr and Paul Kimmel. We'd like to thank them for their vigorous and substantive efforts to include all minority communities in NIH studies. April, as many of you know, is National Organ Donor Awareness Month. And our session today highlights the need to better understand transplantation and disparities in the African American community. The Apollo study is a groundbreaking study to improve the outcomes for kidney transplant recipients and kidney donors. And AAKP has proudly supported this effort since day one. We are working aggressively on Capitol Hill to increase kidney research funds for NIH. We're also pushing to remove barriers to more living kidney donation and to end transplant disparities. This includes legislation to protect kidney donors from discriminatory insurance practices that penalize living donors, both insured and uninsured, and disrupt their life and disability insurance plans. The presentation today about the APOL1 gene and its prominence in African Americans is a great opportunity for every African American at risk of kidney disease and their families to learn to become part of the study. Folks, quite frankly, our lives are at stake. We need to look out for one another as brothers and sisters, and we need to honor the efforts of those at NIH and researchers across the nation who are trying to save our lives. We invite those of you watching today to become involved with AAKP. Patients, family members, and living donors can join for free, and Erin will provide more information at the end of the presentation. Again, I thank you for joining us today.
Thank you so much, Richard. We have a full schedule for today's webinar, so I'd like to go ahead and introduce all of today's speakers up front so we can get right into their presentations. Dr. Barry Friedman is John H. Felts III Professor and Chief, Section on Nephrology at the Wake Forest School of Medicine. Contact Principal Investigator, Wake Forest School of Medicine, Apollo Scientific Data and Research Center, Coordinating Center, Chief Medical Officer, Health Systems Management Incorporated for the Wake Forest and Emory outpatient dialysis programs. Dr. Friedman was one of the highest rated speakers at AAKP's 2019 inaugural Global Summit, hosted in partnership with the George Washington University School of Medicine and Health Sciences. Dr. Marva Moxie Mims is Chief of the Division of Nephrology at Children's National Health System, Washington, D.C. She was previously at the National Institute of Diabetes and Digestive and Kidney Diseases at the National Institutes of Health in Bethesda, Maryland. There, she served as Deputy Director for Clinical Science in the Division of Kidney, Urologic, and Hematologic Diseases, overseeing a portfolio of research including trials for kidney disease, genitourinary dysfunction in adults and children, and Director of the Pediatric Nephrology Program. In addition, she managed the division's small business grants for kidney research. Two of the studies that she initiated are the ongoing Chronic Kidney Disease in Children study, the largest study of pediatric CKD ever conducted in North America, and the randomized intervention for children with vesicoureteral reflux trial, a large trial undertaken to understand the effectiveness of prophylactic antimicrobial treatment in children with vesicoureteral reflux. I'm so sorry for butchering that. She is currently participating in studies of urinary tract infection in young children, childhood nephrotic syndrome, and focal segmental glomerular sclerosis. She also chairs the Apollo Study Steering Committee. Dr. Moxie Mims' focus at Children's is clinical research to improve the care of children with kidney disease and as a tool to educate trainees. She received her undergraduate degree from McGill University in Montreal, Canada, and her medical degree from Howard University in Washington, D.C. She completed her pediatric residency and clinical pediatric nephrology training at Children's National, followed by a research fellowship at the National Institute of Allergy and Infectious Diseases at the NIH. She is board certified in pediatrics and pediatric nephrology and is a member of several national committees. Dr. Mariela Artigosa Goggins is an associate professor of medicine at the University of Miami Miller School of Medicine and the medical director of the Kidney Pancreas Transplant Program at the Miami Transplant Institute in Miami, Florida. She completed her medical education at Cayetano Heredia University in Lima, Peru, and her medical training at Henry Ford Hospital in Detroit, Michigan, and Georgetown University in Washington, D.C. Dr. Artigosa Goggins has been a practicing transplant nephrologist since 1993. She has been involved in medical education and held many administrative positions, including medical director of the Live Kidney Donor Program and of the Kidney Pancreas Transplant Program. Her focus has been clinical research within the field of transplantation and has a special interest in the long-term follow-up of former African American kidney donors, which has led to several publications. She is currently a co-PI from the University of Miami in the NIH-sponsored study, APOL1 genotypes and long-term kidney transplant outcomes, the Apollo Project. Glenda Roberts is the Director of External Relations and Patient Engagement at UW Kidney Research Institute and the Center for Dialysis Innovation. She is also an active and passionate AAKP ambassador who has contributed to countless AAKP events. While living with kidney disease, Ms. Roberts simultaneously rose through the corporate world, evolving from a software developer to senior business executive, managing multi-million-dollar business units for top caliber corporations, including General Electric and Microsoft. She also served as the executive director of the Seattle Transplant House, a passionate activist for kidney research and people living with kidney diseases. She is involved in myriad national and international transformative healthcare initiatives. Recommended by the American Association of Kidney Patients, Ms. Roberts was a recipient of the 2020 President's Volunteer Service Award. Diagnosed with kidney disease when she was just out of college, Ms. Roberts has firsthand knowledge of the challenges faced by patients and families affected by kidney disease. For 4 decades, she slowed the progression of her kidney disease through diet and exercise. Lori Cooper is a kidney donor from 2003 and a kidney recipient in 2015, as well as a patient member of AAKP. She learned of the Apollo research study through Dr. Mona Doshi and was immediately intrigued. After donating a kidney that did not perform as expected and subsequently developing kidney disease, Ms. Cooper has had endless questions and guilt about the possibilities of what went wrong. Not only has Apollo given her reason to believe it was nothing done improperly by herself or her healthcare team, but it has also given her hope for more successful living donor transplants in the future. Serving on the Apollo research study as part of the Community Advisory Committee is truly a great source of pride for Ms. Cooper. It is life-changing, and some might even say life-saving, for the African American community. The knowledge, connections, and friendships Ms. Cooper has developed working with Apollo are invaluable. To know that there is research in this oftentimes underserved area is so very reaffirming. To be part of that commitment to find answers to the questions that plague kidney disease is truly an honor. We're so happy to have all of you joining us today, and I will go ahead and turn things over to Dr. Friedman.
Well, I want to thank Erin, Richard, and everybody at AAKP for this opportunity. My role is to discuss the role of the APOL1 gene in kidney disease and lead that into the field of transplantation for Dr. Moxie Mims to follow on. I think everyone on this call knows that the rates of kidney disease are much higher in the African American population than any other population. If you compare it to the white population, the Asian American, the Native American population, African Americans face threefold higher risk of end-stage kidney disease than all of the other groups. In fact, that is nearly fully explained by that single APOL1 gene differences between racial and ethnic groups. With the patients that we often see with this disease have long been described as having hypertensive kidney failure or just end-stage kidney disease in the chart. For many years, we didn't know the real cause of kidney disease. And here's a middle-aged African-American woman who's thin, did not have diabetes, didn't have much protein in the urine, and was told her kidney failure was from high blood pressure, when in fact, it's an inherited disease from the APOL1 gene. So this paper was published in the journal Science in 2010. We're celebrating its 10th year discovery of the APOL1 gene. The APOL1 gene is the single most powerful gene associated with a common human disease ever found. It just happens to be a kidney disease. And if you look at that picture, you see the blue parasites swimming in the bloodstream, surrounded by the red blood cells of a patient who's infected with African sleeping sickness. And it turns out that the changes in the APOL1 gene, which initially were found only in sub-Saharan Africa, could kill certain of these parasites. Yet, although they protected people from these forms of African sleeping sickness, which led them to live longer and get transmitted to next generations, one thing that was not known until 2010 was that these protective variants from the parasitic disease caused kidney disease. And people who get one copy of the risk gene from their mother and one from their father, so 2 copies of the risk gene, are at very high risk for getting kidney disease. And those risk variants are virtually limited to the African American population. So we now know that the reason many different kidney diseases have clustered in tightly in many Black families. So for those of you in AAKP who have multiple relatives on dialysis, some of whom may have thought they had high blood pressure induced kidney failure, others with glomerular diseases like FSGS, others with HIV associated nephropathy or COVID-19 associated nephropathy, lupus causing kidney disease or sickle cell disease, we now know that those 2 changes in the APOL1 gene, one from your mother, one from your father, puts you at risk for all of these different diseases. All are non-diabetes associated forms of kidney disease. All are much more common in the African American community. So to put this gene in perspective, 13% of all African Americans have 2 copies of the risk variants, which put them at high risk for kidney disease. That's more than 5 million African Americans. And those individuals probably have a 15 or 20% chance of getting kidney disease. However, most of them, 80 to 85%, will not get kidney disease. Another 39% of all African Americans have one copy of the APOL1 risk variant, which means they're carriers and can transmit that one copy of the risk variant to half of their children. So, if two people with one variant have a child, there's a 25% that child will get two risk variants and be at risk for kidney disease. But these variants are not present in whites, Asians, Hispanics, and they explain why African Americans are at such higher risk of kidney disease. Matter of fact, 70% of all cases of FSGS and HIV nephropathy in the African American population would never occur if it weren't for these variants in the APOL1 gene. That's how powerful they are. And we now know that more than 1 of every 3 African Americans on dialysis, so if you're from Los Angeles, Birmingham, Alabama, Chicago, New York, or North Carolina, and you walk into a dialysis unit, 1 of every 3 African Americans on dialysis has kidney failure from this gene. And it explains much of that excess risk for kidney disease. It explains why African Americans have more and more severe kidney disease when they get lupus compared to other groups. And it also explains why kidneys donated from African Americans fail more quickly after transplantation. And I'm going to show you that data. It's been known for a long time that if someone receives a kidney from an African American deceased donor, the kidneys after transplant don't function for as long as kidneys donated by any other ethnic group. It doesn't matter the race of the recipient of the kidney, it's the donor race. And nobody knew why for years and years. APOL1 changed our understanding. This is a study that we did at Wake Forest very early on, 1 year after discovery of the gene relationship with kidney disease. And I want you to see there's 2 groups there. Those are all African American deceased donor kidney transplants. They're all Black. That the group on top in blue, APOL1 non-risk, had 0 or 1 copies of the risk variants, and their transplants did extremely well over 7 years. But the African American group in red at the bottom had 2 copies of the risk variants in the donated kidney. And look how quickly they failed. This explains the fact that it is not the race of the donor, it's their APOL1 genotype, because all these donors were Black. This study met with tremendous pushback because it was done at Wake Forest, a single center study, and a small number of donors. So we then reached out to other transplant programs, and we studied more than 1,150 deceased donor kidney transplants, whose kidneys came from 624 different African American deceased donors. These were done at 113 different kidney transplant centers. And you can see at 6 years, the group that transplants from donors with 2 risk variants in APOL1 were twice as likely to fail as kidneys donated by African Americans with less than 2 copies. The APOL1 genotype of the donor is determining the outcomes after the transplant, not the race of the donor. This is critically important because the way kidneys are given out for transplantation is there's a risk score to know how risky that donor kidney is to match recipients who are healthy with the best quality kidneys or recipients who are maybe not as healthy with lower quality kidneys, so the kidneys last as long as that recipient needs. And there are 10 factors that are calculated to determine what is the risk. One of the 10 is if you're African American or not. Well, that is totally inappropriate. When we know the actual gene causing the change, we shouldn't use a social construct such as race. So we went back and we did the study in the 1,153 deceased donor kidney transplants, replacing the risk based on African American race with the genotypes which we knew. I'm just going to end here by showing that in the current allocation, the way deceased donor kidneys are given out, this is those 1,153 transplants I just showed you. They have about a 70% risk factor, which means those kidneys were estimated to function worse than more than 70% of all the kidney transplants done in the prior year. You can see if you have 0 or 1 risk variant, it's 71%, or 2 risk variants, 69. They're all about the same, 70% risk, but that's assuming the donor was Black. If we take that out and we insert APOL1 genotype, look at the change. The 71% falls to 53%. That means those kidneys are average. They're perfectly good. They're not high risk. They function, worse than about half of all kidneys transplanted. They're average. But if the donor had 2 risk variants, they're much worse than 70%. They're actually worse than nearly 90% of all kidney transplants. Well, why is that important? Because 87% of the time, those kidneys are much better than currently estimated. It's only 13% of the time that they're high-risk kidneys that are going to fail more quickly. So we can improve the quality score in 87% of donated kidneys, and we think that'll make them less likely to get discarded. They're perfectly good for transplant, and they'll help many people. And my last slide shows, as we've talked about with Lori's story, African-American donors of kidneys are at higher risk for getting kidney disease than any other racial or ethnic group. And it was unclear why Black donors had more kidney disease after donating. And this is a study from Mona Doshi that works with Lori that showed, and Mariella Goggins is a co-author on this study, that showed that after people, African-Americans donated and their genotypes were looked at long-term follow-up, there was higher risk of kidney disease and more severe kidney disease in the donors who had 2 copies of APOL1 than in the low-risk group. So in fact, APOL1 explains a tremendous amount of kidney disease in the Black community and appears to play a very important role in outcomes after transplantation. I'll now turn it over to Dr. Moxie Mims.
Good afternoon, everyone. And I would also like to express my thanks for being a part of this panel. So my job is to tell you more specifically about the Apollo study, with Dr. Friedman having laid the foundation talking about the APOL1 gene. So this is a study sponsored by the National Institutes of Health to look at long-term outcomes in those APOL1 long-term transplantation outcomes. And this network is going to do 3 things. Look at the impact of the risk variants, and I'll go into those in a little bit, in the APOL1 gene on the outcomes for the kidneys that come from donors with recent African ancestry. And I define recent African ancestry at the bottom, meaning self-reported African Americans, Hispanic Blacks, Afro-Caribbeans, and Africans. We're also going to look at the recipients of those kidneys and look at living kidney donors of African American recent ancestry. So that's what we're going to be doing. And this is a little bit more information about how we're going to be doing that. So we're going to prospectively, meaning we're going to look forward at kidneys that are transplanted at the time they're transplanted, and then follow the donors, follow the kidney from deceased and living donors going forward over several years. We're going to look at the transplants themselves, the donors, the recipients, and do genotyping, meaning we're going to look at which APOL1 variants the donor and the recipient carry. And in that way, we'll be able to assess what the effect of those genotypes are on the longevity of the kidneys. We're hoping, as Dr. Friedman pointed out, that the results will help some revision of that formula that he showed you, the KDRI, and replace race with genotype, which would be much more accurate and is actually biologic. We further hope that this will lessen the discard of good quality kidneys. So we're hoping this will inform policies and guidelines also for living donors so that people will know if they're at increased risk if they donate a kidney. So this shows our organizational chart that it's across the entire US. Our hope was to engage all of the transplant programs in the United States. We haven't fully realized that, but we have the majority of the transplant programs. This is funded by 3 of the institutes at the National Institute of Health, the National Institute of Diabetes, Digestive and Kidney Diseases, National Institute of Minority Health and Health Disparities, and the National Institute of Allergy and Infectious Diseases. You can see we have our Community Advisory Council, which you will hear a lot more about shortly, the Executive Committee and Steering Committee. We have an external expert panel that kind of acts as our guiding light and advises the NIH on things that we should be doing. And Wake Forest, you've learned, is our scientific and data research center. This also required partnership with United Network for Organ Sharing, the Association of Organ Procurement Organizations, the American Society for Histocompatibility and Immunogenetics and the genotyping labs, as well as the NIDDK repository. So what's the rationale for this study? It's going to be the first prospective assessment, meaning, like I said, looking forward. The study that Dr. Friedman described was looking back at, here are people that received a kidney, now let's go back and see what their status was. Here we're going to be following them going forward. And this will be the first large study to look at the effect of the donor and recipient. The data that we have from the retrospective studies seem to indicate that it's only the donor genotype that's driving this, but we don't know with absolute certainty that that's the case, so we're going to look at both. And there's just not a lot of data out there on the safety of living donor donation in African Americans based on their APOL1 genotype. So we're looking at the time to kidney transplant failure. That's the primary outcome of this study. And it's going to be based on the number of risk variants. We're going to talk about the variants a little bit more in a second. And we're also going to look at the rate of loss. So not just does the transplant fail, how quickly does it fail? What's the rate of change in the serum creatinine concentration, a marker of kidney function, likely well known to people on this call? And the time to development of proteinuria, since protein in your urine can sometimes be the earliest sign of kidney disease. So let's go back and talk a little bit more about kidney health and look at things here that influence not just kidney health, but your health overall. Healthy diet, exercise, not smoking, limiting your alcohol intake, and getting checkups. Those are things over which we have control. But a big component of health is our genes. And of course, we have zero control over that. We inherit these from our parents, and the differences in some genes can put us at risk for different diseases. In the case of APOL1, it puts you at risk for kidney disease. There are three forms of the APOL1 gene, G0, G1, and G2. And like all genes, you inherit two copies. You have one copy that you inherit from your mother, one copy from your father. The G0 is the most common, and there's no increased risk of kidney disease if you have two G0 genes. The two that can cause an increase in risk of kidney disease are G1 and G2. And as you can see from this graphic, if you have only one of the risk variants, G1 or G2, paired with a G0, you're at no increased risk for kidney disease. You're simply a carrier. You can, however, pass that higher risk gene on to your children. Where we see the increased risk for kidney disease is in people who have two copies of G1, two copies of G2, or one copy each of G1 and G2. It's important to point out, though, that 4 out of 5 people, or 80% of people, even if they have two copies of the higher risk forms, will not get kidney disease. So this is not, there shouldn't be doom and gloom that you find out you've got two risk variants and you think that you're absolutely going to get kidney disease. That is not the case, but it does increase the risk. And there's a lot of other research going on in terms of other things that pair with that cause you to have kidney disease. So the Apollo study is here to try and improve the lives of people that are donating or receiving kidney by trying to learn more about these risk variants and the impact that they may have. So again, we're going to look at the genotype or the variants in the kidney donors and in the kidney recipients to see when these two are melded, is there an increased risk? So this is my final slide. The study is being conducted by kidney doctors and surgeons. The Community Advisory Council all came together and designed this study. The Community Advisory Council, you've probably heard already, but we'll certainly hear a lot more, is a group of kidney donors and recipients or relatives of people who have chronic kidney disease or end-stage kidney disease, and therefore are more likely to have high-risk forms of the APOL1 gene. We really want to point out that people who donate or receive a kidney and participate in this study are going to get the same medical care they would whether or not they were in Apollo. It requires just a small amount of blood and urine. We'll find out what form of the APOL1 gene they have, and we'll see how they do over many years. So we come back to our why for this study, and that's to improve the lives of those who donate or receive a kidney. And I think that is the end for me. I will turn it over to Dr. Goggins.
I thank you also for the opportunity to present. My section will focus on challenges in recruitment. We are currently at 40% of our recruitment goal. We have estimated that we need about 2,600 donor recipient pairs to have enough power to come up with meaningful results. When we started about 2 years ago, we thought we could be done by now in recruiting all these 2,600. However, we are down in the blue dotted line. There is a significant gap between what we expected to recruit and we can have actually consented participants. So there are many challenges that we've encountered that affect the recruitment in the study. I'm going to talk about the one we consider more important, such as the COVID-19 pandemic, lower donation rates among African Americans, along with lower research authorization, recipients declining participation, and lower rate of live kidney donation from African Americans. So the COVID-19 pandemic certainly put a strain in our health system. So many transplant programs put a hold on all transplant activities, in particular live donor transplant, which is actually considered an elective surgery. From the recipient end, many of the participants could not come to the clinic in person. It was switched to telehealth, so less opportunity to explain the study in person and to collect the samples. As you have heard from the Apollo, we need African American deceased and living donors. Historically, there have been lower rate of donation rates among African Americans compared to other ethnic groups. There was a study done that tried to determine the donation rates of eligible deaths. These are people that are deceased, but their organs are eligible to be donated. 77% among whites agree to organ donation, whereas among African Americans, it was much lower at 54%. So it is important to be a registered donor because by law, most of the states will once you're registered, it's not revocable by family members. But it's also important to share your decision, share it with your family members that you're actually a registered donor. So there was an important initiative back in the 90s to try to increase donor registration for organ donation. It was very powerful because it came from an influential person in the community, and the focus was tell your family, share your life, but more important, share your decision that you actually want to be an organ donor. And this led to increased donor registration for organ donation. Another challenge that we have encountered was a high rate of decline in research authorization by the next of kin, which is much higher than we anticipated. It was actually a very unexpected finding in Apollo. If a deceased donor is a registered donor, most states, the law includes research and education, and it's irrevocable. Some states, the law requires family to decide on research independently of organ donation. If the deceased donor is not registered, family must decide on organ donation and research authorization. So it's very important that we share our decision, have the conversation with your family that you register to be an organ donor and also want to participate in research. Within our Apollo project, the decline in research authorization varies by state or region, anywhere from 10% or as high as 50%. So for instance, at the University of Miami, where I practice, 80% of our kidneys come from outside our local region. So we receive deceased donor kidneys from all across the United States. So we looked at the next of kin decline research authorization rate, and we saw that among African Americans, 42% declined research, whereas among white was 16%, among Hispanics was 27%. This translated into 139 transplanted kidneys with missed opportunity for research. So the Apollo study actually enrolls more than half, 56% the recipients are African Americans. So this is the group that will benefit from this study. The recipients decline participation is anywhere from 5 to 15%. Doesn't look like it's too high, but again, this is another lost opportunity to enroll in Apollo and advance our research. So how can you help us? These are some talking points that you can, within your community. The most important is increase donor registration at your local DMV and share your decision. Have the conversation with the family that you actually register to be a donor and you are also allowing research at the time of organ donation. Now that you have heard what APOL1 genetic variants is with a link to kidney disease, spread the word, share your knowledge, and also discuss about the Apollo study. And overall, allow research at the time of organ donation, participate in research in general. And lastly, we need to increase live kidney donation among African Americans. Overall, in the United States, only 10 to 12% of all live donors come from African Americans. That is a low number. This number needs to increase to help a community that is in much need for kidney transplantation. So if you are a healthy individual, please consider becoming a live kidney donor. And I think that's it, and thank you for your attention. Pass it on to Ms. Roberts.
Thank you very much, Mariela, and thank you to AAKP for giving us this opportunity to talk about APOL1. What I want to focus on today is some of the pushback that you might receive when you're talking to people in the community about participating in the Apollo study or in research in general. We know that there is historical distrust, especially in our community, as it relates to research. But it's really more than just the Tuskegee or the Henrietta Lacks study. There are lots of other considerations. One of the things that I'm sure many of you can attest to is that there's a lot of misdiagnosis of disease in our community. So grandma goes to the doctor, they say, oh, you have diabetes. Grandma goes back in 6 months and you discover that she doesn't have diabetes, she has something completely different. And that undermines the trust that we have in our community. And you see a similar issue developing around COVID-19. You hear a lot about hesitancy in the Black community in terms of getting the vaccine. Well, that's true. People are concerned about the efficacy, safety of the new vaccines because they have been developed with new technology that allowed them to be developed faster. But that's not exclusively in the African American community. There's hesitancy in a lot of different communities. I mean, the issue seems to be one of access as much as hesitancy. But the elephant in the room is around structural racism and the distrust that we have with research and the healthcare community for a number of different reasons. One, I'm sure a lot of you have read about the various race-based algorithms that are part of all kinds of medicine, not just kidney disease or nephrology. We know that with a lot of the physicians, there's a lot of implicit bias, racism, and that they have a lot of unfounded beliefs. There was a 2016 study that said that most residents and medical students thought that African Americans had a higher tolerance for pain and that we had thicker skin and so we could tolerate needles better. All of that's untrue. And we know that race is a social construct, not a biological construct. And we've had a lot of people talk about the kidney donor risk index and the fact that race is used as a criteria for assessing the viability of the organs that are transplanted. when in fact, when you consider whether or not you have the APOL1 genotype is far more important than race. So people ask, why is it so important for us to participate in research and organ donation? Well, we know that African Americans are overrepresented in the community of people with kidney disease. If you have kidney disease and the high-risk genotype, you're twice as likely to have kidney failure. That means that you're likely to end up on dialysis. The interesting thing is that while the average person on dialysis passes away after about 5 years, African Americans tend to live substantially longer. And while we live longer on dialysis, our disease progresses much faster regardless of the treatment that we are receiving. So the question is it genetic? So if we develop a better understanding of the causes and the progression of kidney disease, we have the opportunity to improve outcomes. And that's why the Apollo study is so important. Now, when you look at organ donation, I can tell you from my personal experience as a kidney transplant recipient, the quality of my life is substantially better now that I have a kidney transplant and I am no longer on dialysis. In addition to having a better quality of life, it has allowed me to live longer. My transplant has survived for more than 10 years and I'm doing fine, and that's great. The problem is that every day 13 people die on the transplant waiting list because we don't have enough organs. And we've seen that African Americans survive as well as all other ethnic groups once they get a transplant. So when you look at the OPN estimated post-transplant survival calculator, it's that index that determines how likely you are to survive after you get a transplant. We see that race is not a factor and it is not an element that is included in that calculator. So that as we leave Kidney Month, and we move into Organ Donor Month in April, this is a great opportunity for you to reach out to your community and ask people to be an organ donor. And when people say, oh, I'm too old, remind them that May is Older Americans Month, and the oldest donor was 92 years old that contributed to saving somebody's life. So tell grandma she's never too old. We've had several people talk about the Community Advisory Board, and we think that the Community Advisory Council, is especially important in Apollo because our lived experiences align with the study participants' experiences. We know that in kidney research, most researchers are white, but on the CAC, most of us are Black, and we have some affiliation with kidney transplants. And we literally have a seat at the table. I love telling this story. One of the things we know is that when we come to the Apollo Steering Committee, we literally sit around the main table. There's some 60 people that you can't see off behind us, and Dr. Friedman, Dr. Moxie Mims, Dr. Kimmel make a concerted effort to make sure that the CAC members are always at the table so that our voices are heard in all aspects of the study. And I want to give you some examples of how we have been able to impact the Apollo study. Some of these are obvious, but there's one story that I love telling because it shows what influence we have. We know that when people have volunteered to be an organ donor for deceased donors, they typically volunteer to be an organ donor and to participate in research. But the CAC insisted that for deceased donors, that we get the family's approval to use those organs in the Apollo research. So it requires an additional agreement to participate in Apollo. And we thought that was important because of studies like Tuskegee, where people know that egregious things went on with our community members, and people had things happen to them unknowingly. We want to make sure that the community is aware of what we're doing with Apollo, but also how it benefits members of the community. And to show the strength of the CAC, there's an organization called the OSMB. They're an oversight organization for Apollo. And what they do is they look at, how the study is progressing, what some of the outcomes are, look at the burden on the patient. And so we had a return of results policy that said, if the recipients or the participants in the study or their family members want to know whether or not they have the risk genotype, we will tell them. Even though there's nothing that we can do at this point about having the genotype, we thought if they want to know, then we should tell them. So the OSMB said, well, since there's nothing that people can do about it, nobody really wants to know that. And in our official Apollo report, so we send back a report every time we have a steering committee meeting, and in our official Apollo report, the CAC said, if you doubt our ability to assess whether or not it is important for the community to have this information, we encourage you to come to the meeting and hear our patient deliberation and participation. So this is a very powerful organization within the Apollo network. These are some of the members that have attended some of the various steering committee members meetings. Here we have the complete Apollo group, and you'll see that we have different people show up at different times because we know that people living with kidney disease are faced with different challenges and we can't always be available. But you can see here, we show up when we can, and whether we're there in person or we're there at the actual meeting, we are active participants in the communication that goes on. These are members of our final in-person meeting that was in March of 2020. And this is the list of the current 2021 Apollo CAC members. If you have questions, reach out to us. Many of the people that you see listed here are active members of Apollo, and they are active members of AAKP. So ask the community to support Apollo, ask the community to participate in research, and ask the community to be organ donors. Thank you very much.
Hi, I'm Lori Cooper. Thank you for this opportunity. It was 2003, and I was living my life like it was golden in every sense of the word. I had a wonderful career. I traveled often, and I had everything I really wanted. I must admit, I had considered being a kidney donor in the past, but at this stage in my life, it was the furthest thing from my mind. I was registered in my state's registry to become a donor as soon as I became of age. And then one day my mom called and she informed me she was in kidney failure. I didn't hesitate to offer to donate a kidney because I knew firsthand what a difference transplants made to the recipients. The donation will always begin with the need for a kidney and the willingness to donate. Some kidney patients may be reluctant to ask friends and loved ones to donate for a variety of reasons, while others will publicly ask for donations. This choice is highly personal and neither is wrong or right. Unfortunately, some people will never consider transplantation due to fear of rejection or the many myths about donations and becoming a donor. Some people are not presented with the option of kidney donation, which is why it is imperative to educate the community at large about the process and the benefits and the risk of transplantation and donation. Donating a kidney is one of the most unselfish acts of love. At the pre-transplant visit, the healthcare team explains to the donor and recipient the donation process. This is an excellent time for both parties to ask any questions they may have and dispel any myths they may have heard. During the visit, the team will explain the matching process, insurance requirements, and also tell them about the support that's offered by the medical team, and they can address any other outstanding questions or issues that either party will have. The first psychological evaluation is one of many during the process, and all psychological visits are one-on-one. And this meeting is one of the most relevant of the process because the recipient and the donor are asked to consider questions they may not have thought about. It is critical that the donor does not feel pressured or is not coerced into making a donation. Equally important is that both parties are aware of possible mental and emotional changes. On the surface, receiving or donating a kidney seems to be medical and or physical, but in reality, it is a multi-level experience for both parties. One persistent myth is that religious organizations forbid organ donation. In fact, the majority of religions worldwide do not object to organ donation. You want to donate. And at first glance, the test that you're going to be approached to take to be approved for donation will seem daunting. They go well beyond an annual physical, and they're not looking for a particular ailment. They're looking at everything. But when the tests are complete, you can rest assured that if you are approved, you are healthy. Along the way, there's going to be meetings with social workers and more psychological meetings to ensure that you're not having to change your heart and that changes in your life because of your decision to donate remain manageable. Congratulations, you've been cleared to donate. This is a huge deal. By now, the full impact of your donation has hit, and you realize more than ever the positive, life-changing effect your donation will provide. There are several reasons a willing donor cannot donate. Unfortunately, being a close relative does not guarantee a match. But thanks to medical advancements in anti-rejection drugs, doctors are able to match more donors and recipients than in the past. The utilization of paired donation has also helped to ensure better matches. Okay, so now everything you've gone through has led to this moment. Anxiety and nerves are at an all-time high for everybody involved. It's important to remember if a family member is donating to a family member, there are two relatives going through major surgery, which can be stressful on the family members waiting on their loved ones to come out of surgery. In my case, my mother and I were in a double-wide prep room. She and my sister were able to be by my side. We had prayer before they wheeled me away. And I found this to be very comforting as this was my first surgery. When I came to, my mother was in surgery and I was offered a cleared liquid diet. My surgery was at 7 a.m. and I was released the next morning. The next morning when breakfast was served, I was actually sitting in my chair. I was able to go see my mother in the surgical ICU before I left the hospital. Despite my family pleas, I went back to the hospital the next day. I can't say that I wasn't in any pain, but it wasn't enough to stop me from going to check on my mother. I was off work on a paid medical for 8 weeks, and the hardest part of that was not being able to drive for 6 of the 8 weeks that I was off. But I had absolutely no complications from surgery whatsoever. One myth that I thought before donation was that I would need to follow a special diet, watch my fluid intake. This is not true. Of course, you're always encouraged to follow a healthy diet. I was also afraid of weight gain and water retention after surgery. I was assured this would not be the case, but I was skeptical. I actually lost a considerable amount of weight after the surgery, which is part of the body's natural healing and adjustment to one kidney. I gained the weight back and leveled off at my pre-surgery weight. I did not gain any weight due to the surgery. As a matter of fact, I lost weight when I watched my diet and exercise, and I gained weight when my lifestyle encouraged gains. The one thing that really worried me in the beginning was, would I be able to go back to my enjoyable life? Would I be able to travel? Would my energy be depleted? Could I still enjoy the rich foods that I loved? And could I still have a good stiff drink whenever I wanted? None of those changes are mandatory, but a healthy lifestyle is always encouraged. After getting my clean bill of health, I decided I wanted to change my ways and live a healthier lifestyle. My lifestyle wasn't horrible, but I knew I could make improvements. So in the end, not only did I help my mother, but I took better control of my health. I realized health is wealth, and I'm so glad I did, because I will always believe it led to a better outcome when I had a serious health issue years later. My mother's transplant was a success. I went back to living my life, doing all the things I had previously enjoyed. I was definitely more health conscious. I exercised more. I drank less pop and alcohol, added more water. But like most people, I would wane from those high set goals and come back to them. Donors are closely monitored for their medical team for 2 years. I volunteered for a research study that required close monitoring for 5 years. During that time, my kidney function was normal and I was given a clean bill of health. My kidney journey would not be complete without Apollo. Most people think, oh, I'm not diabetic, I don't have high blood pressure, nobody in my family has been affected by kidney disease, I really don't need to worry about that one. Well, Apollo seeks to understand why so many people of African descent without the precursors for kidney disease suffer the fate of kidney disease. If the researchers can get closer to knowing why some people are disproportionately affected by kidney disease, then at the very least, better treatments can be developed while a cure is being sought. After some unforeseen health issues, I was contacted by an Apollo researcher. Through Apollo, I've had the opportunity not only to learn more about kidney disease, but to educate and encourage members of my community to take kidney health seriously. The research being conducted by Apollo Research Study is groundbreaking and offers hope for countless of people at risk for kidney disease. For me, Apollo offered a beacon of hope in one of the darkest hours of my journey. I would like to send my heartfelt thanks to Apollo and everyone involved for the work that they do, and especially for including me, because it is a major part of my lifelong dream to live, laugh, love, leave a legacy. Donating a kidney is a major decision, one that will hopefully have a positive effect on you for the rest of your life. I encourage you, if the situation presents itself, to research and investigate the possibilities or sign up for your state's registry to become an organ donor. Thank you for allowing me this time to speak with you. You are appreciated.
Thank you so much to all of our wonderful speakers. We do have some time for questions. I'm going to go ahead and unmute all of our presenters here and start with some of the questions that we've received. All right, question number 1. Has anyone assessed how often physicians are asking Black and/or African Americans if they are interested in genetic testing?
I can start on this and just tell you that there are medications directed against this gene that are being developed and tested. And we think as those studies finding a cure or a treatment for APOL1 kidney disease are increase in size and are done around the country, more testing will be ordered. The issue is many physicians don't want to order this test because there's really no specific therapy for APOL1 nephropathy that they can give today. They don't want to cause patients concern, worry if they have a high-risk genotype. Could they lose insurance or other privileges? Could it count against them in healthcare costs, which these are all prohibited from happening by law, but how realistic that is, we don't know. So I think more physicians will order testing as treatments become available, and Apollo is studying this in the transplant field because that's the fastest way to action for using this gene. But I'll be happy to turn it over to other panelists for their thoughts.
I would echo that, Barry. I think that's been my experience. As a pediatric nephrologist, this comes up with kids as well, and there's always that question of, well, what am I going to do with that information, even when it is raised as an option? And I think more people will be willing to have the testing done when there are therapeutics available.
Thank you. We have another question about the testing. Are potential donors currently being screened for the APOL1 gene?
Mariella, do you want to take that one?
Sure. So at this point, the guidelines do not require that potential live donors for African American live donors must be tested. It's all individual. Every transplant program makes their own decision if to be tested or not. and how to guide or counsel the patients after they get the results back. I could tell you from my own experience, like in my transplant center, we do test everybody that comes forward that it has African ancestry, the APOL1 genetic testing, and we use that as a guideline to determine if they should be or should not be live donors. Some programs do the same. Most of the transplant programs analyze these results in the context of, for instance, the age of the donor. They probably would not take a young donor that has the APOL1 high-risk variants, but they may take an older donor that has not exhibited any problems with kidney disease, such as protein in the urine or decreased renal function and so on. So it really varies. There is no guidelines, clear set guidelines that every transplant program is following at this point.
And I think the very important aspect of Apollo is we want every program to at least inform potential living donor candidates that are African ancestry about the APOL1 gene, about the fact that testing is available, so that even if the program doesn't order it, the individual can make that decision on their own about whether to speak to the doctor about ordering it. That education is critical and something Apollo and the Community Advisory Council has really pushed for. So it's already changing practice in the nation.
Great. A couple of additional questions that came in. Is it possible that low living donation rates among African Americans is partially due to the knowledge that they are at higher risk for perhaps needing a kidney in the future?
Just quickly say, I think it's possible that that's a contributor, as is the fact that African Americans have more kidney disease after donation than whites and others. But my feeling is, if there's a genetic test that pinpoints which African Americans are at high risk, and those people are tested and maybe they don't donate, the rest of the people, 87% of the population doesn't have a high risk. I actually think this testing will increase donation. This shouldn't be different than any other gene test we have for donation. If you come from a family with polycystic kidney disease and that donor is tested and has the risk variant of the PKD1 gene, they shouldn't donate. But if you don't have that risk variant, it's okay to donate. Well, it's probably very much the same for APOL1. And 87% of the population doesn't have a risk variant. They may feel much more comfortable donating once they're tested. So I actually think testing for this gene may increase live donation.
Certainly, family history of kidney disease is what holds a lot of African Americans to come forward to be donors, because they are fear of it could happen to me as well. But as Lori explained, the donation process is very thorough, and they look at a lot of different things to make sure that the donor is absolutely healthy at the time of donation. So family history is a factor, but it's not the only factor that could determine a person is a candidate to be a live donor or not.
And I think that's a very good question, because it points out why it was so important for us to come to you and talk about the Apollo study, so that you can start to spread the word in your community about the Apollo study and what we are finding when we look at the APOL1 gene.
Thank you. Lori, do you have anything to add to that question?
I just want to say that the process for donation, when I was done with that, I knew I was healthy. I actually found out I was healthier than I thought I was, and I felt good going into the donations. The issues that I had nothing to do with the donation itself.
Great. Another question is, for African Americans whose kidneys failed as a result of, say, FSGS, does their risk of reoccurrence or rate of failure decrease if they receive a kidney from a donor with no risk variants?
I'll just say that the people who have FSGS, who get recurrent FSGS after receiving a kidney transplant, have a different type of FSGS. They have disease due to a circulating factor in the blood. If you have the APOL1 gene associated type of FSGS, that is not felt to recur after transplant. So getting a donor kidney should cure this genetic disease as long as the donated kidney doesn't have a high-risk genotype. This is a different form of FSGS than the kind people think about that comes back quickly after transplant.
Right. It falls into the category like a lot that we see in children as well. If it's genetic, has a very low chance of recurring.
Great, thank you. So what resources would you recommend to a transplant program that is performing the APOL1 testing and living donor evaluations? This person says that they complete the test to help discuss risks with the donor, but because there is not a clear consensus that the donor with 2 variants should or should not donate, our program has decided they probably should not donate. Should we be referring donors to genetic counseling? We are participating in an Apollo study as a non-engaged center.
Marva, do you want to take that?
So I would like to echo some of what Mariella stated earlier. I think it's a very personal decision. We've certainly had people tell us that even if they had 2 risk variants, and even if they knew for certain that they might need a kidney down the road, they would still donate. We certainly see that, again, in my role as a pediatric nephrologist. You know, parents are often, you know, just take it. I want to give it to my child. Now, if you're talking about it from the perspective of the impact on the donor, that's one thing. If you're talking about it in terms of the impact on the recipient and whether or not that kidney is going to last a long time, again, I think it depends on the recipient's circumstance. If it's somebody that's on dialysis and is not doing well on dialysis, even if this kidney will buy them not 20 years, if it'll get them 5, 6, 7, 8 years of better quality of life, something that Glenda talked about earlier, then I think, again, it comes down to this very personal decision for the donor and the recipient, looking at the risk to the donor if they've got 2 risk variants and their potential for developing kidney disease down the road, and the recipient, what kind of situation are they in? How desperate in need are they for a kidney at this point? And maybe even if the kidney doesn't last them a lifetime, it may still improve their quality of life. But I think that's such a personal decision. I'm not sure that I'm in a position to say absolutely you shouldn't or you should.
Yeah, that's very important what you said, Marva. My experience is similar. We take case by case and we sit with the donors and we explain. Counseling is important. A lot has to do with the age of the donor. Certainly a younger donor we will not encourage to donate. Older donor that is absolutely healthy, that does not have any evidence of kidney disease, will probably advise towards donation. As we heard in the presentation, only 1 out of 5 carriers of the 2 risk alleles will develop kidney disease. So that's only 20%. But more important, as Lori said, when you are a live donor, you have to follow a good health habits. It doesn't matter if you have the carrier or not. If you don't follow the health habits, if you develop overweight, diabetes, and so on, or you develop hypertension, you don't take care of yourself, you may develop kidney disease regardless of. So it is very important, and after live donation, you follow the good health habits, that maintaining your weight, in diet and so on. Development of hypertension we have also seen at a higher rate in African American donors, more so than Caucasian donors. So if patients develop hypertension, it's crucial that they follow with their PCPs, that they control the hypertension the best they can with medications. So health habits is an important part of the decision making.
Thank you. We have a question from a kidney transplant recipient, and she runs a great support group. Her question is, how do we help the transplant centers to accept more African Americans for transplant? The requirements are so high that most do not qualify because of insurance or funds. Is that something somebody can respond to?
The question is related to recipients that don't qualify for being a kidney transplant recipient or a kidney transplant donor. That will I emphasize. As a kidney transplant recipients, you know, every program has their own protocols to get patients on the list. Insurance is most of the time not an issue because ESRD, they are insured by Medicare. And the workup is pretty much similar for everybody. There may be other medical conditions that the recipients don't qualify to be kidney transplant recipients, but for the most part, they do qualify. And I have to attest that it's not a difficult process to get on the list. It's a lot to fear of coming and being worked up for to get on the list. But every program is different, but they should also inquire.
Hopefully we'll see an improvement now that we have the immunosuppression bill that has been passed. It used to be that after 3 years, your medications were no longer covered by Medicare. So if you didn't have, and they're very expensive medications. So if you didn't have some kind of insurance coverage, the likelihood of your transplant surviving for the long term was lessened because people wouldn't take the amount of medication that they need. That's no longer a problem for us. And so I hope that we'll see more people get on the transplant list because now they are assured of being able to get their medications.
Thank you. Another question came in asking about any data on the prevalence of the APOL1 gene among the people from the Caribbean.
Yeah, well, the risk variant frequencies are less clear in the Caribbean, but they're certainly present. Anybody who came from sub-Saharan Africa, often involved in the transatlantic slave trade, so Afro-Caribbeans, African Americans, many folks in Brazil who have African ancestry, but the frequency of the high-risk genotype in South America, Brazil is lower than African Americans in the United States because there's more mixture from other populations. But no, they're certainly present in Afro-Caribbeans, and it probably is varied based on which Caribbean country we're talking about. And of course, it's very high in sub-Saharan Africa, the highest in the world.
Thank you all so much for these wonderful questions. Due to time, we're going to have to wrap things up here, but if you have a question that we did not get to, please email us at info@aakp.org. We'll work to provide a response for you with help from today's wonderful presenters. I have a few closing slides to go through. If you're not already a member of AAKP, we encourage you to join us. AAKP offers free membership to patients and their family members, as well as living kidney donors. To become a free member, you can join online on our website at aakp.org/join, or you can call us by phone at 1-800-749-2257. To receive all the benefits of membership, please be sure to include your email address when signing up. As an AAKP member, you will be notified by email when opportunities arise where your opinions and experiences are needed to help inform innovation, advance care, and make a meaningful impact to improve lives. We encourage you to respond to our flash surveys and other engagement opportunities to help us elevate the patient voice and change the status quo for kidney disease care. You can also select to receive any of our 5 different electronic newsletters and subscribe to our printed magazine, AAKP Renal Life. We also invite you to follow us on our blog and social media for all the latest news and announcements. AAKP is dedicated to helping patients understand their condition and take control of their health care. We are proud to offer a variety of resources for both patients and caregivers. We also offer numerous kidney-friendly recipes with details on the nutritional content and which stage of kidney disease these recipes are good for. By visiting our website and clicking on the AAKP store button at the top of the homepage, you can find a variety of brochures and online tools that you can order or download. You can also order materials by phone. We have dedicated web pages for a number of related health conditions that impact individuals with kidney disease. And we do have a web page designated to information about the APOL1 gene. AAKP's events in 2021 will once again be held virtually with no registration fees. We invite you to join us at the 3rd Annual Global Innovation Summit with George Washington University, taking place May 13th and 14th. Our 4th Annual Policy Summit, taking place June 17th. And our 46th Annual National Patient Meeting, September 24th and 25th. We also encourage you to visit our YouTube channel to watch presentations from our past events. AAKP has developed a webpage with a plethora of resources on COVID-19, including information from our federal partners like CDC and NIH. We encourage you to bookmark this page for up-to-date information from credible sources. We would again like to thank today's speakers for sharing with us this important information about the APOL1 gene and how you can get involved in the Apollo study. We also want to thank our sponsor, Vertex, for allowing us to provide this educational webinar today. The recording of this webinar will be made available on our Healthline webpage in the next couple of days. Thank you again to everyone, and I invite our speakers to say any last words that they have.
Thanks for having us, and spread the word about kidney donation and participating in research.
Thank you all so much. Be informed and stay safe. Thank you for joining.